Okay, dear students, am I audible? Please reply. Okay, so I'm audible and everything is fine. So yes, Osama, good morning dear, good morning Aswin. So good morning to all. So I would like to brief you firstly, then I will like to start with the session. The brief of the session is that we will have an upper limb session today because already we have covered the lower limb session. And in the upper limb session, the most important topics are the brachial plexus and the nerves and few anatomical reasons which is highly important for you to understand. So we will one by one I will complete each part, and also so today I am going in a reverse way. Firstly, I will start with the axilla, the axillary artery, the axillary lymph nodes, the scapular anastomosis and few important topics. Then I will go to the brachial plexus topic and then the nerves. In between there are MCQs to be solved which is related to the topic. Also many small topics are there to be covered up, like anatomical snuffbox, the carpal tunnel syndrome, the media. So three important nerves will be done in detail, that is median, radial and ulnar nerve. Also the muscles will be covered up. Also the flexor retinaculum, extensor retinaculum, carpal tunnel, the palmar spaces of the hand, anatomical snuffbox, so scapular anastomosis, all will be covered up. So everything is fine. Yes, good morning to all, and we will exactly start with the topic today, that is axilla. So let's start. So if I talk about the axilla, it's a truncated area, which is lying in between the lateral aspect of the chest and that of the upper arm. So exactly you can see it is having it is a six-sided structure, pyramidal structures. I'm slightly enlarging it. So when I'm enlarging it, why I am enlarging it? So that you have an idea of all the walls. So we have to know the structures forming all the important areas. So this is the apex part. So I have used yellow color for the apex part, or we can use a different color. Yeah, so this is the apex part. And lower down we have got, so I am using, this is the base part. This is the base. So this is the base, this is the apex. Then we have got also, this is the lateral wall. This is the medial wall, and posterior and anterior wall is coinciding. So we will have the posterior wall and we will have the anterior wall. So this is the anterior and posterior. The anterior wall will lie anteriorly and the posterior wall will lie posteriorly, overlap. So what you can see that it's a six-sided pyramidal structure, and for the understanding of the topic, it is important that we should know how and which muscles or which structures are forming these walls. And in the topic of axilla, we have to know the contents which is residing in the axilla, and we will have the detailed discussion of axillary artery and axillary lymph node and axillary vein. So let's start with the topic. So yes, good morning Aradhana, good morning Shah, Fazal, good morning Osama, Abhishek, Sudhanshu Sarma. Okay, so let's start. So exactly this is one of the image, which is the image of Gray's Anatomy, where I want you to give an idea of the six-sided wall pyramidal structure, that is the axilla. So here if you will see, you can see the cut part of, this is the muscle which has been dissected out. So can I use another color? Yeah. So this is the cut part of the muscle which has been shown to you. This is pectoralis major muscle. Which muscle is this? This is the pectoralis major muscle. So this is the cut part of pectoralis major muscle. Now it is okay. So this is forming the anterior wall, and in after this, if you go more deeper, you can see the pectoralis minor muscle has been shown. So pectoralis minor muscle, which is the key muscle of the axillary region, and you can clearly see it is attached to the coracoid process. So that means we have got three important structures which is forming the anterior wall of the axilla: the pectoralis major, the pectoralis minor, and the subclavius. Now here on the posterior aspect, if we move, yes, Shah Fazal, good morning from Pakistan. Yeah, dear. Now, if we go more posterior aspect, we will have the structures which is forming the posterior wall. So in the posterior wall, we have got the subscapularis muscle. So I would like to shade it. So I'm using a different color. So this is the subscapularis muscle. Lower to it, this is the subscapularis muscle. Lower to it, we have got the other two muscles, that is latissimus dorsi and the teres major muscle. So these muscles are forming the posterior wall. Now, Also, we can appreciate in this image the serratus anterior muscle digitation. So actually this serratus anterior muscle digitation is forming, see here. So this serratus anterior muscle digitation is forming the medial wall, and this structure which you have seen here, this is forming the posterior wall. So, and also on the lateral aspect, if we move more laterally, you can see the coracobrachialis and that of biceps brachii muscle. This is forming the lateral wall. So in short, and the apex, if I talk about the apex, it is directed in upward direction and base is lying downward. So base is actually formed by axillary fascia and the apex is directed from the axilla to the cervical region. So that is the reason we also term apex as the cervico-axillary canal. So we will talk about the contents. Before that, I just want everybody to have an idea of boundaries of the axilla. So let's talk about boundaries of axilla. So the first thing which is very, very important for you, that what all things we have to know about the boundaries. We have to know what is apex. We have to know what is base. We have to know what is anterior wall. How is the anterior wall formed? We have to know how is the posterior wall formed. We have to know how is the medial wall formed. You have to know the lateral wall. So that means we have to know the details of all these walls and how the structures are related to these walls and what are the contents lying inside. So let's talk one by one. So we will start with this topic. So let's start with the first topic. Apex. So when we are talking about the apex, the other name of apex is cervico-axillary canal. Cervico-axillary canal. The other name of apex is cervico-axillary canal. Now, cervico-axillary canal is a passage. It is acting as a passage for the structures in the axilla. So it is forming a passage for the structures communicating in the neck and the axillary region, and it is directed upwards and medially. It is directed, the apex is directed in upwards and medial direction. And it is important to know that you should be aware of the boundaries of the apex of the axilla. So if I am talking of the boundaries of the apex of axilla in your own body, you can understand. We have got an anterior aspect, the clavicle. So we can have, it's a space which is bounded by medially by the outer aspect of the rib. So in the medial aspect, there will be the first rib, outer aspect of the first rib. Posteriorly, we will have the scapula. And if I talk about important structures which is forming the front. So clavicle is lying in the front or anteriorly. Posteriorly is the scapula, and we will have the outer border of the first rib which is forming the medial border. And this is the boundary of apex, which is also called as cervico-axillary canal. It forms a communication between the axillary region and the neck region. So write down boundaries in front, boundaries so in front it is bounded by clavicle, behind it is bounded by scapula, and medially it is bounded by outer border of first rib. Outer border of first rib. Outer border of first rib. Hence, it is termed as cervico-axillary canal. Now, talking about the other aspect, for example, we have done with the apex. The next important thing which you have to understand is the base. So, let's talk about the base. So, if I talk about the base is also termed as the floor of axilla. And if I talk about the base, it is formed by the lower end of the axilla. It is directed in downward direction and is formed by the axillary fascia. So, it is directed in downward direction. It is just formed by the axillary fascia. Now, let's talk about all the walls. So, anterior wall. So, if I talk about anterior wall, the anterior wall is formed by following structure. It is formed by pectoralis major muscle. It is formed by pectoralis major muscle. It is formed by pectoralis minor and by subclavius muscle Okay, now posterior wall. Now talking about posterior wall. So when we are talking about the posterior wall, and we have to know the important structures forming the posterior. So it is formed by subscapularis muscle. It is formed by subscapularis muscle. It is formed by, so above there is subscapularis muscle, lower down there will be latissimus dorsi muscle, and that of latissimus dorsi muscle is lying there, and there is teres major muscle, sorry, this is latissimus dorsi, and we have got teres major muscle. I want my dear students to write all these by yourself. Actually, what happens if you are not writing it, you will not be able to correlate. Any possibility of receiving PDF, ma'am? If so, from where it is available? So you can just communicate with the channel and they will provide you with the PDF. Okay. But my dear Muhammad and everyone, please write the notes by yourself. Okay. Yes. Okay. So now talking about, so we will try to give you the PDF. I think after the PDF will be sent to the channel, and from that from the whole academic groups you can have the PDF notes. There will be there is a provision of providing PDF also. Now posterior wall. Now talking about the medial wall. So if I am talking on the medial wall is formed by upper 4-5 ribs. It is formed by upper 4-5 ribs and corresponding intercostal muscles overlapped by serratus anterior muscle. Okay, so we have done with this. Now coming to the lateral wall. The lateral wall is formed by tendon of biceps brachii and bicipital groove of humerus bone, which also contains, so other muscle which is related in the lateral wall is, coracobrachialis muscle, and by coracobrachialis muscle and short head of biceps brachii. So in short, we have finished with the with whole of the boundaries and all. We have finished with this boundaries of the axilla and all. Now the next thing is to know about the content of the axilla. So important contents in the axilla, and few of the contents I will like to elaborate it. Before that, I just want everybody to see this transverse section of the axilla. So when you are seeing the transverse section of the axilla, it becomes easy for you to correlate. It becomes easy for you to correlate with the contents lying inside the axilla. So if I am talking about the contents which is lying inside the axilla, it is having following structure. So it is having axillary vein, it is having axillary artery, it is having cords of brachial plexus which is arranged around the second part of axillary artery. It is also having the long thoracic nerve as the contents. It is having the axillary fat, axillary lymph node, and also intercostobrachial nerve. So these all, if I am talking about long thoracic nerve, it is giving innervation to serratus anterior muscle. So basically in this image, you can have an idea of the important structures which is forming the boundaries of this important axillary region. So if you will see this image, you can see this is the subscapularis muscle. And as I told you, subscapularis muscle along with the teres major and the latissimus dorsi muscle. So this structure is all forming, Good morning, Shakti. Yeah, good morning. So these structures are all forming the posterior wall. Posterior wall. Okay, done. Now, if I am talking about anterior aspect, anteriorly we have got pectoralis minor and we have got pectoralis major. So anteriorly we have got pectoralis minor and pectoralis major muscle. So this is anterior. We have got short head of biceps brachii in coracobrachialis along with long head of biceps brachii in the bicipital group. All these structure is forming lateral wall. And medially we have got serratus anterior muscle. Medially, if you will see, this is the serratus anterior muscle. So medial wall is formed by serratus anterior muscle. And the contents which is lying inside is the brachial plexus. So the contents which is lying inside is the brachial plexus along with axillary vein and axillary artery. Along with axillary vein, axillary artery. So got it? So now I just want everybody, we have already seen the boundaries, and we are now we have to know about the contents which is lying inside. So let's talk about the contents which is lying inside in the axilla. So let's talk about that. So please write on the list. The contents of the axilla are following. It contains axillary artery and its branches, so axillary artery and its branches will be a separate topic which I will just tell you about the details. So that will be fine for you. Axillary vein and its tributaries. Vein and its tributaries. Cords of brachial plexus. Cords of brachial plexus. Then we have got axillary lymph node. Axillary lymph nodes. Then we have got fibrofatty tissue. And other than that, we have got long thoracic nerve. We have got long thoracic nerve and intercostobrachial nerve and intercostobrachial nerve and intercostobrachial nerve. Intercostobrachial nerve. Okay. So basically these are the structures which is forming the content of the axilla. Okay. Now the next topic is the axillary artery and its parts and branches. So the next topic which I want everybody to know is the axillary artery, its part. Hi ma'am, I have recently completed MBBS. Your lecture helped me a lot and I am grateful to you. I wanted to talk to you. Good morning. Yeah, good morning dear Ankit Kumar. Good morning to everyone. And I'm so glad that my lectures has helped you. So yes, we will have a conversation. Don't worry. Okay, let's focus on the topic now. Okay, axillary artery and its part. So axillary artery and parts. If I'm talking about axillary artery, I would like to explain the axillary artery, how it is formed and what are the important parts. So what you can see, there is a landmark here which is shown. So everyone, please concentrate on this. What is this structure? This structure is the first rib. So this structure is the first rib. So this structure is the first rib which you are seeing. Okay, so this is the first rib and it's still cartilage. So I just want to everybody to understand that beyond the level of first rib, so till the level of first rib, it is subclavian artery. That means this part of the artery, that means this artery which you are seeing, this will be subclavian artery. This will be subclavian artery. And beyond the level of first rib, this part of the artery which you are seeing, this whole part of the artery is the axillary artery. Okay, now here is one muscle which is termed as, this is pectoralis minor muscle attached to the coracoid process. So this muscle is pectoralis minor. So I just want everybody to understand that this bony structure which you are seeing is the coracoid process. This bony structure which you are seeing is the coracoid process. What is it? This is the coracoid process. This bony structure is the coracoid process. This bony structure is the, okay, what is this? This is coracoid process. What is this? This is the pectoralis minor muscle. This muscle is pectoralis minor muscle. Now, why is the pectoralis minor muscle termed as key muscle of the axilla? Because this is a landmark which will divide the entire axillary artery into three parts. So, till the level of pectoralis minor upper border, this is the first part of axillary artery. This is the first part of axillary artery, and the part of axillary artery, so I just want the part of axillary artery here, there will be also the axillary artery, and the parts of axillary artery which is lying deep to that of pectoralis minor. This is the second part. This is which part? This will be the second part of axillary artery. And beyond the level of this, so beyond the level of the pectoralis minor, this is exactly termed as the third part. So this will be third part of axillary artery. This will be the third part of axillary artery. Now, here this muscle is teres major muscle. Which muscle is this? This is the teres major muscle. This is teres major muscle. So, till the level of teres major muscle, that is till the level of the lower border of teres major muscle. So, exactly till the level of the lower border of teres major muscle. So, yes, it's important to note down. So, this is the teres major muscle. So, till the level of, if you want, I can use another color. So, from here to here, this is the part of, third part of axillary artery. So, please let me know, have you understood the concept of first part, second part and third part? First part of axillary artery is above pectoralis minor. So, the part of axillary artery extending from first rib till the upper border of pectoralis minor is the first part of axillary artery. The part of axillary artery lying posterior to pectoralis minor is the second part. The part of axillary artery beyond pectoralis minor till the level of lower border of teres major is the third part, and beyond teres major muscle, axillary artery changes its name to brachial artery. Will change its name to brachial artery. Now for today, now in this topic, I will firstly tell you about the branches of axillary artery. So let me just yes dear. Okay, now please let me know, dear students, have you got any doubt till now? Can we proceed further talking about the parts of axillary artery? Please let me know. So we have done with the axillary artery parts and we are knowing how it is divided into three parts. The next important thing is to know the individual branches of each part. Okay, individual branches of each part. Done? Now. So axillary artery, so I will firstly describe and then tell you. So if you want, you can just write axillary artery is continuation of subclavian artery. It's a continuation of subclavian artery beyond the level of first rib, beyond the level of first rib. So it's a continuation of subclavian artery beyond the level of first rib. Okay, beyond the level of first rib. So it's a continuation of subclavian artery beyond the level of first rib. Got it? Axillary artery is divided into three parts. Axillary artery is divided into three parts. Axillary artery is divided into three parts. First part of axillary artery, first part of axillary artery So if I am talking about first part of axillary artery, it is first part of axillary artery is above pectoralis minor muscle, is above the pectoralis minor muscle. Second part of axillary artery, is posterior to pectoralis minor muscle. Third part of axillary artery is beyond the level of pectoralis minor muscle. So in short, we are knowing the whole extent of the pectoralis minor muscle. So in short, we are knowing all the how we are knowing the details of how it is divided in three parts, how it is divided into the first part, how it is divided into the second part, and how it is divided into the third part. Okay. Okay, okay, dear Ankit. So yes, Ankit, you are in which college? Please let me know. Ankit, you are in which college? You are studying in which college? So we have done with the details of axillary artery. Now the next topic is, so after that, I want everybody to concentrate on this image. So when you are seeing this image, you can understand the important branches. So why I am telling you to concentrate on this image? Because in this image, we will understand the branches of axillary artery. Important branches of axillary artery. Is it okay? So now here we are seeing this is the subscapular artery. This is which artery? This is the subscapular artery. Okay. Now, if we are talking of the subscapular artery, and this is the landmark is first rib. So, what I told you, beyond above the level of first rib and its costal cartilage, the artery is named as subclavian artery, but beyond that level, it is the axillary artery. Now, here this is the first part, this is the second part, and this is the third part of axillary artery. Now, to remember the different, so to know the different aspect of the part, so here we have got the second part, this is the first part, and this is the third part. Yeah, don't worry, Rakesh Yadav and everyone. We will have consequently many sessions and you will get all the important topics covered up. Okay, now if I am talking on the part, if I am talking on this the first part, this is the second part, this is the third part. Now it is important to know the branches of individual parts. So let's talk about the branches. So concentrating on the first part, it is giving just one artery and the name of that artery. Actually, total 6 direct arteries are. So the name of artery is the superior or supreme thoracic artery. So superior or supreme thoracic artery is the branch from the first part of axillary artery, and the branches from the second part of axillary artery, we have got the lateral thoracic artery as the branch from the second part. We have got thoracoacromial artery as the branch from the third part. And again, the thoracoacromial artery will give following small branches. It will give, so actually it gives 4 more branches. The thoracoacromial artery will give 4 more branches, and that is appearing as a sprouting of flower. So we will have 4 branches: pectoral, clavicular, deltoid and acromial, which are sprouting like a flower and going in 4 directions. From the third part, we have got 3 direct branches. So it is posterior circumflex and anterior circumflex humeral artery and the subscapular artery. Subscapular artery is the largest branch of the axillary artery, posterior circumflex and anterior circumflex. So total we have got 6 branches. Now further, the subscapular artery will divide into 2 more branches. One is circumflex scapular and another is thoracodorsal artery. So that means the axillary artery is giving 6 direct branches, and subsequent branches is also named here. So please write down branches of axillary artery. Branches of axillary artery. So branches from the first part. Now I would like firstly to talk about the branches from the first part. So if I am talking about the branches from the first part, it gives just one branch. What is the name? The name is superior thoracic artery. The name is superior thoracic artery. In the other name of superior thoracic artery, it is also termed as superior thoracic artery, is also termed as supreme thoracic artery. What is the other name? It is also termed as superior thoracic artery. It is also termed as superior or supreme thoracic artery. So it's okay. I don't think it's so difficult part, so that you have to know. Let's talk about the second part. If I'm talking about the second part of axillary artery, it will be giving subsequently 2 direct branches. And what are they? 2 direct branches are thoracoacromial artery and lateral thoracic artery. So the second branch is lateral thoracic artery. Its further branches will also give blood supply to the mammary gland. And the third branch is thoracoacromial artery, which is also called acromiothoracic artery. Both are similar. And thoracoacromial artery or acromiothoracic artery will further sprout in 4 directions. It will be further sprouting in 4 directions. It will further sprouting in 4 directions. Okay, so it will further sprout in 4 directions, and they are, what are that? They are deltoid branch, acromial branch, clavicular branch, and pectoral branch, and the pectoral branch. Okay. Now we have got the third part. So third part, branches of axillary artery, third part. Branches of axillary artery, third part. Yes, Rakesh Yadav, you can take my class if I am going topic wise. So whichever topic is importantly included in anatomy subject for D Pharma, you can go. So this is a quick revision. This is a revision kind of thing. So many topics are done in one day. But if you want individual topic, that would be better for you. So I will subsequently take that session, and you can be live for that session. Third part of axillary artery is giving 3 direct branches. So what is the third part of axillary artery giving? It is giving 3 direct branches. So that is anterior circumflex humeral artery, anterior circumflex humeral artery. Then it gives posterior circumflex humeral artery. And we have got subscapular artery, subscapular artery. The subscapular artery will further give subsequent branches. So subscapular artery will further give branches. It will give further two branches. One is thoracodorsal artery, another is circumflex scapular artery. Thoracodorsal artery, which will give blood supply to latissimus dorsi muscle, and we will have circumflex scapular artery. Circumflex scapular artery. So done with this. Now we have done with this. So now let's move further. So now I would like to tell about axillary lymph node. So before proceeding to axillary lymph node, I would like just a brief about axillary vein also, because so why I am talking about axillary vein topic, because if you are knowing axillary vein, it becomes easy for you to understand the location of axillary lymph node. So I just want everybody to write down the heading, that is axillary vein. Axillary vein. Axillary vein. So the next topic is axillary vein. So either we can go with this. Yeah. So it's important to know its tributaries to understand the location of few important axillary lymph node, because it is clinically very important. Axillary vein. So when I am talking about axillary vein, actually it's formed at the lower border of teres major muscle by the union of basilic vein and the vena commitans of the brachial artery. So vena commitans of brachial artery and that of basilic vein together join to form the axillary vein at the level of lower border of teres major muscle. So please write down the axillary vein. The axillary vein is formed. The axillary vein is formed. The axillary vein is formed at the lower border of teres major muscle by the union of basilic vein and venae commitans and venae commitans of the brachial artery. It runs upwards along. So if I talk about this axillary vein, it runs upwards along the axillary artery and its end at the level of first rib when it is draining into subclavian vein. So it runs upwards along the medial side of the axillary artery and ends at the outer border of first rib by becoming subclavian vein, by becoming the subclavian vein. By becoming the subclavian vein. By becoming the subclavian vein. Now it's okay. Now let's talk about the tributary. So it's also important to know the axillary vein and its tributaries. So the tributaries of axillary vein are following. So basically the tributaries of axillary vein is corresponding to the branches of axillary artery like lateral thoracic vein, subclavian vein, and ultimately it is also having another tributary. The name is cephalic vein. So let's write down the heading tributaries and then we will come with the axillary lymph node. So please write on the heading tributaries of. Okay, so here only I just want in the axillary, here you can just write down axillary vein tributaries. It is important to know the axillary vein tributaries. So what are the most important tributaries of axillary vein must be known to you. Axillary vein tributaries. So if I am talking about axillary vein tributaries, axillary vein tributaries. Axillary vein tributaries. So if I am talking about the axillary vein tributaries, first is veins which corresponds to the branches of axillary artery, namely the lateral thoracic vein, and the subscapular vein. Now cephalic vein is another important tributary which joins actually this cephalic vein is an important tributary which joins the axillary vein when it pierces the clavipectoral fascia. Now let's talk about axillary lymph nodes. I just want firstly to show you this image where you can understand the important axillary lymph node. So basically we have got 5 axillary lymph nodes. So this is the apical axillary lymph node. This is the pectoral, which is also called as the anterior. This is the posterior. This is the central, and this is the lateral. So how many axillary lymph nodes are there? Basically we have got 5 axillary lymph nodes. This is the lateral axillary lymph node. This is the central axillary lymph node. This is the posterior subscapular lymph nodes. This is the apical, that is the terminal, pectoral or the anterior axillary lymph nodes. So together we have got 5 axillary lymph nodes. So this is the pectoral axillary lymph node, which is also called as the anterior. This is the posterior, which is also called as the subscapular axillary lymph node. This is the lateral axillary lymph node. This is the central axillary lymph node, and this is 5th one is the apical axillary lymph node. So basically these are the 5 axillary lymph node must be known to you. Okay. Now other than that, it is important to know the axillary lymph node location. So let me just enlarge this image. So here the blue color vein which has been shown to you, this is the axillary vein. So firstly, I want everybody to understand the location. I would like to draw 2 more veins which is important for you to understand. So here I will draw one vein. And here I will draw another vein. Just a schematic diagram to make you understand. Okay. Okay, basically it is important to understand these veins. So exactly this is the axillary vein which is shown you in this image. Okay, Now, here two veins I have highlighted, like this is the lateral thoracic vein. This is lateral thoracic vein, and this vein is the subscapular vein. Subscapular vein. Okay, axillary vein is already highlighted here also. This is the axillary vein which has been highlighted. This is the lateral thoracic and this is the subscapular vein. So now to understand the important lymph nodes and the location, which is very, very important for you to understand. So in this image, we can see the 5 groups of axillary lymph nodes are there. The first one is, if I am talking of the first one is the anterior group of axillary lymph node, and when I am talking about anterior group of axillary lymph node, you can see it is lying close to the lateral thoracic vein and it is draining lymphatics from the whole of the anterior aspect of the so exactly it is draining lymphatics from the upper half of the trunk and from the major part of the breast. Okay, and the next one is except that of the axillary tail of spins, or which is a part of breast, which is draining into the posterior group of axillary lymph node. The second group is the posterior group of axillary lymph node, which is also called as the subscapular group. Why? Because you can see this was the anterior group which is lying close to the lateral thoracic vein. This is the posterior group which is lying close to the subscapular vein, and in between these two, in between the anterior and posterior, we have got the central group of axillary lymph node. So this is the third. Okay, now we have also got the lateral group of axillary lymph node which is located along the axillary vein. So it is located along the axillary vein and draining lymphatics from the upper limb. And this is the terminal group of axillary lymph node, and terminal group of axillary lymph node is, this is the lateral, and this is the terminal group of axillary lymph node which is called as the apical group of axillary lymph node. So in short, we have got 5 group of axillary lymph node, and it is important to know the structure which is draining in these group of axillary lymph nodes. So till now, my students, if you have got any doubt, you can just ask me. Till now, is it okay? Are you understanding it? I will give you the individual aspect of these axillary lymph node and the lymphatics draining from the region. So that is highly important for you. So let's talk about, so the heading will be axillary lymph node. The heading is axillary lymph node. Axillary lymph nodes. So let's start. So write on the heading axillary lymph node. Axillary lymph node. Next topic is axillary lymph node. Now let's talk about the first one, that is anterior group of axillary lymph node, which is anterior or pectoral group. Anterior or pectoral group of axillary lymph. When I am talking about anterior and pectoral group of axillary lymph node, here what happened, the anterior pectoral group of axillary lymph node is located along lateral thoracic vein. So anterior pectoral group of axillary lymph node, they lie along the lateral thoracic, they lie along the lateral thoracic vein. They lie along the lateral thoracic vein. So they are located along the lateral thoracic vein at the lower border of pectoralis minor. At the lower border of pectoralis minor muscle. Now they receive lymph from, so the important aspect of this anterior group of axillary lymph node, they receive lymph from, they receive lymph from anterior aspect. So they receive lymph from upper half of the trunk, lymph from upper half of the trunk anteriorly, and from major part of, and lymphatics from major part of breast except axillary tail of spine, except axillary tail of spines. Now, so exactly if for example if the exactly if there is the cancer involving axillary tail of spines, they can be misdiagnosed as an enlarged lymph node. So basically so basically what happens exactly, axillary tail of spines is lymphatics drains into posterior group, and if the axillary tail of spines is enlarged, they can be at times misdiagnosed or can be cancerous or all. So basically this anatomical fact you have to keep in mind. So the second group is, so we have done with the first anterior, now talking about the second one, that is the posterior. The posterior or subscapular group. The posterior or subscapular group. The posterior or subscapular group of axillary lymph node. So when I am talking about posterior or subscapular group of axillary lymph node, they lie on the posterior axillary lymph node. They lie on the posterior axillary fold. They lie on the posterior axillary fold along the subscapular vein. Along the subscapular vein. They receive lymph from upper half of the trunk posteriorly. They receive lymph from upper half of trunk posteriorly, and from axillary tail of spines, and also receive lymphatics from axillary tail of spines. So done. So now we are very clear about the posterior subscapular group of axillary lymph node and the anterior group of axillary lymph node. What about the third one? The third is the central and that of the lateral. So we will talk about firstly the central group of axillary lymph node. So exactly we have already seen in the image that the central group of axillary lymph node is situated in between anterior. The central group of axillary lymph node is situated in between anterior and that of, in between the anterior and that of posterior. Central group of axillary lymph node receive lymph from the other group. They receive lymph from other groups of lymph node. And one of a clinical aspect here I want to describe. So basically, if we are talking about intercostobrachial nerve, what is intercostobrachial nerve? It's a nerve. It's a cutaneous nerve which is having a communication with the medial cutaneous nerve of arm. So intercostobrachial nerve, which is a branch. If I talk about the intercostobrachial nerve, it's a branch from the second intercostal nerve, and it can communicate with the medial cutaneous nerve of arm. So what happened in case of enlarged central group of axillary lymph node in case of breast cancer? What happened if the central group of axillary lymph node is enlarged? So it can compress the intercostobrachial nerve, and in such case what will happen? The breast cancer patient will complain severe pain in the medial aspect of arm. Now we will talk about the lateral group. So when I am talking about the lateral group of axillary lymph node which is located along the axillary vein, they receive lymphatics from upper limb, from the upper limb. They are receiving lymphatics from the entire upper limb. Now coming to the fifth, that is the apical. So if I am talking about the apical, it is also called as infraclavicular lymph node. clavicular lymph node. Apical is also called as infraclavicular lymph node. So if I am talking about apical or infraclavicular lymph node, they are situated near at the apex. So they are situated in the apex of axilla, and they are terminal group of lymph. They are terminal group of axillary lymph node. What do you mean by terminal group of axillary lymph node? That means all the lymphatics drained by this group, that is central, anterior, posterior, all will ultimately drain into the apical group of axillary lymph. That means ultimately all these lymphatics will drain into apical group of axillary lymph node. Yes, dear. Yes. Good morning to everyone. Yes. Good morning, Varun. Good morning, Kavasi. Good morning, Punit. Good morning to all of you. Yeah. Okay. Now we will talk about scapular anastomosis. The next topic is scapular anastomosis. So we have to know about scapular anastomosis. It's a very important topic. Why it is important, I will tell you. Actually, if I am talking about scapular anastomosis, you have to know the important arteries which will form this anastomosis. So exactly, arterial scapular anastomosis is an arterial anastomosis which is it's an arterial anastomosis which is located. It's an arterial anastomosis which is exactly located around the scapula. And basically, if in one line I have to describe scapular anastomosis, this is taking place between the branches of first part of subclavian artery and the branches of from the third part of axillary artery. But it is important that individual collaboration has to be discussed. So let's start with that. The arterial anastomosis around the scapula is principally found between the branches of the the first part of the subclavian artery and third part of axillary artery. So this is about the scapular anastomosis. The next important point is to know the scapular anastomosis is taking place at which location and what are the important arteries principally which is taking part in the formation of scapular anastomosis. So if I am talking about scapular anastomosis, it's important for you to know that the scapular anastomosis is taking place around the body of scapula and also around the acromial process of the scapula. So that is very important. So please write down. So firstly, I would like to explain and then I will write down the details. Okay. Now, if you will see this image, you can understand here. So let me just help you to understand the scapular anastomosis. Yeah. Yeah. So here you can see this is the So here you can see this is the posterior view of the scapula showing the spine of the scapula. So this is the spine of the scapula. And this is A for acromial process. This is A for acromial process and this is the body of scapula. Now around the body of scapula, the arteries which is forming scapular anastomosis are, so you can see this is the subclavian artery. This is the subclavian artery which you are seeing. Okay. Now the subclavian artery is giving a branch from the subclavian artery which is a branch from the first part. So you can see this is the thyrocervical trunk which is a branch from the first part of subclavian artery. So this is thyrocervical trunk which is the branch from the first part of subclavian artery. Now here you can see that it is giving, the thyrocervical trunk is giving another branch, that is suprascapular artery. So here means the suprascapular artery, which is actually taking part in the anastomosis, is having the source from which artery? So it's actually the branch of first part of subclavian artery. It anastomoses with another artery, that is circumflex scapular artery. So what you can appreciate here, it is anastomosing with another artery, that is circumflex scapular artery. And we already know that circumflex scapular artery is a branch of subscapular artery, and subscapular artery is a branch from third part of axillary artery. So this is exactly the anastomosis which is taking place. Here you can see the anastomosis which is exactly taking place at the body. Now, if I am talking of acromial process, the acromial branches of thoracoacromial artery and the acromial branches from posterior circumflex humeral artery. Now, here we already know, if we are talking about posterior circumflex humeral artery, it is also a branch from third part of axillary artery, and it is anastomosing with the acromial branch of suprascapular artery. So you can see this is the acromial branch of which artery? Suprascapular artery. And very nicely you can appreciate that these two arteries are forming major source of anastomosis in the acromial process. Also contribution is taken from thoracoacromial artery. So these are the anastomosis on the scapula. So please write down the details. So let's talk about the details of scapular anastomosis. So you can just write, we have already talked about, so write on the heading scapular anastomosis. Scapular anastomosis. So firstly, we have already talked about the major arteries which is forming the anastomosis. I would like to divide it into the parts, that is the anastomosis of the arteries which is taking part at the level of body and that of acromial process. Okay. So we will talk about, so the first anastomosis which I want to describe here is the anastomosis which is taking part around the body of scapula. So first point is around the body of scapula, anastomosis which is taking place around the body of scapula. Anastomosis which is taking place around the body of scapula. So if we are talking, it is consist of, so around the body of scapula, the anastomosis is occurring via two sources. One is suprascapular artery. One is suprascapular artery, which is a branch from the thyroid. So suprascapular artery is a branch from the thyrocervical trunk, and we know that thyrocervical trunk is a branch from first part of subclavian artery. So this is forming the anastomosis. So this suprascapular artery is forming the anastomosis with, circumflex scapular artery, It is forming anastomosis with circumflex scapular artery. And we know that circumflex scapular artery is a branch from third part of axillary artery. And also contribution is taken from, deep branch of transverse cervical artery, which is also a branch from thyrocervical trunk, which is a branch from first part of subclavian artery. So moving further, deep branch of the transverse cervical artery, which is a branch from thyrocervical trunk. And we know the thyrocervical trunk is a branch from first part of subclavian artery. Done. So this was one of the anastomosis which is taking place around the body of scapula. And the second level of anastomosis is, so talking about the second level. So if I am talking of the second level of anastomosis, that is taking place at the level of over the acromial process, of scapula. So the second level of anastomosis is over the acromial process of the scapula. Over the acromial process of scapula. Over the acromial process of scapula. So this anastomosis is from acromial branch of, it is from the source of acromial branch of the thoracoacromial artery, which is a branch from second part of axillary artery. So slight contribution is taken from this artery, but a major contribution is from third part of axillary artery and first part of subclavian artery. Also from acromial branch of suprascapular artery, and also from the acromial branch of posterior circumflex humeral artery. Acromial branch of posterior circumflex humeral artery. Posterior circumflex humeral artery. So done. So we have finished with this topic. Let me just check with the students, have they understood or not? Okay. Which anastomotic branch? Okay, dear Bindu. When axillary artery is ligated, which artery supports? Okay, I will tell you, Bindu. Actually, the thing is that when there is any kind of actually, when we are talking about any kind of blockage which is lying in the subclavian artery or the axillary artery, basically the branches of the third part of axillary artery and the first part of subclavian artery will form collateral circulation, and this collateral circulation which is formed via this anastomosis is enough to maintain the nutrition or maintain the blood supply to that of the upper limb. Okay, dear. So Bindu, that is like, that means if there is any blockage in the first part of axillary artery, if there is any blockage of the second part of axillary artery or other parts of subclavian artery is also having second and third part, at the anastomosis and collateral circulation and blood supply of upper limb and scapular region is maintained because there is collateral circulation formed between the branches of first part of the subclavian artery and third part of axillary artery. So Bindu, is it okay? Have you understood? Jaswant, yes, good morning, dear. Varun, good morning. Have you understood? Please let me know. Okay, done with this. Now we will talk about another topic, that is, I would like to talk about brachial artery and profunda brachial artery branches, and then we will come to the scapular spaces, and then we will solve few MCQs related to the topic. Is it okay? Can we proceed with the brachial artery and that of the profunda brachial artery? Everyone, next topic. Brachial artery. Brachial artery. Bindu, okay, yeah, good. Okay. This is brachial artery. Now, brachial artery, it is continuation of, axillary artery beyond the level of lower border of teres major muscle. teres major muscle. Teres major muscle. Okay. So now, other than that, it's also important to know the important branches of brachial artery. So exactly, and what happens exactly at the level of neck of radius, again the brachial artery divides into terminal branches, that is ulnar and radial artery. Now I just want everybody to concentrate on this image. So this is showing you the brachial artery branches. So here in this diagram, if I slightly enlarge this, you can see this is the part of teres major muscle. So this is the part of which muscle? This is the part of teres major muscle. So this is teres major muscle, which you have seen here. Now what I told you, the axillary artery changes its name to, brachial artery beyond this level, and then the brachial artery will give further branches. It is giving nutrient artery to the humerus sometimes. It is giving superior ulnar collateral artery. It is giving inferior ulnar collateral artery. It is giving profunda brachii artery, one of the deep, profunda brachii artery is called as deep artery of arm. It's the largest branch from the brachial artery. Okay, and other than that, it also give muscular branches. Other than that, it also give muscular branches. That means important branches of brachial artery will be, one more diagram is there where you can see the brachial artery. So important branches are profunda brachii artery, nutrient artery, muscular, superior inferior ulnar artery, and also the terminal branches, that is radial and ulnar artery. If I talk about the profunda brachii artery, which is an important branch from that of the brachial artery, it gives subsequent branches. Profunda brachii artery is traversing through lower triangular space, and it is giving subsequent branches like muscular branches, radial collateral artery and middle collateral artery. It also gives nutrient branches to the humerus bone, and it gives one of the deltoid branch. That means profunda brachii artery is giving radial collateral, middle collateral, nutrient artery, and that of ascending nutrient artery and a deltoid as a ascending branch. So basically you have to know the important branches of this arteries, and then we will come to the next topic. So you can just write here the heading, branches of brachial artery. Branches of brachial artery. So important branches of brachial artery. Important branches of brachial artery. So let's write all the important branches of brachial artery which must be known to you. Let's write the name of all the important branches of brachial artery. Branches of brachial artery. The branches of brachial artery are following. The branches of brachial artery is following. It gives following branches. The following branches are given from the brachial artery. It gives muscular branches. It sometimes gives nutrient artery to humerus bone. Actually, nutrient artery to humerus bone is an important branch given by the profunda brachii artery mainly, but sometimes brachial artery can also give nutrient artery to the humerus bone. Okay, nutrient artery to the humerus bone. Now, other than that, we will also see the other branches. So it gives superior ulnar collateral artery. It gives inferior ulnar collateral artery. It gives other branch, inferior ulnar collateral artery. Inferior ulnar collateral artery, superior ulnar collateral artery. It gives terminal branches. It gives terminal branches. So if I talk about the terminal branches of these arteries, so the terminal branches are two, and the terminal branches given are radial artery. So terminal branches are given at the level of neck of radius, that is radial artery and ulnar artery. Okay. Now I would also like everybody to note down also the branches of profunda brachii artery. So please write on the heading profunda brachii artery. Write on the heading branches of profunda brachii artery. Branches of profunda brachii artery. So let's talk about the branches of profunda brachii artery. So important branches of profunda brachii artery is following. It gives deltoid branch. So it itself is the profunda brachii artery is also called as deep artery of arm. What is the other name? It is also called as deep artery of arm. Profunda brachii artery is also called as deep artery of arm, and the further branches which it gives, a deltoid branch. It gives a radial collateral artery. It gives middle collateral artery. It gives middle collateral artery, and it gives nutrient artery to humerus. It gives nutrient artery to humerus. It gives nutrient artery to humerus bone. It gives nutrient artery to humerus bone. So basically these are the branches of profunda brachii artery which has been shown. Other than that, so done with this. Now I would like to also show you an image here. So exactly in this image, why I'm enlarging it and showing an important image. So here what you can see, we have got two terminal branches. So we have got two terminal branches. We have got radial artery as the terminal branch and ulnar artery as the terminal branch. So here one of the artery which has been asked so many times in the MCQ. So these are the two terminal branches which is given at the level of neck of radius. Now here you can see the ulnar artery is giving one of an artery. The name is the common interosseous artery. What is the name? Common interosseous artery. The common interosseous artery further divides into anterior interosseous artery and posterior interosseous artery, and then it gives one of an important branch, that is interosseous recurrent artery. So in the previous year of examination this question has been asked. So I want you to understand that the two terminal branches of radial and of the brachial artery is the radial and ulnar artery, which is given at the level of neck of radius. Radial and ulnar artery take part in formation of palmar arches of the hand, palm. And here one of the branch of ulnar artery which is very importantly taking part in the formation of elbow anastomosis is interosseous recurrent artery. Interosseous recurrent artery is a branch of posterior interosseous artery. Posterior interosseous artery is a branch of common interosseous artery, and common interosseous artery is a branch of ulnar artery. So this is again an important point which you can note down, then we can move on to the next topic. So here you can write one of important point. You can write radial and ulnar arteries are terminal branches of radial and ulnar arteries are terminal branches of brachial artery. Are terminal branches of brachial artery. Radial and ulnar arteries are terminal branches of brachial artery. Now talking about branches of ulnar, and I just want you to tell an important point. Ulnar artery, if I talk about ulnar artery, it gives one of the important branch, that is common interosseous artery. That is common interosseous artery. And common interosseous artery will give further branch, that is that is anterior interosseous artery. That is anterior interosseous artery and posterior interosseous artery and posterior interosseous artery. The posterior interosseous artery will give another branch, that is interosseous recurrent artery. That is interosseous recurrent artery. That is interosseous recurrent artery. So this is very important for you to understand, because in the previous year of examination it has been asked. So we have done with this. Now the next topic is a very important and a simple topic, but the question has been asked in the previous year of examination. And okay, I just want, before proceeding to this, collateral circulation through, before proceeding to the subscapular space, we have already finished with the topic of scapular anastomosis. So the collateral circulation through scapular anastomosis is very important clinically. So if the subclavian and axillary artery are blocked anywhere between the first part of subclavian and third part of axillary artery, there is a potential pathway of collateral circulation maintained, which is very important for maintaining adequate blood supply to upper limb. Now talking about the subscapular spaces. So when we go for the dissection on the scapular region from the posterior aspect, we can visualize quadrangular spaces, and we can visualize the upper and the lower triangular spaces, and it is important for us to know the boundaries of these spaces and the contents of these spaces. So let's talk about that. So we have to know in this category three spaces. Three spaces are very important that you have to know. So we have got quadrangular space, we have to know upper and the lower triangular space, we have to know upper triangular space, and we have to know lower triangular space. Okay, now one by one I would like to describe the boundaries and the content. So for that, firstly I want everybody to see this image, where this is a schematic diagram to make you understand the boundaries. So this is a schematic diagram to make you understand the boundaries. So firstly I would like to tell about quadrangular space. So if you are, so here actually this is the quadrangular. So let me just, okay, now this whole area is the quadrangular space, this is the upper triangular space, and this is the lower triangular space. Okay, so this is quadrangular space, this is upper triangular, and this is lower triangular space. Got it? Okay, so I will write more. This is upper triangular and this is lower triangular. See here. So this is U and this is L. Okay, now let me just outline this quadrangular space, this upper triangular space, and this lower triangular space. Okay, now let's focus on to the quadrangular space boundary. So if I am talking about a quadrangular space boundary, what you can understand, here you can see one muscle. What is this muscle? This is the teres minor muscle. This is which muscle? This is teres minor muscle. This is teres major muscle. Which muscle is this? This is teres major muscle. And in between you can see long head of biceps, long head of triceps, sorry, long head of triceps muscle. So this is long head of triceps, this is long head of triceps, and this is the teres major muscle. This is teres minor muscle, this is teres major muscle, and this is long head of triceps. This is long head of triceps. So done. So we have done with the boundaries. So you can just use your two fingers. You can just use your 2 fingers to understand. Yeah, this is the 2 fingers which can be used to understand the quadrangular and the 2 triangular spaces. Just a minute. You can use like this, okay, for yourself. So now this will be the teres minor muscle, the upper one. The lower middle finger is the teres major, and this will be the medial one, will be the long head of triceps, and laterally we will have the humerus bone. Now here, if I want to talk about the boundaries of quadrangular space, you can see this is the muscle which is the teres minor muscle. So teres minor muscle is forming the boundary superiorly. Also, we will have the subscapular muscle, which is not shown. Below with the boundary is teres major muscle, and medially is the long head of triceps, and laterally is the surgical neck of humerus. What is it? This is the surgical neck of humerus bone. So this forms the boundary. That means this forms the boundary of quadrangular space. Now, if I am talking about the upper triangular space, the boundary is, we have done with the quadrangular space boundary. Now the next topic is upper triangular space. Upper triangular space boundary, superiorly it is formed by the teres minor muscle, T minor, inferiorly by T major, teres major muscle, and for this laterally it is formed by the long head of triceps. For the lower triangular space, if I am talking about the lower triangular space, it is having the boundary medially the long head of triceps, laterally the shaft of humerus bone. So lower down it has come, so shaft of humerus bone, and superiorly we have got the teres major muscle. Now what remains next is to know the structures passing through these spaces. After knowing the boundaries, it is also important for us to know the structures passing through the spaces. So actually I will use another diagram to help you understand. But if I am talking about quadrangular space, one artery and one nerve is passing through the quadrangular space, and that is posterior circumflex humeral artery and vein, that means posterior circumflex humeral vessels, and axillary nerve, which is related with the surgical neck of humerus. If I am talking about upper triangular space, just one artery is passing, that is circumflex scapular artery, and this circumflex scapular artery, if I am talking about the circumflex scapular artery, this artery is a branch of subscapular artery, which is a branch of third part of axillary artery. When I talk about lower triangular space, one artery and one nerve is passing through this space. The nerve is radial nerve and the artery is profunda brachii artery. Which artery is it? This profunda brachii artery and the vein, and radial nerve. The other name of profunda brachii artery and vein is the deep artery of arm. So done. So here again you can see in this image. So very nicely you can appreciate in this image. You can appreciate in this image the quadrangular and that of lower and upper triangular spaces. So here you can see the quadrangular space, the triangular spaces, and you can clearly see the teres minor muscle is superiorly. This is the teres major and this is the long head of triceps. So here we have got following spaces and the boundaries can be well appreciated. Now what I told you, there is another schematic diagram just is making you understand the contents of these spaces. Quadrangular space is having two structures traversing, the axillary nerve and posterior circumflex humeral vessel. In the upper triangular space we have got circumflex humeral artery, and in the lower triangular spaces we have got profunda brachii vessel, that is deep artery of arm, and the radial nerve related with the shaft of humerus bone. So this is the image which is also showing the same structures and the structures traversing. We have got this as the quadrangular space. So we have got the quadrangular space, we have got the upper triangular, and we have got the lower triangular space. You have to use another. So we have got upper quadrangular space, we have got upper quadrangular, upper and the lower triangular space, and the structures traversing. Again, I would like everybody to see this another image which is showing you the quadrangular space here. This is QS, means quadrangular space, which is having teres minor superiorly, teres major inferiorly, and medially long head of triceps. Again, one image is there which is the cadaveric image showing all the spaces. So we can see the quadrangular space here. We can see the upper triangular and we can see the lower triangular space. Now this is QS, this is U triangular, and this is L triangular. So here you can see how you are going to utilize the space boundary. This is the long head of triceps, this is the teres minor muscle, and this is the teres major muscle. Okay. So we have got all the muscles and we have got all the boundaries of quadrangular and triangular spaces. So we'll come to the MCQs, but I just want quickly to write this details so that it will be easy for you to revise. So please, let's write the individual spaces. So let's write. All of you, have you understood? Any doubt? Please let me know. All the students, have you understood? Yes, medicine, Sally, you are absolutely right. So yes, dear. So let's write down the details. So write down the details of quadrangular space. Quadrangular space. Quadrangular space. So let's talk about quadrangular space. So if I am talking about quadrangular space, we can just note down quadrangular space boundaries. Quadrangular space boundaries. So let's talk about quadrangular space boundaries. So superiorly, it is bounded by teres minor muscle on the posterior aspect, and also there will be subscapularis muscle on the anterior aspect. And there will be capsule of shoulder joint. So actually all these structures are forming the superior boundary of the quadrangular space, and thereafter inferior boundary. So if I talk about inferior boundary of quadrangular space, inferiorly it is bounded by teres major muscle, medially it is bounded by long head of triceps, laterally it is bounded by surgical neck of humerus. Surgical neck of humerus. Okay, surgical neck of humerus. Now we have done with the quadrangular space. The next thing is to know the contents. Contents of quadrangular space. So next thing is to know the contents of quadrangular space. So if I talk about the content of quadrangular space, it contains two important structures. And what are they? They have got two important structures. We have got two important structures in the quadrangular space, and that structures are axillary nerve and posterior circumflex humeral artery. Posterior circumflex humeral artery. Posterior circumflex humeral artery. So basically these are the contents of quadrangular space. Done. Now let's talk about the contents of upper and the lower triangular space. So I would also like to talk about the contents of upper and lower triangular space. So please write on the heading. Upper triangular space. Upper triangular space. So let's talk about the boundaries of upper triangular space. So when I am talking about the boundaries, so let's try and write down boundaries of upper triangular space. So if I am talking about the boundaries of upper triangular space, superiorly it is bounded by teres minor muscle. Superiorly it is bounded by teres minor muscle. Laterally it is bounded by long head of triceps. And inferiorly it is bounded by teres major muscle. Teres major muscle. So that means on inferior aspect we have got teres major muscle, superiorly we have got teres minor muscle, laterally long head of triceps, and the structures traversing. So content of the structures traversing through the space. So exactly it's not the content which we are talking. Content ke the better word will be structure traversing. Structure traversing through lower triangular space. So through upper triangular. So structures traversing through upper triangular space. So it's important to know the structures traversing through upper triangular space. So structures traversing through upper triangular space. In this we have got just one content, that is circumflex scapular artery. That is circumflex scapular artery. So upper triangular space we have got just one structure, and that is circumflex scapular artery, which is a branch of third part of axillary artery. Now talking about lower, the next is lower triangular space. Lower triangular space. Lower triangular space. So if I am talking about lower triangular space, the lower triangular space boundaries are: medially it is bounded by long head of triceps. Laterally it is bounded by shaft of humerus bone. Superiorly it is bounded by teres major muscle. Superiorly it is bounded by teres major muscle. And the structures passing. So if I am talking about the structures traversing, so next is structures passing. Structures passing through this space. Structure passing through this space. Structures passing through this space. So let's talk about the structures passing through this space. So if I am talking about the structures passing through this lower triangular space, we have got two structures. One is the radial nerve and the other is profunda brachii artery. Profunda brachii artery, which is also called as profunda brachii artery, and vein, which is also called as deep artery of arm. What is the other name? It is also called as deep artery of arm. The other name of profunda brachii artery is deep artery of arm. So we have done with this. So let me just check with the students. Can we solve few MCQs related to this topic, everyone? Yes, Punit, you are absolutely right. So yes, Punit has given all contents and all the boundaries very good. So yeah, thumbs up goes for him. Okay, dear. Now, can we have MCQs now? So let's start with the MCQs related to the topic. So let's start with the first MCQ. So I will wait for everyone to answer and then I will come up with the explanation. Question number 1. Question number 1 for everyone. So which is true regarding, which of the following is true? So which of the following is true regarding the quadrangular space? So which of the following is true regarding quadrangular space? It is bounded superiorly by teres major, bounded inferiorly by subscapular teres minor, medially by humerus, laterally by long head of triceps, contain posterior circumflex humeral artery, axillary nerve, brachial plexus herniation occur here. So which is true regarding the quadrangular space? Please give me the right answer here. Which of the following is the most correct answer about quadrangular space? So Jayashree, Rathore, Bindu, Punit, everyone is telling D. So is the D answer right? Yes, absolutely the D answer is right and all of you gets a thumbs up. So absolutely right answer. Absolutely right answer. Yes, exactly the right answer is D. Exactly, the right answer is D. So definitely you get a right answer. Aurora has also given a right answer. Yes. Now talking about, so if I talk about quadrangular space, just to summarize, quadrangular space is bounded superiorly by teres minor, inferiorly by teres major, medially by long head of triceps, and laterally by surgical neck of humerus. Two structures are passing through it, and that structures are axillary nerve and that of posterior circumflex humeral artery. Deep artery of arm accompanies which of the following nerve when it is winding around the body of humerus, whether it is accompanying radial, musculocutaneous, median, ulnar or axillary. Yes dear, please mark the right answer. Aradhana is telling E, deep artery of arm. What about others? Deep artery combines both are contents of lower triangular space. Okay, so Punit has given the explanation and along with it, it has given the answer also. And the correct answer is absolutely A. Yes, lower triangular space, exactly correct, lower triangular space. And we know that deep artery of arm. What is the other name of deep artery of arm? I told you so many times, deep artery of arm and radial nerve is traversing through lower triangular space. And what is the other name of deep artery of arm? Absolutely correct. Profunda brachii artery, Punit. Absolutely correct here. Absolutely correct. Now, all of you, question number third. Which of the following parts of the humerus is matched correctly? Yes, Jayashree is also right. Jayashree Rathore is absolutely right. Yes. Now, the next is which of the following parts of the humerus is matched correctly with the nerve with which it is in direct contact. With which it is in direct contact. Distal end of humerus, radial nerve is there, surgical neck, musculocutaneous nerve, radial groove, musculocutaneous nerve, medial epicondyle, ulnar nerve, scapular notch, suprascapular nerve. So Bindu has given the answer, Punit has given the answer. What about others? So the correct match the following. So the correct match the following is, especially the right answer will be medial epicondyle and ulnar nerve. Absolutely correct. Absolutely correct. It's the medial epicondyle and ulnar nerve. So we have got medial epicondyle and ulnar nerve as basically the most correct answer here. So yes, you are absolutely right. Now I will tell you, yes, a distal end of humerus is related to radial nerve is wrong. Distal end of humerus will be related to median nerve. Surgical neck is related to axillary nerve, so it is wrong. Radial groove is related to radial nerve, so it is wrong. This is correct. And scapular notch is related to suprascapular nerve is wrong. Actually, this will be suprascapular notch. Suprascapular notch. The better word will be suprascapular notch, which will be related with the suprascapular nerve. So basically, only one correct option is medial epicondyle. I would like to show you this image. So see here, arteries. So surgical neck of humerus will be related with the posterior circumflex humeral artery, and axillary nerve. The potential damage to the mid shaft area or radial groove will be radial nerve and profunda brachii artery. Damage to ulnar nerve is related to medial epicondyle and supracondylar fracture, that is the fracture just above the condyles. Yes, Punit, spiral groove and radial groove is the same thing. Yes, they are same. Yes, they are same. Yes, they are same, dear. Now, here in this image, you can see the potential damage to the supracondylar fracture above the condyles will be damaging the brachial and the brachial artery and the median nerve. Here in this diagram, you can see correctly. So here in this diagram, you can correctly see that medial nerve is related medially in the cubital fossa distal aspect, radial nerve is laterally, and ulnar nerve will lie related to medial epicondyle. Radial nerve is more related onto the lateral aspect in the cubital fossa. Medial nerve will be on the medial aspect in the cubital fossa. Now this is a diagram showing you, so we can just outline the spine of the scapula. So this is the spine of the scapula, and this is spine, and this is A for acromial process. So here you can see there are two ligaments. So here you can see there are two ligaments. Okay, this ligament is the transverse scapular ligament, and this is the spinoglenoid ligament. So what you can appreciate in this diagram, so the nerve, the artery is lying deep to the transverse scapular ligament, and the suprascapular nerve is lying superficial to the to that of the ligament, transverse scapular ligament, and this is suprascapular notch. So basically this is suprascapular notch, which is related to suprascapular artery and suprascapular nerve. This is spinoglenoid ligament. So basically the word scapular notch is not correct. In this option, if they have used suprascapular notch, then only it was a correct option and the right answer. Now everyone, can we start with the next topic, brachial plexus? It's a very, very important topic. So many times the MCQ has come from this topic. So let me know, every students, can we go with the topic of brachial plexus? Okay, brachial plexus. Okay. So should we start? Okay, brachial plexus. So I just want you to I just want everybody to have a detail of brachial plexus. So if I'm, yes, Punit, you are right. So you can see this image where you can see the brachial plexus are emerging out from the neck and reaching the axillary region. So when it is emerging out from the neck, it is passing between two important scalenic group of muscle. So basically brachial plexus is traversing between scalenus medius and scalenus anterior muscle. If I talk about the trunks of brachial plexus, it is passing between the scalenus medius and scalenus anterior muscle and then reaching the axillary region. Aradhana, time of session at which ends? It will end when the upper limb is finished. So I think it will end in evening only. Evening, till evening, 5 o'clock I will sure continue it. Okay, till 5. 9. So minimum till 5 or 6. Aradhana, if I have to complete entire upper limb, I will require timing till evening. Is it okay, Aradhana? Okay. Now, scalenus anterior, scalenus medius, and this is the subclavian artery and the trunks of brachial plexus traversing through it. Brachial plexus, yes, Punit is absolutely right. Brachial plexus is formed by the ventral rami of C5, C6, C7, C8 and T1. So, let's write about brachial plexus. Brachial plexus is formed by the ventral rami of, it is formed by the ventral rami of C5, C6, C7, C8 and T1. Brachial plexus is formed by the ventral rami of C5, C6, C7 and T1. Now, it's also, now you can also write one more point here, that is, firstly I would like to, so this is the most common formation of brachial plexus. So that is the most common formation of brachial plexus, but I just want you to give the concept of prefixed and postfixed brachial plexus. So that is the most common form of brachial plexus, but when I am talking about prefixed brachial plexus, sometimes what happens, the brachial plex formation, the brachial plex formation is taking contribution from C4 also. So it takes contribution from C4, then it is called as prefixed brachial plexus, and sometimes brachial plex take contribution from T2, then it is called as postfixed brachial plexus. So this is the most common formation of brachial plexus, but sometimes brachial plex can be prefixed and postfixed. So write down the details of prefixed and postfixed brachial plexus. prefixed brachial plexus. Prefixed brachial plexus takes contribution. Punit, ma'am, keep going, because for the very first time I find very interesting class topic wise during MBBS. I never used to like anatomy. Thank you for the session. So yes, thank you so much, dear. Thanks for your words. That is encouraging for me. So takes contribution from C4 cervical 4 nerves and postfixed brachial plexus. If I talk about postfixed brachial plexus, the postfixed brachial plexus takes contribution from T2. Got it? Yeah, so that is okay. Now I would also like to write here one more point. The trunks of brachial plexus are emerging from, so please write down, trunks of brachial plexus emerges from trunks of brachial plexus emerges out in between trunks of brachial plexus emerges out in between the scalenus, anterior and scalenus medius, anterior and scalenus medius muscle. Okay, done with this. Now it's important for us to know the major components of brachial plexus. So there are 5 components of brachial plexus and you should be aware of this. So by a example of one image, I am going to explain each components of brachial plexus. So I will take an image and then I will explain each component of brachial plexus. Together we have got 5 major components of brachial plexus, and that are roots of brachial plexus, trunks of brachial plexus, divisions of brachial plexus, and the cords of brachial plexus and its branches. So for a proper understanding, it is important to know that these are the parts of brachial plexus which are located at which region. So if I am talking about it, so let me just, yes dear Punit, so let me just show you this image. So when I am showing you this image, if I am talking about the roots of brachial plexus, the roots of brachial plexus is located in the neck region. The trunks of brachial plexus is traversing in between the scalenus medius and scalenus anterior muscle, and the division is located behind the clavicle. That means roots, trunks and division are supraclavicular structures of the brachial plexus. The cords of brachial plexus is located, cords and the branches of the cords of brachial plexus are located in the axillary region. So that means the roots are located in the neck. Trunks are also located in the neck in between scalenus medius and scalenus anterior muscle. It is emerged. Division is located behind the clavicle. The cords and brachial plexus are located in the axilla region. So that means, in short, if I have to give important location, so I will just tell roots, trunks are supraclavicular structures. Roots and trunks are supraclavicular structures. Why supraclavicular structure? Because they are supraclavicular structures of brachial plexus. They are supraclavicular structures of brachial plexus. Divisions of brachial plexus. So divisions of brachial plexus, roots and trunks of brachial plexus. Division of brachial plexus is located behind the clavicle. Cords and branches of brachial plexus. Cords and branches of BP means brachial plexus. They are infraclavicular structures of brachial plexus. They are infraclavicular structures of brachial plexus. They are infraclavicular structures of brachial plexus. Done? So we have done with this. Now I would like to show you a image. So what is this image here? Actually, this image is actually a schematic diagram, and this schematic diagram help you to understand about the formation of brachial plexus. So this is a very important diagram. Why it is very important? Because this will help you to understand how the brachial plexus formation takes place. So this is a very important diagram which help you to understand the formation of brachial plexus. So here, if you will see this image, you can see these are the roots of brachial plexus. What are these? These are the roots of brachial C5, C6, C7, C8 and T1. So ventral rami of C5, C6, C7, C8 and T1 is forming the roots of brachial plexus. Now coming to the next part, that is trunks of brachial plexus. So when I am talking about the trunks of brachial plexus, we have got upper trunk, we have got middle trunk and we have got lower trunk. So now how you can understand the formation of upper trunk, please see the diagram, it will help you to understand. So when you are seeing the upper trunk, you can clearly appreciate the formation. You can see C5 and C6 will join to form the upper trunk of brachial plexus. C7 alone forms the middle trunk of brachial plexus. C8 and T1 will again join to form the lower trunk of brachial plexus. Okay. So this is how the formation of brachial plexus takes place. So this topic is about formation of brachial plexus. So till now you are understood the diagram and you are knowing how the formation of roots and trunks of brachial plexus takes place. Now the next part is division. The next part is division of brachial plexus. And to understand the division of brachial plexus, I will use this diagram. And here you can see we have got, this is blue color is A for anterior. So this is anterior. So if you want, I can write this is anterior, this is anterior, this is also anterior. So we have got three anterior divisions. So each of the upper, lower and middle trunk will divide into anterior and posterior division. Yellow color is for posterior division. So this is posterior, this is also posterior and this is also posterior. That means each of the trunk is again dividing into anterior and posterior. So what you can say, each trunk is again dividing into anterior and posterior division, and here anterior division of upper and anterior division of the middle trunk will lead to the formation of lateral cord of brachial plexus. So basically you can just use another color. So this is anterior division of upper, anterior division of middle. This together will join and lead to the formation of lateral cord of brachial plexus. Now anterior division of lower will lead to the formation of medial cord of brachial plexus, and posterior division, now see this diagram, posterior division of all the three trunks, posterior division of all the three trunks will join to form the posterior cord of brachial plexus. So this is how the three cords of brachial plexus are formed. So this is how the three cords of brachial plexus are formed, and it is very important that you should understand the formation of brachial plexus, and the next step is to know the branches of individual components of brachial plexus. So please let me know, students, have you understood the formation of brachial plexus? Please let me know. So please let me know, have you understood the formation of brachial plexus? Then we can come up with the branches of individual component of brachial plexus. Punit, okay? Okay, very nice. Now for the branches of individual components, for the cords, I would like to explain a story to you, and via that story you can understand the branches from each part of the brachial plexus, mainly which part, mainly the cords of brachial plexus, which has to be known to you. Okay? Okay, so let's see. Now here just giving you the concept of anterior and posterior. So basically this is the cut section of the spinal cord. So this is the gray matter. So this is the gray matter which you are seeing. This is the gray matter. Now, this is the gray matter and this is the white matter. So, you can just write here, this is the gray matter and this is the white matter. This is the gray matter, this is the white matter, that is the cut section of the spinal cord. And now what you can appreciate from the gray matter, if I am talking about the gray matter, so if I am talking about the gray matter, here the gray matter of the spinal cord is having dorsal nerve roots and it is having ventral nerve roots. So you can see it is having dorsal nerve root and it is having ventral nerve roots. So these are all dorsal nerve roots will be joining and this will lead to the formation of dorsal root ganglia. What it will form? It will form dorsal root ganglia and here these are the ventral nerve roots. So exactly the ventral nerve roots are motor and the dorsal nerve roots are sensory. So basically when we are talking about dorsal nerve roots, they are sensory, but motor nerve roots are ventral nerve roots are motor. So dorsal root and the ventral root will join to form the spinal cord, the spinal nerve. So it is very important for you to note down that all the spinal nerves from the spinal cord, we have got 31 pairs of the spinal nerve. All the spinal nerves pair which is emerging out from the spinal cord will be mixed type because it is formed by joining two roots. The motor is ventral and the sensory is the dorsal. After their formation, you can see in this image, after the formation, if you will see nicely here, what you can appreciate, after their formation, they again divide into dorsal ramus and that of ventral ramus. Now, ventral ramus will give innervation to the structures on the anterior aspect of the body and the dorsal ramus will give innervation to the structures which is lying in the back. So, that is very important. So, that is the concept of ventral rami. So, when I am writing this term that the anterior or the ventral rami of the cervical nerves, that is C5, C6, C7, C8 and T1, that is first thoracic, is leading to the formation of brachial plexus. So, you should be aware with the term ventral rami and dorsal rami. So, yes everyone, Punit, Aradhana, Jayashree, Bindu, everyone, those who are live, please tell me, have you understood this concept of ventral rami and dorsal rami? That is important. Everyone have understood? Can we proceed further? So, Punit is telling yes ma'am, he is under, Jayashree is telling yes. Okay, clear? Now, the next important step is to know the branches. Okay, so the branches from the roots of brachial plexus. Aradhana, no ma'am, thanks a lot, proceed. Dadagiri Games is telling thanks a lot. Aradhana, no, you didn't understood. Okay, for Aradhana, I am repeating it. For Aradhana, I am repeating it. For Aradhana, I am repeating it. See this image. Okay, Aradhana, it is for you. See this image. Okay, so when you are seeing this image, you can see the darker. This is cut. Aradhana, please concentrate. This is the cut section of the spinal cord which you are seeing. And in the cut section of the spinal cord, in the middle part, we have got the gray matter and the outer zone is white matter. Okay, always the gray matter is formed by the nerve cell bodies and the white matter is formed by nerve fibers. Okay, dorsal nerve root. So when you see the gray matter, there is dorsal horn and there is ventral horn. So when I am talking about dorsal horn, it is sensory. It is a sensory component and ventral horn is motor component. Okay, ventral horn are motor component and dorsal horn are sensory component. Now, the formation of the spinal nerves can take place by joining the two nerve roots, that is dorsal and the ventral nerve roots. That means if I am talking about this dorsal root, it is sensory. If I am talking about the ventral roots, it is motor. That means each and every spinal nerve. That means whenever I am talking about the spinal nerve, it will be always mixed type. Why? Because these two nerve roots join together. These two nerve roots will join together and leads to the formation of spinal nerve. After the formation of spinal nerve, it diverges in two directions. It again divides into two rami. So the spinal nerve again divides into two rami. The ventral one will go to the anterior aspect of the body and the dorsal one will give innervation to the back muscle. So when I am using the word that that brachial plexus is formed by the ventral rami of C5, C6, C7, C7, C8 and T1, that means that we are talking about the ventral rami and this is the concept of ventral rami. Okay, same way when I am using the word femoral nerve formation, the formation of obturator nerve, the formation of different nerve, I am using the ventral rami. So this is the image which will help you to understand the concept of ventral rami and dorsal rami. That means each spinal nerve after their formation will divide into two rami. The one going anterior in the body is the ventral rami, and the one giving innervation to the muscles of back is the dorsal rami. Aradhana, Arora, have you understood now? Aradhana, have you understood now? Fazal has understood. Okay, Aradhana, this is for you. Please let me know so that I can proceed. Okay. So now, okay, great, Aradhana. So now it's great that you have understood. Now let's move with the branches of the different parts of brachial plexus. So first thing which I want you to understand is the branches of roots of brachial plexus. So see this image and understand the roots of brachial plexus. So here, this is C5, this is C5, this is C6, this is C7, this is C8, T1, and so this is basically the roots of brachial plexus. This is basically the roots of brachial plexus. Now, from the roots of brachial plexus, we have got two branches. One is dorsal scapular nerve and the other is long thoracic nerve. So, from the roots of brachial plexus, we have got dorsal scapular nerve as one branch and we have got long thoracic nerve as the other branch. So, that means roots of brachial plexus is giving two important direct branch, long thoracic nerve and dorsal scapular nerve. Dorsal scapular nerve will have the root value C5. Long thoracic nerve will have the root value C5, C6 and C7. Other than that, the roots of brachial plexus is also giving communicating branch to phrenic nerve and branches to the scalenus group of muscle. Now, when you see the superior trunk, this is what? This is upper trunk, that is superior trunk. This is the middle trunk and this is the lower trunk. Now, it is very important for you to note down that there is only branches from the upper trunk of brachial plexus. So, we have got two branches from the upper trunk of brachial plexus. One is suprascapular and other is nerve to subclavius. So, here we can see two branches from the upper trunk of brachial plexus and there is no branches from the middle trunk and the lower trunk. So, both have the root value C5 and C6. Both nerve to subclavius and suprascapular nerve is having the root value C5 and C6. Now, it is important to know the branches of cords of brachial plexus. So, firstly, I will talk about the lateral cord of brachial plexus. So, we know that lateral cord of brachial plexus is giving three branches. So, when you see the lateral cord of brachial plexus, I would like to show you the three branches. So, we have got musculocutaneous nerve, we have got the median root of the lateral root. So, this is, good morning, this is lateral root. And there is one more nerve here which has not been shown here, the lateral pectoral nerve. So, this is lateral pectoral. So, this is LPN, lateral pectoral nerve. This is musculocutaneous nerve. This is musculocutaneous nerve and this is median nerve lateral root. So, these are the three branches. These are the three branches from the lateral cord of brachial plexus. Actually, I am showing you these branches, but I will give you a mnemonic and a story by which you will remember the branches of brachial plexus. Now, talking about the posterior cord, we have got which is formed by the posterior root of all the three trunks, and this is giving 5 branches. So, it is giving the axillary nerve, the radial nerve, the thoracodorsal nerve, the inferior and superior subscapular nerve. So, basically, I will use another color. So, I am using, so this is the posterior cord of brachial plexus and let me show you all the branches. So, when I am talking about the posterior cord of brachial plexus, the branches are axillary, the branches are radial, the branches are superior or upper subscapular, inferior means lower subscapular, and that of thoracodorsal nerve, nerve to latissimus dorsi. So, all these means, that means 5 branches are there from the posterior cord of brachial plexus. So, please don't get worried. I am just showing you in the image, but I will give you a mnemonic and a story to memorize the branches of different parts of brachial plexus. So, done. So, that means till now we have done the lateral cord and we have done the posterior. What remains? The last is the medial cord. Now, talking about the medial cord, so this is the medial cord. This is the medial cord, and from the medial cord we have got subsequently 5 branches. How many branches? 5 branches. So if I talk about medial cord, it is forming the ulnar nerve. It is also forming the part of, this is the medial root of M for medial root of median nerve, and it is giving medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and one more nerve is there, that is medial pectoral nerve. So which nerve? Medial pectoral nerve. So basically this is fifth one, medial pectoral nerve. So that means basically if I am talking about the branches, this is the ulnar nerve. Okay, this is the ulnar nerve. This is the medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial root of median nerve, and medial pectoral nerve. All these are the branches from medial cord of brachial plexus. So actually why I have pointed out these branches in this image, so that if a image based question comes, you are able to identify the branches. So once more we will practice it. I have taken one blank image for you, and once more we will practice the labeling of this brachial plexus once I am finished with the story, where I will help you to understand the branches of different component of brachial plexus. So let's start with the story with the cords. So but firstly, directly posterior cord give 5 branches. Yes, lunar. Yes dear. So now right, yes Punit, you are right, but I will give you a different story for it. Okay. So firstly, before starting the story, please firstly write the branches of trunks and that of the branches of roots. So write down the heading branches from the roots of brachial plexus. Branches from the roots of brachial plexus. So the branches from the roots are long thoracic nerve. Long thoracic nerve. So when I am using the word long thoracic nerve, actually it is also called as, what is other name? It is also called as Bell's nerve. It is also called as nerve to serratus anterior. Nerve to serratus anterior. So it is nerve to serratus anterior, and the root value is C5, C6 and C7. What is the root value of this? What is the root value of long thoracic nerve? C5, C6 and C7. Now, the second is dorsal scapular nerve. The dorsal scapular nerve gives innervation to rhomboidus group of muscle, and the root value is C5. It gives in, so this is the long thoracic nerve. This is the dorsal scapular nerve. Yes, Punit, you are right. The dorsal scapular nerve will give innervation to rhomboidus muscle. Rhomboidus muscles. And if I talk about the branches from the trunk of brachial plexus, branches from the trunk of brachial plexus, so if I am talking about the branches from the trunk, branches from the roots of brachial plexus, these are the two important branches, but it also gives communicating branches to phrenic nerve, and it also gives branches to scalenus group of muscle, longus colli. So it is also giving branches to scalenus group of muscle and communicating branch to communicating branch to phrenic nerve. Now, before proceeding to the cords of brachial plexus, I just want you to give the branches from the trunk of brachial plexus. So write down branches from the trunk. So here the next topic will be branches. So we know that branches only is given from the upper trunk. So branches from upper trunk of brachial plexus. Branches from upper trunk of brachial plexus. So only the upper trunk is giving branches. Yes, dear Punit, you are absolutely right. The branches are, yes, Punit and Medico, both of you are right. The name of branches are nerve to subclavius Actually, nerve to subclavius sometimes can be given from the root of brachial plexus also. C5 and C6 is the root value. Dadagiri games. Okay. And the other is nerve, suprascapular nerve. Suprascapular nerve. And suprascapular nerves are also C5 and C6. Root value is C5 and C6. Got it? C5 and C6. Now done with this, now I would like to talk about the branches from the different chords of brachial. One by one we will go into the details of it. So firstly I would like to tell about the branches from the lateral chord of brachial plexus. So for this I would like to tell you a story. So previously, yes, previously the sessions are on the Unacademy platform, and also many other platforms are there where the session is there, and don't worry, on this platform also I will cover up the entire sessions. Okay. Now branches from the lateral chord of brachial plexus. When I am using this word branches from the lateral chord of brachial plexus, so for example you want leave, so you will apply medical leave. What you will do, you will apply a medical leave. So you will apply a medical leave of 2 days. Okay. For example, you want a break, you want to meet someone special at your place or someone special friend at your place. So you want to apply a leave. And generally, you know that medical leaves are approved. So you will not take a risk and you will apply a medical leave. Of how many days, dear? You will apply medical leaves of 2 days. You will apply medical leaves of 2 days. Okay. So you have applied a medical leave of 2 days. That means ML2. What does that means? That means ML2. So you have applied a medical leave of 2 days, that is ML2. That means the branches of lateral chord are M and 2L. 2L. So here M stands for musculocutaneous nerve. M stands for musculocutaneous nerve. C5, C6 and C7 is the root value. L stands for lateral pectoral nerve. Lateral pectoral nerve. Root value is C5, C6 and C7. And another L stands for lateral root of median nerve. Lateral root of median nerve. So here lateral root of median nerve is also having lateral root of median nerve is C5, C6 and C7. So lateral root of median nerve. So branches from lateral chord, we will have lateral root of median nerve. Medical leave 2. M for musculocutaneous nerve, L for lateral pectoral nerve, L for lateral root of median nerve, C5, C6 and C7. So that means medical leave 2, ML2 is the branches from lateral chord of brachial plexus. Medical leave 2. M for musculocutaneous nerve, L for lateral root of median nerve, L for lateral root of median nerve. So all these are the branches from the medial chord of lateral chord of brachial plexus. Now coming with the branches of posterior chord of brachial plexus. Branches from the posterior chord of brachial plexus. Now after you have applied a medical leave 2, you want to meet the special person at your place. So you have not done cleaning at your place. You have not done cleaning at your place. So you will go with the cleaning process. So when you are doing the cleaning process, what you find? You find rats in the upper and lower self. What you have found? You have found rats in the upper self and lower self. So next is rats. And when you did the cleaning process, you have found rats in the upper self and rats in the lower self. So that means we have got 5 branches from the posterior chord of brachial plexus, and these branches are R, A, T, S. R, A, T, S, upper and lower. So U and L. So here R stands for radial nerve. So I will just go with. So here R stands for radial nerve, A for axillary nerve, T for thoracodorsal nerve, thoracodorsal nerve, and upper and lower self means upper subscapular nerve, upper subscapular nerve, and the lower subscapular nerve, lower subscapular nerve. So we have got upper subscapular and we have got a lower subscapular nerve. So this is what? This is rats. This is rats in the upper self and the lower self. Got it? So these are the branches. So that means 5 branches is from the thoracodorsal nerve means nerve to latissimus. Yes, absolutely correct, Puneet. It is nerve to latissimus dorsi having the so very good. Yeah, it's nerve to latissimus dorsi having the root value of C6, C7, and C8. So I will write radial nerve root value C5, C6, C7, C8, and T1. It is the largest branch of brachial plexus. Axillary nerve C5 and C6 is the root value. Thoracodorsal nerve C6, C7, and C8 is the root value. Suprascapular nerve C5 and C6, no, upper subscapular and lower subscapular, both has got the root value of C5 and C6. So we have done with the branches of posterior cord. What remains is the branches from the medial cord. So let's talk about the branches from medial cord. So when I am talking about the branches of medial cord, after the cleaning process, so the cleaning process has been done, and after the cleaning process, so branches from medial causes. So if we talk about the branches of medial cord, so what is important for you to understand? So exactly if I talk about the branches of medial cord, you have to understand the branches of medial cord, and for if you have completed with the cleaning process of your room and you have found rats and you have cleaned up, you will meet that special persons, and then when you meet that special friend, you tell him or her made for you, M for you, me for you. So you will tell me for you. So that means there are 4M. That means there are 4M and there is 1 U. So that means there are 4M and there is 1 U. Me for you. Me for you. So there is 4M and there is 1 U. So here M stands for medial pectoral nerve. Medial pectoral nerve. Medial root of median nerve. Yes, yes, Medico, you are right. Yes, yes, you are right. Me for you. Medial root of median nerve. Medial root of medial cutaneous nerve of arm. Medial cutaneous nerve of arm. Medial cutaneous nerve of forearm. Medial cutaneous nerve of forearm. And ulnar nerve. And ulnar nerve. So medial pectoral nerve root value is C8 and T1. Medial root of median nerve is C8 and T1. Medial cutaneous nerve of arm is C8 and T1. Medial cutaneous nerve of forearm is C8 and T1. And ulnar nerve is C8 and T1, and in the bracket there is C7. And in the bracket there is C7. So these are all about the roots of medial cord of brachial plexus. So these are the details of the branches from the medial cord of brachial plexus which I have written. So we have done with this. Now we have done with, so all of you have done with the branches. Now next point is to know ops point. Everyone. Puneet, yes, we know that medial cord is formed from the anterior division only. So yes, these are the branches. Yeah. Yes, Punit. Yes, Punit. Now talking about orbs point. So actually, orbs point is the level of upper. So exactly so exactly if I talk about orbs point is exactly okay. Okay. So basically, if I am talking about orbs point, it is the level of. So basically, if I am talking about orbs point, it is the level of upper trunk of brachial plexus. So at the level of upper trunk of brachial plexus, we have got these structures. So that is important for you to understand. So write down orbs point where the six nerves meet. Orbs point is the point where six nerves meet. And this is at the level of upper trunk of brachial plexus. Upper trunk of brachial plexus. To make you understand, I will make orbs point. So basically, we know that this is C5 and C6, which will join to form the upper trunk. So it will join to form UT means upper trunk, and then again it will divide into anterior and posterior division. So here you can see. So this is division, this is division, this is the anterior division, and this is the posterior division. So basically, anterior upper trunk is again given in two branches, SS and NS. So basically, C5, C6, SS. What do you mean by the word SS? Suprascapular nerve. Suprascapular nerve. NS means nerve to subclavius, anterior and posterior division. So together there is how many? 1, 2, 3, 4, 5 and 6. Together we have got, so this point, so this point is called as, so this level of upper trunk is called as, so if we are talking about, wait a minute, so this is the upper trunk, this is the upper trunk. So basically this point, the level of upper trunk is the point where six nerves are meeting. How many nerves? Six nerves are meeting, so it is called as the orbs point. So it is called as orbs point. Got the concept? Now let's talk about the injuries of brachial plexus. So upper trunk of brachial plexus is injured. That injury is called as orbs Duchenne palsy. What is it called as? It is called as orbs Duchenne palsy. Wait, yes, Medico, you are absolutely right. Yes, dear, you are absolutely right. That is called as orbs Duchenne palsy. So when there is excessive, what is the reason of this palsy? When there is an excessive, so when there is an excessive increase in the angulation which is taking place between the head and the shoulder. So when there is an excessive increase in the angle which is formed between the head and the shoulder, that is called as birth injury. That will be that is the birth injury or fall on the shoulder. So you can see a difficult birth, vaginal delivery, or the person is falling from a height and landing onto the shoulder. So excessive increase is there in the angulation between head and the shoulder. So head and shoulder excessive angulation is there, and this will lead to birth injury or fall from a height and landed on the shoulder. This is called as orbs Duchenne paralysis, and the nerve roots which is involved in this case is C5 and C6. Which nerve root is involved? C5 and C6 nerve root is involved. And the presentation of the patient will be policeman tip deformity or waiter tip deformity. The presentation of the patient will be policeman tip deformity or waiter tip deformity, which is called orbs Duchenne paralysis. Now, it can be either birth injury, or it can be either due to fall on the shoulder. Now, the nerve roots which is basically involved is C5 and C6, which I have already written, and this is a case. Here, what you can see, this is the arm. The arm is hanging, the arm is by the side of the body. The arm is medially rotated and adducted, and this is the forearm. So what you can see in the forearm is pronated and extended. So in case of, yes, absolutely right, Punit, sign and symptoms of position of the limb. So you can write policeman tip deformity. So what are the presentation in the policeman tip deformity? So here in this case you can appreciate the arm. The arms hangs by the side, so it is medially rotated. The arm is medially rotated and in an adducted position. So it is medially rotated and in adducted position. What about forearm? So if I talk about the forearm is in extended position. It is extended and in pronated position. It is extended and in pronated position. So the baby and the acquired condition has been shown in this image. Now the next case is of lower trunk palsy. So when I am talking about lower trunk palsy, the site of injury is lower trunk. What is the level? What is the root value of lower trunk? Lower trunk root value is C8 and T1. So what is the root value? The root value is C8 and T1. The site of injury will be lower trunk, and the cords of brachial plexus which is involved is medial cord of brachial plexus. That means the muscles which is getting innervation from the root value C8 and T1 from the medial cord of brachial plexus branches will be involved, and also medial cutaneous nerve of arm and forearm will be involved. Now, the reason of the lower trunk brachial plexus is called as cervical rib. What do you mean by cervical rib? An extra rib. Generally, the ribs are in thoracic cage, but if there is an extra rib in the neck region, that is called a cervical rib. Undue abduction of the arm or birth injury in a difficult breech position or a hyperabduction of arm is done. Hyperabduction of the shoulder or arm is done. That will lead to Klumpke's paralysis. That condition will lead to Klumpke's paralysis. Okay. So lower trunk palsy with having the injury involving C8 and T1, medial cord of the brachial plexus is involved, which is causing injury to ulnar nerve, medial cutaneous nerve of arm and medial cutaneous nerve of forearm. Now, the patient will have, you can see this image where you can see the claw hand, medial two fingers are involved, and here actually T1, C8 and T1 is involved. T1 fibers, T1 nerve fibers are also carrying sympathetic fibers. So T1 nerve fibers are also carrying sympathetic fibers. So in case of Klumpke's paralysis, sympathetic fibers are involved, and basically the small muscles of the hand are involved, intrinsic muscles of the hand are involved. That will lead to the condition of claw hand. So the person will have claw hand mainly in the medial two fingers because only ulnar nerve is involved. Yes, the reason is hyperabduction of arm. Absolutely correct, Punit. And the patient will have Horner syndrome. The features of Horner syndrome will be partial ptosis because levator palpable superioris, smooth muscle is gone. Partial ptosis. What do you mean by the ptosis word? Ptosis means drooping of upper eyelid. Miosis means constriction of pupil. Anhidrosis means absence of sweating. And anophthalmos means sunken. Anophthalmos means sunken eyeball. Yes, claw hand means this. This is complete claw hand. And this is medial claw hand. So when I am talking about medial claw hand, what does that mean? There is hyperextension at the metacarpophalangeal joint and there is flexion at the interphalangeal joint. Yes, there is hyperextension at the metacarpophalangeal joint and there is extension at the interphalangeal joint. And this is just the reverse of the action of lumbrical muscles because lumbricals and interosseous muscles has been paralyzed. Okay. The person in the baby is also having ptosis, drooping of upper eyelid, constriction of pupil, anhidrosis, absence of sweating on the side involved, sunken eyeball, and these are the features of Horner syndrome in which sympathetic T1 fibers are involved. So Klumpke's paralysis is associated with Horner syndrome, but upper trunk brachial plexus or Erbs-Duchenne paralysis is not associated with the case of Horner syndrome. So these are the basic difference between upper trunk and the lower trunk palsy. Also, the mechanism of injury is different. In a lower trunk brachial plexus, the mechanism of injury will be fall from a height, and for saving yourself, you have holded a tree. In that case, hyperabduction of arm takes place, or a difficult birth injury in the extended breech position, cervical rib. The injury in case of upper trunk brachial plexus will be difficult vaginal delivery and somebody is fallen from a height and landed on shoulder and neck. So now we will solve few MCQ in which I will explain you the MCQs giving. So this is a clinical MCQ. So this is a clinical MCQ and an image based question. So you have to take proper time in making the right answer because till now I have not gone into the details of nerves. So, okay, if you are not able to solve also, please don't get worried because still I have to explain the nerves, important nerves in detail. So, let me read it. A 23-year-old, so yeah, a 23-year-old male is evaluated after sustaining a neck and shoulder injury. The nerve indicated by the blue arrow, as you can see on the illustration given below, is injured in the patient. Which of the following is most likely to be weakened as a result of injury? The option given is flexion of the hand is weakened, abduction of the fingers are involved, extension of the hand is involved, adduction of the thumb is involved, opposition of the thumb is involved. So I just want to enlarge this image. Take your time and identify the blue color arrow marked nerve. So this is an image of brachial plexus. This is an image of. So I just want everybody to understand the nerve or identify the nerve. So this image or this question is containing multiple questions. So first part is to identify the nerve. I have also taken a blank image of brachial plexus so that I can once again explain you all the branches of brachial plexus. So here you will get a time to identify the nerve. So the hint is, no, don't come to the answer first. First identify the nerve. So you can just see this. This is how the nerve is formed. This is how. So that means you have to identify this arrow marked nerve. These are the branches. So identify the blue arrow marked nerve. Which nerve is this? Which nerve this will be? This is showing the image of brachial plexus and you have to identify the nerve. See here. This is the hint of formation of the nerve. So which nerve is this? Everyone try to identify the nerve. Punit, Medico, Aradhana, Jayashree. So Jayashree has given her answer and a clap for Jayashree. She has given perfectly right answer. That is radial nerve. Absolutely great. Absolutely great. Radial nerve. Yes, absolutely great. Punit has also given a right answer, radial nerve, and radial nerve is the right answer. It is the largest branch of brachial plexus. And you can see this is the posterior division of all the three trunks. And as I told you, posterior division of all the three trunks leads to the formation of posterior cord. So this is posterior cord and this nerve is RN radial nerve. This will be axillary nerve. This will be upper subscapular. This will be lower subscapular and this will be thoracodorsal nerve. This will be thoracodorsal nerve. So in this image, the identification of the nerve is radial nerve. Now one part is done. Now the next is the answer. So radial nerve is basically giving innervation to extensor group of muscle. So can you tell me what will be the right answer? Which part will be weakened in the injury of the arrow marked nerve? Whether it is flexion, whether it is abduction, extension, adduction, opposition. Punit, Jayashree, absolutely correct. A very tough question has been solved by you and it's a very good answer. It was image based question. It was a mixture of image and clinical question and both of you have given a perfectly right answer, extension of hand. Everyone, have you understood? Just you have to pay attention to the image and for everyone, don't worry if anyone other has not answered it correctly. I will once again explain for them so that if an image based question comes, the identification of the nerves will be done clearly. So I think formation of brachial plexus is already known to you. I am not going into the repetition of this. We know that posterior cord is formed by all the posterior division of all the three trunks. Lateral cord is by the anterior division of upper and middle trunk. Medial cord is by anterior division of the lower trunk. Now, basically, I will take this image. So basically, I will take this image. Why I will take this image? Because this is a blank image in which I want everybody to understand the important branches of brachial plexus. Okay, I will write. So basically, this is C5. This is C6. Okay, so this is C5. This is C6. This is C7, this is C8 and T1. So that means this part is the roots. So this part is the roots of brachial plexus. So this will be which nerve? This is DS, and this will be which nerve? This is LTN, LTN. So what means D? So that means two branches of the roots has been shown to you. Two branches of the root has been shown to you. DS means dorsal scapular nerve. So what do you understand by DS? DS means dorsal scapular nerve, and LTN means long thoracic nerve. Okay. So if you want the full form, DS means dorsal scapular nerve, LTN means long thoracic nerve. Okay. Now coming to this point, so this is the upper trunk. Which trunk is this? This is the UT, upper trunk. So from upper trunk we have got two branches, SS and NS. SS and NS. So here SS stands for suprascapular nerve and NS stands for nerve to subclavius. Nerve to subclavius. NS stands for nerve to subclavius. Nerve to subclavius. Got it? Everyone, is it okay? Is it okay? Now, as I told you, now what I have told you here, this is the lateral cord. What is it? This is the lateral cord of brachial plexus, and the lateral cord of brachial plexus has been shown. So this nerve will be lateral pectoral nerve. This nerve will be musculocutaneous nerve. So this is the musculocutaneous nerve. So this is LPN, lateral pectoral nerve, musculocutaneous, and this is the lateral root of median nerve. So that means this is the third branch. So we have got all the three branches from lateral cord. So I'm just enlarging this. Now we have got all the three branches from the lateral cord. What remains is the, so now we will talk about the posterior cord. So when I am talking of the posterior cord, this is the posterior cord which is formed by taking the posterior root of all the three trunks. And we have got 5 branches from the posterior cord. How many branches? 5 branches. So this is AN, axillary nerve. This is radial nerve. This is LS. This is US, and this is thoracodorsal nerve. So how many branches? We have got 5 branches from the posterior cord of brachial plexus, and coming to the medial cord. So this is the medial cord of brachial plexus, and when we are talking of the medial cord of brachial plexus, again we have got 5 branches from the medial cord of brachial plexus. So these are this is medial root of median nerve. This is medial root of median nerve as the first branch. Okay, this is ulnar nerve, second branch we can say. This is LPN, this is MPN, that is medial pectoral nerve, and these two are medial cutaneous nerve of arm and forearm. So it is medial cutaneous nerve of arm, and this is medial cutaneous nerve of forearm. Medial cutaneous nerve of forearm. So this is 4th and 5th. So how many branches? We have got 5 branches. So we have got 5 branches from the, medial cord also. So basically you have to practice this. So again you can practice all the branches from this blank image. Already I have shown you the important branches and I have explained the important branches in this image. So I think it will be easy for you to identify all the branches. So this is how you are going to practice it. Now, if we are talking about the direct answer, that was radial nerve. We know that radial nerve gives innervation to all the extensor group of muscle. So definitely the extension will be affected in this condition. So let me tell why the other options are not correct. Flexion of hand is not the correct answer because flexion of the hand is not the function of radial nerve. For it, the ulnar nerve and median nerve is involved. For it, the median nerve or the ulnar nerve is involved. Abduction of fingers. Abduction of fingers is also not important because adduction of thumb is by ulnar nerve, apposition of thumb is by median nerve, and abduction of the fingers will also affecting the ulnar nerve, median nerve. Extension of hand is the right answer. The reason is that because it is affected in case of radial nerve. Understood everyone? Let's move on to the next question. Explanation is given nicely. You can just go through all the options like E is not the right answer because most reliable sign of median nerve injury is abduction and opposition of thumb. Damage to deep branch of ulnar nerve will affect the adductor pollicis muscle and then the adduction is lost. Damage of recurrent branch of median nerve and ulnar nerve will affect the position of abduction of the fingers, and damage of median nerve will affect in the pointing finger and carpal tunnel syndrome. So we have got the right answer as the radial nerve, which will affect the extension of the fingers and elbow. Next question, all of you please take your time and give me the right answer. It's also a clinical question. A 2-year-old boy falls from a tree. So you have to identify the mechanism of injury and then give me the right answer. Falls from a tree, climbing but catch himself on a branch of tree. He swings his hand, right arm and jumps to the ground. Several hours he presented to emergency room with the hand clumsiness. Which of the following is most likely injured in this case? Axillary nerve, radial nerve, musculocutaneous nerve, long thoracic nerve or brachial plexus lower trunk or brachial plexus lower trunk. So please mark the right answer. So I have received an answer from Jasri. What about others? Medico is also telling E. So if anyone falls from a height and to save himself or herself, they will just catch hold of a tree. Then in that case, there is hyperabduction of arm. There is hyperabduction of arm and the shoulder. And due to hyperabduction of arm and shoulder, the patient will have Klumpke's paralysis, injury to the lower trunk brachial plexus. So definitely the right answer is E. So Medico and Jayashree, both of you have given right answer. A thumbs up goes for you and you are right. Yes, definitely the right answer is brachial plexus of the lower trunk. So axillary nerve, yes, Medico, you're right. Axillary nerve is not the right answer because if axillary nerve is injured, deltoid muscle will be injured. Radial nerve is not the right answer because in that case, extensor group of muscles will be injured. Musculocutaneous is not the right answer because in that case, BBC is involved. What is BBC? Biceps brachii, brachialis and coracobrachialis. Musculocutaneous nerve is the nerve of anterior aspect of arm and three muscles in the anterior front aspect of arm. Brachialis, biceps brachii and musculocutaneous and that of coracobrachialis will be injured. Long thoracic nerve is also not the right answer because it gives innervation to serratus anterior muscle. So the right answer is the lower trunk of brachial plexus involving C8 and T1 nerve root causing Klumpke's paralysis. So the key word, so the important words which you have to focus here. So how you are going to approach for the right answer is that you have to concentrate on the keywords which is given. The hint is already given in the MCQ, that is fall from a tree and catch himself on holding a branch of tree and there is clumsiness of the hand. So that means this is the mechanism of injury of lower trunk of brachial plexus. So this is mechanism of injury of lower trunk of brachial plexus. So this is mechanism of injury of lower trunk of brachial plexus. Okay, now the cause of injury will be birth injury, Klumpke's paralysis, cervical rib. So the cause of injury is an extra rib in the cervical region, Klumpke's paralysis. Birth injury also when anybody falls from a height and to save himself or herself catch hold of a tree. So in case of elevated cervical rib, what will happen? Also the subclavian vessels and lower trunk of brachial plexus can be injured. So undue hyperabduction of arms is the reason of lower trunk brachial plexus injury. So the mechanism of injury, I want you to show this images. So if you see these images, you can understand the three reasons or mechanism of injury of lower trunk brachial plexus. So please concentrate on this. The lesion of brachial plex lower trunk. The lower trunk brachial plex injury will be via these three. So this is the case of hyperabduction of arm, and to save himself or herself, catch hold of a tree. Cervical rib is the other, and the difficult vaginal breech delivery is the other reason of Klumpke's or lower trunk paralysis. Now, as I told you, the major nerve which is injured in case of Klumpke's or lower trunk brachial plexus is mainly C8 and T1, and we know that ulnar nerve is also having the root value C8 and T1, taking also contribution from C7. That means all the muscles which is innervated by ulnar nerve is paralyzed. So when I am using this term, all the muscles which will be paralyzed will be the intrinsic muscles of the hand. So all the intrinsic muscles of the hand will be paralyzed. Also, the ulnar flexors of the wrist and fingers will be paralyzed. So ulnar nerve lead to the paralysis of intrinsic muscles of the hand, the ulnar flexors of the wrist and fingers. Medico, treatment of the regeneration of the nerve. Okay, so we have got, exactly we will try to regenerate the nerves. So basically full recovery is not there, but physiotherapy. So that also depends on the treatment, like physical therapies, topical ointments, पेन के लिए एनसेट्स दे सकते हैं. सर्जरी इज नीडेड फॉर सीवियर केसेस. सो नर्व ग्राफ्टिंग कैन बी डन. वी वांट टू रीजनरेट, सो नर्व ग्राफ्टिंग कैन बी डन. Physiotherapy can be done, conservative treatments can be done, and for severe injuries we will go for surgical repair or surgeries, and nerve grafting will be done. Okay, medico. So in low grade injury we can just go for conservative treatments, physiotherapy and medicines, but if the injury is much more and the nerve is totally not working, then we will go for surgical repair of the nerve, and nerve can be we will take grafting, the nerve graft can be done. Now the patient will have claw hand, and mainly the medial two fingers are affected. As I told you, why medial two fingers? Because ulnar nerve is giving innervation to medial part of flexor digitorum profundus. So only mainly the medial two lumbricals and medial part of flexor digitorum profundus muscle is involved. So that means muscles, all the muscles will be involved. If I am talking about all the muscles will be involved, but basically the muscles which will be involved will be the intrinsic muscles of the hand, and other than that we will also have the involvement of medial part of flexor digitorum profundus, lumbricals medial, that is third and fourth, and interosseous muscles. Now in this case the patient will have foment sign positive. What do you mean by foment sign positive? Now flexion of distal phalanx. So exactly what happens will, for example, I will explain you this. For example, if I will tell you to hold this between your thumb and index finger, you can hold it like this. So I can hold it like this. So for holding a block or a piece of paper, you will keep your thumb adducted. So you will keep your thumb adducted and you can hold it like this. But if the adduction of thumb is not possible, why adduction of thumb is not possible? Because adductor pollicis is supplied by ulnar nerve, and in case of lower trunk brachial plexi, ulnar nerve is injured. That means ulnar nerve is not working, and adductor pollicis means thumb, and adductor pollicis means the muscle responsible for adduction of thumb is not working. So foment sign will positive. And in this case, if you tell the patient to hold this block of piece of paper or block of structure, he or she will hold it by flexing the thumb. So he or she will hold it, this structure, by flexing the thumb, and flexion of thumb is done by flexor pollicis longus. That means adduction is not possible, and foment sign is testing the integrity of the muscle. The name of the muscle is adductor pollicis. Now here adductor pollicis is not working, and to perform the action of holding the piece of paper or block, the adduction is not possible. So the thumb flexor pollicis, that is flexion of thumb, is active, and the structure which will be paralyzed is adductor pollicis. So you can also see Klumpke's features. In this case, you can see the medial fingers are involved, medial two fingers are involved because ulnar nerve is injured, and only the medial part of lumbricals and medial part of FDP and all interosseous muscles are involved. Other than that, you can see the patient will have foment sign positive in case of Klumpke's paralysis. Now, when you see the dorsal aspect of the hand, as shown in this, so you can see in this case also. So, when you see the dorsal aspect, what you can appreciate that the interossei muscles, so there is loss of interossei muscles. So, we know that in between the metacarpal, here there is interossei muscle, so that will be atrophied. So, there will be atrophy of dorsal interossei muscle. So, we know that palmar and dorsal interossei both are supplied by ulnar nerve. So, if ulnar nerve is injured, there will be atrophy of interossei muscle, Klumpke's paralysis is there, and also as I told you, there will be, so basically for adduction of thumb is not involved, but flexion can be done. So, you can see flexion can be done by flexor pollicis longus. So, Foreman sign is positive in case of Klumpke's paralysis. So, these are the features of Klumpke's paralysis. Now, other than that, other feature is Horner syndrome. As I told you, T1 nerve roots are involved. So, as I told you, T1 nerve roots are involved, C8 and T1. So, basically T1 nerve roots are involved, and we know that T1 nerve root is carrying sympathetic fibers, so the patient will have Horner syndrome. So, you can see the baby is having Horner syndrome. Ptosis means paralysis of levator palpebral superioris muscle, drooping of upper eyelid. Meiosis means constriction of pupil, and hydrosis means absence of sweating. Anophthalmos means sunken eyeball. There is disruption of the fibers traversing from head and neck region. Via which nerve? Via T1 nerve, that is the first thoracic nerve. Also, the lesion of brachial plexus, you can see the here, this is the obs-Duchenne paralysis. So, this is showing you the upper trunk palsy, and the reason of upper trunk palsy is excessive. So, you can see in this patient there is excessive neck and shoulder. So, you can see there is excessive suppression. So, so in the case of upper trunk brachial palsy, there is excessive suppression of head and neck during the birth, vaginal birth delivery, and if excessive suppression of head and neck is done, there can be injury of upper trunk brachial plexus. And the injury is at the level of orbs point. And we know that orbs point, how many nerves? The C is suprascapular nerve, D is nerve to subclavius, and this is C5. This is anterior and posterior division. This is anterior division, and this is posterior division. So, basically 6 nerves are meeting at this position, and these 6 nerves are involved in the lesion of upper trunk brachial palsy. Now, this is how the patient hand is hanging by the side. The patient is not able, so you can see the baby, it feels like someone is asking money from behind. So, it's like this. Okay, someone is asking money from behind. So, you can see the arm is adducted, medially rotated, and forearm is pronated and extended. Arm is adducted, medially rotated and adducted. Arm is medially rotated and adducted, and forearm is pronated and extended. And this position is called as waiter tip deformity, policeman tip deformity. Lesions of upper trunk brachial plexus is the patient will not have any kind of abduction movement, no lateral rotation, no flexion, and no supination. The waiter tip or policeman tip deformity is the lesion which is seen in upper trunk brachial plexus. Now, other options. So, actually we have done with this MCQ, and as I already told you before proceeding to the next topic, axillary nerve is not the right answer. Why? Because axillary nerve is giving innervation to which muscle? Deltoid muscle. And basically when deltoid muscle is injured, only abduction of arm from 15 to 90 degrees involved. Wrist drop is also was not complained in this MCQ, and wrist drop is seen in the case of radial nerve injury. Musculocutaneous nerve is not the right answer because it gives innervation to BBC, biceps brachii, brachialis, and coracobrachialis. Musculocutaneous nerve is not the right answer because it will also give innervation to muscles of anterior aspect of arm. Now, in case if there is a lesion of musculocutaneous nerve, basically the 3 muscles will be paralyzed. Which 3 muscles will be paralyzed? Just giving you an introduction of musculocutaneous nerve being involved. Musculocutaneous nerve is a branch of lateral cord of brachial plexus, and the 3 muscle which will be paralyzed is the muscle of anterior aspect of arm, that is BBC, biceps brachii, brachialis, and coracobrachialis. Now, musculocutaneous nerve gives one cutaneous branch, that is lateral cutaneous nerve of arm. Lateral cutaneous nerve of forearms. That means in case of injury of musculocutaneous nerve, the lateral cutaneous nerve of forearm will also be injured, and such kind of history was not given in this question, so it is also not the right answer. Long thoracic nerve is giving innervation to which muscle? Serratus anterior muscle. And when serratus anterior muscle is involved, you can see this is a condition of winging of scapula. So the patient will have winging of scapula because the protraction action of the scapula is not able to be performed. Nerves of bell is the other name, and we know that winging of scapula, prominence of the medial border of scapula is seen, and when you ask the patient to push against the wall, the medial border of the scapula is outward projected, and that condition is called as winging of scapula. Winging of scapula. Now, if there is suprascapular, I am just giving you few small nerves injury. If the suprascapular nerve is injured, suprascapular nerve root value is C5 and C6, and we know that suprascapular nerve innervates two muscles, supraspinatus and infraspinatus. Suprascapular nerve innervates two muscles, supraspinatus and infraspinatus, and we know that supraspinatus is causing abduction of arm from 0 to 15 degree. Infraspinatus is causing lateral rotation of arm. Okay, and supraspinatus is causing abduction of arm. Abduction of arm 0 to 15 degree. That means this function will be involved. That means abduction of arm and lateral rotation of arm will be affected if suprascapular nerve is injured, because two muscle is paralyzed, supraspinatus and infraspinatus. The action of supraspinatus, that is initiation of abduction, will be not able to be performed, and infraspinatus is causing lateral rotation of arm and shoulder. Axillary nerve is giving innervation to, if I talk about axillary nerve, it is giving innervation to two muscles. So axillary nerve is giving innervation. Axillary nerve, again the root value is C5 and C6, and it is giving innervation to deltoid muscle, and it is giving innervation to teres minor muscle. So that means the action which will lost in this condition is deltoid muscle is causing abduction of arm, and we know that abduction of arm which will be involved in this condition will be from 15 degree to 90 degree, and teres minor is causing lateral rotation of arm. So such kind of loss of function was not presented in this case, so definitely axillary nerve is not the right answer. Other than that, axillary nerve is also giving one cutaneous branch which is giving innervation to, so sensory, we know that it also gives upper lateral cutaneous distribution on the upper lateral aspect of the arm. So sensory innervation on the deltoid area or upper cutaneous nerve of arm will be affected. So sensory innervation on upper lateral aspect of arm will be also affected in this condition. So such kind of history was not performed, so axillary nerve is also not injured in this case. So basically we have talked about all the important branches of brachial plexus nerves and their injury. Next, so if you have got any doubt, please let me know. Next is to know three nerves. So after this we will study three nerves in detail, that is ulnar, medial and radial. So we will see the details of these three nerves. Why? Because these three nerves are very important. All the other nerves like long thoracic nerve, musculocutaneous nerve, axillary nerve, suprascapular nerve and many other important nerves we have already discussed in brief, but I want that we should have a detailed description of three important nerve, radial, medial and ulnar nerve, because so many MCQs has been asked from this topic. So yes, my dear students, I will, if you want any questions to be arise, please let me know. I will take a break of 10 minutes and then again we will start the session. Is it okay? Till now you have got any doubt? So basically we have covered till now axilla, axillary lymph nodes, axillary artery, the contents of the axilla. We have finished with the topic of scapular anastomosis. We have finished with the topic of branches of brachial artery, profunda brachii artery. The scapular spaces, quadrangular, lower and upper triangular spaces. We have finished with the topic of brachial plex, their branches, and also we have finished with the topic of brachial plex injuries. So next topic will be the detailed description of median, ulnar and radial nerve. Then we will have the description of few important anatomical region and the joints of upper limb. And lastly, I will also tell about the muscles of upper limb. Is it okay? Can we take a break of 10 minutes, 5 to 10 minutes? Okay, Everyone, do let me know. So I am giving you a break. Okay, dear? Okay, Jayashree, okay, Medico. So we will have just a break of 5 to 10 minutes. Okay? Thank you. Okay, so we can start the session now. Am I audible? Let me just check. I will just check. Okay, so we can start the session now. Here we have already covered up the important brachial plexus is branches and all. The next thing which we have to start here is the nerve. So we will talk about the nerves now. Okay. So the most important first nerve, so I told you three nerves are there which we have to know detail about this. So we have to know about the detail of these three nerves. So I would like to start with the ulnar nerve first. So let's talk about the ulnar nerve. The ulnar nerve is, so if I talk about ulnar nerve formation is, it is a branch from medial cord of brachial plexus. Ulnar nerve is a branch from medial cord of brachial plexus and its root value is C8 and T1. So what is the root value of ulnar nerve? It is just C8 and T1 and it is also called as Mugician nerve. It is also called as the Mugician nerve. So ulnar nerve root value is C8 and T1, and as the ulnar nerve gives innervation to intrinsic muscles of the hand, so it is particularly giving innervation to intrinsic muscles of the hand, the small muscles of the hand. So these small muscles are involved in activities of the function, like I am writing, we can play the music, all these are the function which is performed with the ulnar nerve. So it is called as the Mugician nerve. Now, so here this is the brachial plexus. Here this is the brachial plexus, and here if you will see the medial cord, this is the medial cord of brachial plexus. Here you can see the ulnar nerve. So this is the medial cord of brachial plexus. Here you can see the ulnar nerve. So what is it? This is the ulnar nerve. So basically in this diagram you can clear with that the medial cord branch is the ulnar nerve having the root value C8 and T1. Now let's talk about the course of the course of the ulnar nerve in different parts. So I would like to tell the course of the ulnar nerve firstly in the axilla. So we have already discussed that the cords of brachial plexus are formed in the axilla. That means ulnar nerve will be formed in the axilla, and thereafter it will run on the medial side of the axillary artery, and it will traverse in between the axillary artery and vein. So the formation of the cords of brachial plexus takes place in the axilla. So the branches of the cords of brachial plexus will also lie in the axilla. In the axilla, the ulnar nerve runs on the medial side of axillary. What is the course? It will run on the medial aspect of, it is running on the medial side of axillary artery. So it is running on the medial side of axillary artery, and the exact location will be in between the axillary artery and axillary vein. So here we can see the ulnar nerve. This is basically in relation to, this is the axillary artery, A for axillary artery, and it is running medial to the axillary artery. Thereafter, the course is in the arm. So in the arm, the ulnar nerve is located, and in the arm, the ulnar nerve is running medial to brachial artery. So in the axilla, the artery is axillary artery, and when the axillary artery reaches the level of lower border of teres major, it changes its name to brachial artery, which we have already discussed. So that means if I have to further tell about the course of ulnar nerve, so definitely here if I have to tell the course, I will tell that it is running medial to the brachial artery. It pierces the intermuscular septum and enters the posterior compartment. So it pierces the intermuscular septum, and thereafter from the anterior aspect of the arm, now the ulnar nerve is reaching on which aspect of the arm? It is reaching in the posterior compartment of the arm. So it is reaching in the posterior compartment of the arm. So first is formation in the axilla, then traversing medial to axillary artery, then traversing medial to brachial artery, piercing the intermuscular septa, and from anterior aspect of the arm, it reaches the posterior compartment of the arm. So same thing I want to show here. So here in this diagram, you can see this is the ulnar nerve. And here you can see this is the intermuscular septum, medial intermuscular septum. So here you can see this is the medial intermuscular septum, which has been pierced by ulnar nerve. So from anterior aspect of arm, now ulnar nerve is traversing to the posterior aspect of the arm. Now in the posterior, so this is an image of posterior aspect of the arm. So I would like to show the posterior aspect of the arm, where you can see the ulnar nerve is traversing posteriorly, and it is traversing posterior to medial epicondyle of the humerus. It is traversing posterior to medial epicondyle of the humerus. To be more specific, this is medial epicondyle, and this is O for the olecranon process of ulna. So this is O for the olecranon process of ulna. So this is O for the olecranon process. So definitely ulnar nerve is traversing here. If you will see, this is the ulnar nerve. It is traversing definitely between. So definitely it is traversing between the. So basically, if we talk about ulnar nerve, it is traversing between. This is the ulnar nerve, and definitely it is traversing between the olecranon process. It is traversing between the olecranon process and that of medial epicondyle of humerus bone. So done. Now it will reach the elbow, and when I am talking about the relation of ulnar nerve in the elbow, the exact location will be in a groove which is on the dorsal aspect of medial epicondyle, and the exact location of ulnar nerve at this location, it will be intervening between the medial epicondyle and olecranon process. So the location of ulnar nerve will be in between the medial epicondyle and olecranon process of the ulna. Okay, between the medial epicondyle and olecranon process of the ulna. Now I will show you this diagram where you can see the ulnar nerve. So this is the ulnar nerve. And exactly the ulnar nerve location will be going more medially in relation to flexor carpi ulnaris. So it will give innervation to one of the forearm muscle, that is flexor carpi ulnaris. Actually, ulnar nerve is traversing posterior to medial epicondyle in between medial epicondyle and olecranon process, and from the medial aspect of the forearm, it gives innervation to medial part of flexor digitorum profundus and also the flexor carpi ulnaris, two muscles. It will traverse between two heads of flexor carpi ulnaris. So if I have to talk about the further course of the ulnar nerve in the forearm, it is passing between the humeral and the ulnar head. So it is passing between. So if I talk about ulnar nerve, the ulnar nerve is passing between humeral and ulnar head of flexor carpi ulnaris. So what is the course? It is passing between the humeral and the ulnar head of flexor carpi ulnaris. It lies superficial to posterior and oblique part of ulnar collateral ligament of elbow joint, and thereafter it runs downwards in the medial side of forearm. So to elaborate and to tell about entire course of ulnar nerve gives innervation to flexor carpi ulnaris, and in its course it is traversing between the two heads of flexor carpi ulnaris, the humeral and ulnar head. It lies superficial to the posterior and oblique part of ulnar collateral ligament, and thereafter it runs downwards on the medial side of forearm. Now talking about forearm ulnar nerve. So this is the ulnar nerve. And here in this diagram, what I want everyone to understand is that this nerve is passing between two heads of flexor. It is passing between ulnar nerve is traversing behind medial epicondyle, and it will pass between two heads of flexor carpi ulnaris. So we have got two heads. So this is H. This is the humeral head of flexor carpi ulnaris, and this is U. That is ulnar head of flexor carpi ulnaris. So in this diagram, what you can appreciate, Ulnar nerve is exactly traversing between the two heads of flexor carpi ulnaris. Now further, if you will see the further course of ulnar nerve, it rests. The further course of ulnar nerve, if you will see, it rests on FDP. What is the full form of FDP? FDP means flexor digitorum profundus. FDP means flexor digitorum profundus muscle. Flexor digitorum profundus muscle. And FCU means flexor carpi ulnaris. FCU means flexor carpi ulnaris muscle. So it is resting on FDP under the cover of FCU, and ulnar artery in this location lies radial to ulnar nerve. So when I am using this word, that means the ulnar artery and ulnar nerve both are traversing, but in the forearm, if we will see the relation of ulnar nerve and ulnar artery, the ulnar artery is lying lateral to the ulnar nerve, and thereafter it gives palmar, cutaneous and the dorsal branches. So here in this diagram, you can clearly see this is the ulnar nerve. And it's you can see here the ulnar nerve is passing here in the FDP muscle medially. Now talking about further course, and it reaches the wrist. When it reaches the wrist, it enters the palm by passing over flexor retinaculum. So ulnar nerve enters the palm by passing over flexor retinaculum. Ulnar nerve lies lateral to pisiform and it is located medial to hook of hamate. Ulnar artery is located lateral to ulnar nerve, and thereafter it traverses into the Guyon's canal. It traverses into the Guyon's canal. So if I talk about ulnar nerve, which is located medial to ulnar artery, it will pass superficial to flexor retinaculum. Ulnar nerve and artery will traverse in the wrist in Guyon's canal. What is Guyon's canal? Guyon's canal is bounded by two bones. It is bounded by a pisiform bone on the lateral aspect, hook of hamate on the medial aspect, and it is covered by a superficial slip of flexor retinaculum that is called as volar carpal ligament, and it is located superficial to flexor retinaculum. So this is whole details of Guyon's canal. So I just want everybody to see this Guyon's canal so that you can understand. So we are talking about which canal? We are talking about Guyon's canal. This is Guyon's canal. So in the Guyon's canal, we have got ulnar nerve and we have got ulnar artery. Okay. Now the bound. So here you can understand here. This is superficial slip of flexor retinaculum and this is flexor retinaculum. So basically here you can see this area is Guyon's canal in which ulnar nerve resides, in which ulnar artery resides. So to understand this, you can see this is the ulnar nerve and this is the ulnar artery. So in Guyon's canal, we have got, ma'am, image is not clear. So what about others? Actually, Aradhana, what about others? Is the image clear? It's very clear, I think. I can clearly see in my. So I think you have to check your net connection, dear. What about Medico? What about Jayasri? What about Punit? Can you see this image clearly? I can see this image very clearly in my phone also. It's very clear. So it's very clear here. Clear. So Jayasri is telling clear. I think please Aradhana. Jayasri is telling clear. So Aradhana, you have to check your internet or your device which you are using. No, there must be some setting has to be done, because it's very clear on my phone also. It's very clear on my phone also. When I check my phone, it's quite clear. Okay. Okay. Now the ulnar canal is also called as, the ulnar canal is also called as ulnar tunnel or Guyon's canal, and it is a semi-longitudinal canal which allows the passage of ulnar nerve and ulnar artery into the hand. So it is forming a passage for ulnar nerve and ulnar artery to traverse into the hands. So I just want everybody to understand The roof of ulnar Guyon's canal is formed by superficial palmar ligament, that is the other name of flexor retinaculum. That is, superficial palmar ligament is actually the extension from flexor retinaculum. On deeper aspect flexor retinaculum, the space is bounded medially by pisiform and pisohamate ligament and laterally by hook of hamate. So it is a space which is bounded by hook of hamate and pisiform bone. So we have got lateral boundary, hook of hamate, and we have got medially, and more onto the proximal aspect we have got pisiform bone. It is approximately 4 centimeter long, and this is the course. So I just want everybody, so again see here this image. So yes, Aradhana, can you see this image clearly? Can you see this image clearly? Please let me know. So I can see this image clearly in my phone, so I am asking. So here you can see this is the, so for your understanding I am just showing you, this is the flexor retinaculum. This is the flexor retinaculum. Okay, this is the flexor retinaculum. So basically here we have got the flexor retinaculum. Okay, this is the FR means flexor retinaculum. So ulnar nerve is passing superficial. So here you can see, and the superficial slip. So I will use another color for the superficial slip. So this is the superficial slip of flexor retinaculum, which is called as volar carpal ligament. So this structure which you are seeing here is the superficial slip of volar carpal ligament. So this is volar carpal ligament. So this is the volar carpal ligament. So exactly, and we can see the pisiform bone medially and the hook of hamate laterally. So we can see the pisiform bone medially and the hook of hamate laterally. So this is the boundary of Guyon's canal. This is the boundary of Guyon's canal. So is it okay, Aradhana? Now you have knowing the Guyon's canal. So if you want, I will write it for you. So write down Guyon's canal. Guyon's canal. So when I'm talking about Guyon's canal, it is boundaries is important to know, boundaries. So if I talk about Guyon's canal's boundary, so you can write medially, it is bounded by okay, okay, Aradhana, now the image is sometimes fluctuation of net source must be there, no, so that it takes time to get cleared up. So you should check your net connection also. So medially it is bounded and laterally. Pisiform bone, pisohamate ligament. Laterally, hook of hamate. Superficially, flexor retinaculum. And deeper aspect, deep aspect there is, no, so exactly deeper aspect is the flexor retinaculum. So just a minute. Deeper aspect, there is flexor retinaculum, and superficially there is superficial slip off, superficially bounded by superficial slip off flexor retinaculum, termed as volar carpal ligament, volar carpal ligament, termed as volar carpal ligament. Okay, so that is termed as volar carpal ligament. So this is the details of Guyon's canal. It's already written, but I have given you the full details so that you will not get confused. Now, done with this. Now, terminal branches. Now we will talk about the terminal branches. So the terminal branches of ulnar nerve is, it divides into superficial, it divides into superficial and deep branches when it reaches the proximal part of hypothenar eminences. So when it reaches the proximal aspect of hypothenar eminences, there it divides into superficial and deep branch. Where it divides into superficial and that of deep branch. So here you can see the ulnar nerve and the ulnar artery. So this is the ulnar nerve and this is the ulnar artery. So you can clearly appreciate in this diagram, if I just enlarge this, this ulnar nerve is lying more medially and the ulnar artery is laterally, and you can see here in this diagram, this is the flexor retinaculum. So this is the flexor retinaculum. So it is running superficial to flexor retinaculum, but it will be covered by a superficial slip. So this is flexor retinaculum, but it will be covered by superficial slip of flexor retinaculum, and it will give innervation to medial aspect of 1.5 of the fingers on the palmar aspect, and it will also give innervation to the dorsal aspect. Okay. So now I would like to show you and tell you about the important branches the ulnar nerve is giving. So important branches the ulnar nerve is giving in the arm. So it is giving no branch in the arm and the axilla. It gives innervation to two muscles of forearm, that is flexor carpi radialis, flexor carpi ulnaris and the medial part of flexor digitorum profundus, and basically many muscles of the hand. So many short muscles of the hand, intrinsic muscles of the hand is getting innervated from the ulnar nerve. So I would like to write the list for you. So please write on the list branches of ulnar nerve. Branches of ulnar nerve. Ulnar nerve gives no branches in the arm and axilla. It is giving no branches in the arm and the axilla. Ulnar nerve innervates two muscles of forearm. That is anterior aspect. Two muscles of forearm on the anterior aspect, and the name of muscle is, what is that muscle called as? The name of that muscle is, so the name of that muscle is flexor carpi ulnaris. Is the flexor carpi. The name of that muscle is flexor carpi ulnaris and flexor digitorum profundus and flexor digitorum profundus. So if I talk about flexor digitorum profundus, it is mainly giving innervation to medial part of flexor digitorum profundus. It is mainly giving innervation to medial part of flexor digitorum profundus. It is mainly giving innervation to medial part of flexor digitorum profundus. Now talking about ulnar nerve distribution in the hand. So let's talk about that. Branches of ulnar nerves in the hand. So branches of ulnar nerve in hand. So what I told you, in hand, basically it is giving innervation to important muscles, important intrinsic muscles of the hand. So the first group of muscles being innervated is hypothenar muscles. Muscles of hypothenar eminences, so hypothenar muscles. And in this category, it is giving innervation to three muscles. And what are these three muscles? These three muscles are abductor digiti minimi muscle, abductor digiti minimi muscle, abductor digiti minimi. When I am using the word abductor digiti minimi muscle, what does that mean? That means the muscle in the medial aspect. Abductor digiti minimi muscle, flexor digiti minimi muscle, flexor digiti minimi muscle, flexor digiti minimi muscle, and opponents opponens digiti minimi muscle. Okay, so these are the three hypothenar muscles. So these are the three hypothenar muscles. So these are the three hypothenar muscle list. These are the three hypothenar muscles. These are the three hypothenar muscles which is in the list of hypothenar group. And the other is adductor pollicis muscle. Adductor pollicis muscle of the thenar region. It also gives innervation to all the palmar interossei muscle. It also gives innervation to all the dorsal interossei muscle. And other than that, it also gives, fifth point, other than that, it also gives innervation to lumbrical muscles. It also gives innervation to medial lumbrical muscles. Medial lumbrical muscles. So medial lumbrical muscles means third and fourth lumbrical muscle, and it also gives innervation to one of a muscle which is lying in the superficial fascia, that is palmaris brevis muscle. That is palmaris brevis muscle. So all these muscles, all these important, so that means basically many important muscles or many smaller muscles of the hand region, many small intrinsic muscles of the hand region is getting innervation from the branches of ulnar nerve. It is giving innervation to hypothenar group of muscle. It is giving innervation to that of adductor pollicis muscle. It is giving innervation to palmar and dorsal interossei muscle. It is giving innervation to medial lumbrical muscle and palmaris brevis muscle. So done with this. Now we will talk about cutaneous branches of ulnar nerve. Now we will talk about cutaneous branches of ulnar nerve. Now in this diagram you can see the cutaneous distribution of ulnar nerve. In this diagram you can see cutaneous distribution of ulnar nerve. So if I am talking about cutaneous distribution of ulnar nerve, you can see in this diagram that it is giving cutaneous distribution on medial. So it is giving cutaneous distribution on medial 1.5 aspect of medial 1.5 aspect of palmar and dorsal hand and medial 1.5 fingers. Medial 1.5 fingers both on palmar and dorsal aspect. Both on palmar and dorsal. Both palmar and dorsal aspect. So that means both on palmar and dorsal aspect, medial 1.5 fingers and medial 1.5 of the palm is innervated or getting sensory innervation from which nerve? It is receiving sensory innervation from ulnar nerve. Is it okay? Now let's talk about clinical anatomy. So we have finished with this. Now the next important point is to know the clinical anatomy. So let's talk about the clinical anatomy related with ulnar nerve. Any doubt till now? Any doubt, my dear? So we will talk about clinical anatomy. So lesions of ulnar nerve in the wrist. So let's talk about that. So I would like to tell you the lesions of the lesions of injury which takes place for the ulnar nerve. For example, it takes place in the Guyon Canal. So it can happen in the Guyon Canal, and in the Guyon Canal we know that the ulnar nerve ulnar artery traverses between the hypothenar eminences and the muscles. So basically, you can see medial claw hand. The patient is having medial claw hand. So in this diagram, you can appreciate the patient is having medial claw hand. So here you can see the patient is having medial claw hand. The patient will have medial claw hand. Now, other location of injuries will be, if I talk about other location of injuries, it can be either when it is traversing into the forearm, when it is traversing in behind the medial epicondyle, in between the medial epicondyle and olecranon process, that is also called as cubital tunnel. So in between medial epicondyle and olecranon process, we have got the location of cubital tunnel. There also ulnar nerve can be injured. So when it is passing between the medial epicondyle and olecranon process of ulnar, it can be entrapped in this region and there can be the lesion of ulnar nerve. So it is traversing in cubital tunnel syndrome, and it can also be trapped. It can also be compressed between the two heads of flexor carpi ulnaris. So in the course, we have already talked that when it is traversing between the ulnar and the humeral head of flexor carpi ulnaris, there also it can be trapped. As you can see, this is the trapping of ulnar nerve between the medial epicondyle and olecranon process. Next is lesions of ulnar nerve in the hand. So it gives branches. So exactly the other reasons of being trapped is it can be compressed between two carpal bones, that is pisiform bone and the hamate. And if it is trapped sensory, if the motor branch is only trapped, you know the sensory branch is already given superficially and before, so the sensory branches will be spared. Now, as I told you, in case of ulnar nerve injury, Foreman test is positive. So, ulnar nerve injury, we have got Foreman test positive. Okay, just a minute. Yeah. So, Foreman test is positive, and this is an image. Actually, we have also talked about Foreman test when I was talking about lower trunk brachial plexus injury. So, Foreman test is done for which nerve? It is done for ulnar nerve. So, it is done for checking the integrity of ulnar nerve. So, here you can see in normal cases, when we keep, for example, I will take an example of this block. So, when we keep this block in between our thumb and index finger, so normally our thumb is in adducted position. So, we hold this block by adducting the thumb. So, it is in adducted position. But if the adductor pollicis is not, if adduction of thumb is not possible, what will happen? The flexion of thumb is done to hold this structure. So, flexion of thumb is done to hold this structure, and this is the Foreman test positive. So, Foreman test positive in ulnar nerve injury, and there is paralysis of, in this case, there is paralysis of adductor pollicis muscle. And for holding the structures, for holding the structure in between thumb and index finger, for holding the structure in between thumb and index finger, the thumb is flexed. The thumb is flexed, which is performed by, and the flexion of thumb is performed by which structure? The flexion of thumb is performed by, flexor pollicis longus muscle. Flexor pollicis longus muscle. Okay, now, okay, so actually this ulnar nerve test integrity can be known by performing this Foreman test, which is positive in case of ulnar nerve injury, and it checks the integrity of which muscle? It checks the integrity of adductor pollicis muscle. Okay, now let's solve few MCQs related to the, is it okay? So we have finished with ulnar nerve. Let me ask the students, can we solve few MCQs related to ulnar nerve? Everyone, can we solve few MCQs related to ulnar nerve? So we have finished with this topic of ulnar nerve. Can we start the MCQs now? Aradhana, Jayashri, Medico, Punit, Faizan, everyone, those who are live. So let me know so that we can start the SAF. Okay, SAF Ali. Yes, so SAF is telling okay. So let's start. So yes, question number 1. So I would like to solve this MCQ along with you. So this is a clinical question. I will read it for you. A 19-year-old female presents to your office complaining of right hand clumsiness. Physical examination reveals decreased sensation over the fifth finger and a flattened hypothenar eminences. The patient is having flattened hypothenar eminences. The affected nerve is commonly injured at which of the following location? Whether it is injured at the level of carpal tunnel, whether it is injured at the level of hook of hamate, whether it is injured at the level of surgical neck of humerus, whether it is injured at the level of head of radius or coracobrachialis muscle. So SAF has given the answer. I am waiting for others. Then I can proceed with the next question. So actually, Saif Ali, you have given perfectly right answer. You have given perfectly right answer, and the location of injury is hook of hamate, and we know that in relation to hook of hamate, the ulnar nerve runs, and it can be injured in the level of Guyon's canal. So absolutely correct. Saif Ali has given absolutely right answer, and thumbs up goes for him. Aradhana Arora, a thumbs up again goes for Aradhana Arora. C has also given absolutely right answer. Absolutely correct. So basically, the right answer is hook of hamate. Yes, the right answer is hook of hamate because it is related with the ulnar nerve, and ulnar nerve is injured in this level. Carpal tunnel is the wrong answer because carpal tunnel will be related with the compression of median nerve. So it is wrong. Surgical, anyone can tell me surgical neck of humerus is related with which nerve? I have previously told you surgical neck of humerus is related with which nerve? And it is a wrong option here. It is related with axillary nerve, and it is not injured in this case. Head of radius is also, yes, absolutely right, Aradhana. You are absolutely right dear. Head of radius will be related with the radial nerve, and it is not injured in this case. Coracobrachialis is getting innervation from musculocutaneous nerve, and it is also not injured because the key word which is mentioned is flattening of hypothenare eminences, and we know that sensation on fifth finger. So sensation in the medial finger is gone and hypothenare eminences is affected. That means hypothenare muscles, that is abductor digiti minimi, flexor digiti minimi and opponens digiti minimi is affected in this case. So definitely the right answer will be hook of hamate, Guyon's canal in relation to ulnar nerve. So ulnar nerve gives sensory innervation to medial part of the fingers, fourth and fifth finger, and also gives innervation to the lumbrical muscle medially, interosseous muscles, and also to the hypothenare eminences muscle. So it passes between it passes in the Guyon's canal along with ulnar artery, which is lying between the pisiform bone and the hamate bone. Carpal tunnel is wrong because median nerve is compressed in this region, and the affection will be off and the injury will be on the lateral aspect. Now, surgical neck of humerus is also wrong. Why? Because surgical neck of humerus is related with axillary nerve. Head of radius is also wrong. Why? Because head of radius will be related with the case of nursemaid elbow, and it will be leading to the case of radial nerve and will lead to wrist drop. Coracobrachialis is long because it's a muscle of front of arm and it is supplied by musculocutaneous nerve. So let's move on to the next question, that is question number 2. A 53-year-old male complains of strange feeling in the right hand. Strange feeling on the right hand. On physical examination, there is loss of sensation. So on physical examination, if you will see, there is loss of sensation over the fifth digit. Which of the following nerve has most likely injured in this case? So which of the following nerves? So which of the following nerve is most likely injured in this case? Ulnar, medial, radial, musculocutaneous and axillary. So Saif Ali and Aradhana Arora has already given the answer. Strange feeling, sensation lost over the fifth digit. So these are the keywords which is given. Sensation lost over the fifth digit, that is medially. So definitely ulnar nerve is the right answer, and both of you has given right answer. So yes, absolutely correct. Both of you has given the right answer. Ulnar nerve is the right answer. So loss of sensation of the fifth digits, definitely the medial side of the palm we have got innervation by ulnar nerve. So it's a claw hand deformity will be seen, medial claw hand. Medial nerve is not the right answer because classical presentation will be ape thumb deformity or loss of sensation will be laterally. Radial nerve will cause wrist drop and the sensation lost will be over dorsum of the thumb. Musculocutaneous nerve will lead to the paralysis of BBC, and this was not presented in this condition. It will give innervation to the muscles of front of arm. Axillary nerve is also not the right answer because axillary nerve gives innervation to deltoid muscle and teres minor muscles, and they are not involved or paralyzed in this condition. Now, let's talk about the formation of median nerve. Formation of median nerve. So when I am talking about formation of median nerve, it takes via formation of median nerve is via two routes, that is so if I talk about median nerve, it is the thickest nerve of the brachial plexus. So it's the thickest nerve. Why it is thick? Because it is formed by taking contribution from both the medial cord and lateral cord of brachial plexus. It has got two roots. It has got a medial root and it has got a lateral root. So it is having a medial root and it is having a lateral root. So it is taking contribution from both medial and lateral root, and then it leads to the formation of medial nerve. So that means it is the thickest nerve of the brachial plexus, and its root value will be, the medial root value is C8 and T1, lateral root value is C5, C6, C7. That means overall median nerve will have the root value of both of this will be added on, and the overall C5, C6, C7, C8 and T1. Why it is called as labor nerve? The reason is that basically median nerve is giving innervation to the flexor group of muscles of forearm except those innervated by ulnar nerve, and only two muscles of the forearm front aspect, that is the flexor carpi ulnaris and the flexor digitorum profundus medial part, is innervated by ulnar nerve. Rest all the muscles of forearm is innervated by median nerve. So that is the reason definitely the median nerve is called as labor nerve. So all difficult motion of the movements of the limbs can be done. Upper limb can be done. Forearm, we use forearm, this flexor group of muscle for lifting the structures and all. So that is done by the median nerve. Now here I just want you to give a quick recapitulation of how the formation of median nerve takes place. So see here. So if you will see this image, you can understand. So exactly in this diagram, you can see this is the lateral root of median nerve. This is, so exactly in this diagram, this is the lateral root of median nerve. This is the lateral root of median nerve, and this is the medial root of median nerve. This is the medial root of median nerve. So this is how the whole of median nerve is formed. So this is how the whole of median nerve is formed. So what you can see, this is the medial root and this is the lateral root. So median and lateral root both, so that means branch. That means if we are talking about median nerve, you can basically see it takes contribution from this is the lateral root LR and this is the MR, this is the medial root. So that means lateral root is formed from the lateral cord of brachial plexus and medial root is formed from the medial cord of brachial plexus. So this is how the entire median nerve is formed. This is how the formation of median nerve takes place. So this is the thickest nerve. Now let's talk about the course of median nerve in brief. So let's talk about the course. We already know the course of brachial plexus are formed. So the course of brachial plexus are formed in the axilla. That is already known to us. That means formation of median nerve has taken in the axilla, and after its formation it is passing lateral to the third part of axillary artery. So in the axilla, what is the location of median nerve? In the axilla, the location of median nerve is lateral to third part of axillary artery. Now let's talk further about the contribution. So thereafter, if I talk about the contribution, thereafter if I talk about the course and relation, in the arm we will see that the median nerve is traversing lateral to brachial artery. So thereafter we will see the median nerve is traversing lateral to brachial artery, and in the middle of the arm it will pass in the front of brachial artery. So this is the course. So let me talk about the course. So basically it descends lateral to brachial artery. So if I am talking about the course of median nerve in the arm, it is descending lateral to brachial artery. It is descending lateral to brachial artery, and in the middle of arm, it is crossing in front of brachial artery. That means it is changing its direction. Firstly, lateral to brachial artery. We know that axillary artery changes its name to brachial artery at the level of lower border of teres major. So firstly it was descending lateral to axillary artery, then it is also lying lateral to brachial artery, and after that in the middle of arm it will cross in front of the brachial artery. Now it will lies medial. Now you can see, now the median nerve is lying medial to brachial artery in the region of cubital fossa. So at the level of cubital fossa, now it is lying medial to brachial artery. So I will just enlarge this. So I will just enlarge this. So when I am enlarging this, here I want you to show this is the region of cubital fossa. So this is the region of okay, so this is the area of cubital fossa, and here you can see the medial most structure is median nerve. The medial most structure is median nerve. Then we have got the brachial artery, and then we have got the biceps. So we have got the biceps tendon. So this is the biceps tendon. This is the biceps tendon, and the fourth structure is the radial nerve. The fourth structure is the radial nerve. Okay, now if we are talking about cubital fossa and we are talking about the relation of the structures in the cubital fossa from medial to lateral. So here medial to lateral. So from medial to lateral, the structures are median nerve is the medial most structure, and it will lie medial to which artery? It will lie medial to brachial artery. So this is what I want you to understand, that it is located medial to brachial artery in the level of cubital fossa. Then we have got here the biceps tendon. So we have got just lateral to brachial artery, we have got the biceps tendon, and lateral to it, or the lateral most structure here, will be the radial nerve. So these are the four structures related to the cubital fossa. And now here we can appreciate that the medial nerve is located medial to the brachial artery. Now in the elbow, now coming to the elbow region, and when I am talking about the course of the median nerve in the elbow region, it is located behind. It is located behind bicipital aponeurosis, and it is lying in front of brachialis muscle. It is lying in front of which structure? It is lying in front of brachialis muscle. It is lying in front of brachialis muscle. Got it? It is lying in front of brachialis muscle. Now thereafter, in the elbow region. So when I am talking about the elbow region, in the elbow region, again I want you to show that there is a bicipital aponeurosis. So you should understand what is bicipital aponeurosis. Actually the medial extension, in the medial aspect, the biceps tendons will flatten. The biceps tendon flatten to form bicipital aponeurosis. So here you can appreciate that two structures are covered by bicipital. So this is bicipital aponeurosis, and this bicipital aponeurosis, so here we can see this is the bicipital aponeurosis, and bicipital aponeurosis is covering two structures, that is the brachial artery and median nerve. So it is covering brachial artery and that of median nerve. Now I would like to show you this cadaveric image, so we can talk about this cadaveric image. So in this cadaveric image, again we have to know about the boundaries. So this is the pronator teres muscle. This is pronator teres muscle, and this muscle which you are seeing is the BR, brachioradialis muscle. Which muscle is this? This is the brachioradialis muscle. Okay. Now, so and here in the cubital region itself, you can see the important structure. So here we can see this is the brachialis muscle. This is the brachialis muscle. Okay, this is brachialis muscle. This is brachialis muscle. And here you can say this structure which I am highlighting, the medial most structure in the cubital fossa, this will be the median nerve. So this structure is the median nerve. And other lateral to it, you can have the tendon of biceps. So biceps tendon is there, lateral, because artery is not shown in this image. So please don't get confused. Artery is not shown in this image. So this is the biceps tendon. This is tendon of biceps. Also the interosseous nerve. So also we can see the nerve. So actually we can see the radial nerve here. So we have the laterally, we can see the radial nerve. So here we can see the radial nerve laterally. So we can see here RN for the radial nerve. So we can see the radial nerve here. So, and this is S. Why I have written S? This is the supinator muscle. So in this diagram, you can see brachialis and the supinator, S for supinator muscle. These two muscles are forming the floor of the cubital region, and it is having the boundary pronator teres medially, BR for brachioradialis laterally. I just want you to appreciate here the medial nerve which is lying medial to biceps tendon. Okay, done, and it is lying over the brachialis muscle. Now we will talk about the further course of the median nerve. So when I am talking about the further course of the median nerve, what you can appreciate that it will pass in between the two heads of pronator teres. It will traverse between the two heads of pronator teres, and then it passes between the tendinous ridge. So actually, after traversing between the two heads of pronator teres, it will traverse in the tendinous ridge which is formed between the two heads of FDS muscle. What is FDS muscle, my dear students? FDS muscle full form is flexor digitorum superficialis muscle. Flexor digitorum superficialis muscle. So it is flexor digitorum superficialis muscle. So it enters the forearm between the two heads of pronator teres muscle. It will pass deep to tendinous arch which is formed by humero-ulnar and the radial head of FDS muscle. Flexor digitorum superficialis muscle. Now in this diagram you can see this is the median nerve. This is the median nerve, and this median nerve is passing between the two heads of pronator teres muscle, and thereafter median nerve is passing in relation to FDS, between two heads of FDS, flexor digitorum profundus muscle. Flexor digitorum profundus muscle. Got it? Now, further, if I talk about the forearm course, it is descending. It descends between FDS. After that, it will be descending between FDS and FDP. What do you mean by FDS? Flexor digitorum superficialis. And if I talk about FDP full form, it is flexor digitorum profundus. So basically, it will traverse on the lateral aspect of the lateral edge of FDS and FDP muscle. Now here you can see median nerve is shown here, which is passing in relation to FDS muscle, and thereafter if the flexor digitorum superficialis muscle is cut, and the deeper aspect you can get FDP. So this is FDP muscle, which, so that means exactly if I talk about the course of median nerve, what you can say, the median nerve is passing in between, it is passing in between FDS and FDP muscle. Now in the wrist, so now talking about its course in the wrist, when I am talking about its course in the wrist, the median nerve enters the palm. So it enters the palm by passing deep to flexor retinaculum. The space which is lying deep to flexor retinaculum is called as carpal tunnel, and that means that the median nerve can be compressed in this osteoaponeurotic in this compartment, osteoaponeurotic compartment, and actually deep to flexor retinaculum, that is deep to transverse carpal ligament, the space which is lying beneath flexor retinaculum of the hand, wrist, we will have a space that is called as carpal tunnel, and that space is occupied by median nerve. And in case of certain condition like obesity, pregnancy, rheumatoid arthritis, lunate fracture, acromegaly, myxedema, and all hypothyroidism, there can be compression of median nerve in this space that is called as carpal tunnel syndrome. So here I just want you to show this image. So you can clearly see this structure, which I want everybody to understand, is the flexor retinaculum. So here you can see this is the flexor retinaculum, and this structure which you are seeing is the MN, median nerve. So you can see median nerve is passing beneath the flexor retinaculum, and ulnar nerve, you can see this is UN ulnar nerve. Ulnar nerve is passing superficial to flexor retinaculum. All their palmar branches will also pass. So palmar branches of both ulnar. So it is also important for you to note down. It is also important for you to know that palmar branch will always pass superficial. Palmar branch will always pass superficial to flexor retinaculum. Now I just want everybody to understand the important muscles the median nerve innervates. So in the axilla and arm, no muscles are innervated, but if I talk about median nerve branches in the forearm, it gives innervation to all the flexor group of muscles of forearm and few muscles of the hand. Basic muscles of the hand are getting innervation from ulnar nerve. So write the motor branches and then we will come with the cutaneous innervation. So write down branches of median nerve. So write down branches of median nerve. In axilla and arm, it gives no branches. It gives no branches. So in axilla and arm, it gives no branches. In axilla and arm, it is giving no branches. In forearm, median nerve is giving following branches. In forearm, it is giving following branches. So basically, all the muscles of forearm is innervated by median nerve except all the flexor group of muscles of forearm, not the extensor one, is innervated by median nerve except flexor carpi ulnaris and the medial part of flexor digitorum profundus. So in forearm, it innervates all the flexor muscles of forearm, all the flexor forearm muscle. It innervates all the flexor forearm muscle except FDP medial half and FCU, that is flexor carpi ulnaris. Okay, so basically which all muscle it innervates? So basically please write down the name of the muscle which is innervated by the median nerve. So it innervates flexor carpi radialis. It innervates palmaris longus muscle. It innervates flexor carpi radialis, palmaris longus muscle. It innervates flexor digitorum superficialis. It innervates flexor pollicis longus. It innervates flexor digitorum profundus. Lateral half, and it innervates pronator quadratus muscle. So actually here itself I just want you that these three muscles, when I am talking about flexor, so when I am talking about these three muscles, when I am talking about flexor pollicis longus, flexor digitorum profundus and pronator quadratus, if I am talking about these three muscles, when I am talking about these three muscles are innervated by deep branch of median nerve. So these three muscles are innervated by deep branch of median nerve. And what is the name of deep branch of median nerve? So if I am talking about the deep branch of median nerve, the name is AIN. And what is AIN? So here I want to write the full form of AIN. The AIN full form is anterior interosseous nerve. Anterior interosseous nerve. So anterior interosseous nerve is the deep branch of medial nerve and the three deeper muscles of the flexor forearm, that is FPL, flexor pollicis longus, pronator quadratus and the lateral half of flexor digitorum profundus. So these three muscles will be innervated by deep branch of medial nerve, that is called as anterior interosseous nerve. That is called as anterior interosseous nerve. Now please write down the muscles innervated in the hand. So write down third point. So you can write muscles innervated in the hand. Median nerve innervates following muscles in the hand. Following muscles of hand. And the name of that muscles are muscles of thenar region. So muscles of thenar region. So basically in the thenar region, it gives innervation to following three muscles. What is it? The following three muscles. So it gives innervation to following three muscles, and they are abductor pollicis brevis, flexor pollicis brevis and opponens pollicis. So write down the full form of these muscles. Abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis muscle. Other than that, it also gives innervation to lateral two lumbrical muscle. It also gives innervation to lateral two lumbrical muscles. So it is giving innervation to lateral two lumbrical muscles, that is first and second lumbrical muscles. So actually these all muscles, so these are the few muscles which is innervated by the median nerve in the hand, and most of the muscles, if I talk about most of the muscles of the hand is innervated by ulnar nerve. Done? Now I would like to explain the cutaneous branch of median nerve. Now I want you to understand the cutaneous branches of median nerve. So if I am talking about cutaneous branches of median nerve, you can appreciate in this diagram. In this diagram, you can see the ventral, palmar and the dorsal aspect of the hand. So you can see the ventral, palmar and dorsal aspect of the hand. So I will use there. So exactly on the palmar side, so this is the palmar aspect. On the palmar aspect, you can see lateral 3½ of the palm and the digits. So lateral 3½ of the palm and also the digits are innervated by median nerve. And on the dorsal aspect, you can see lateral 3½ nail buds. So lateral 3½ nail buds are dorsally also innervated by median nerve. Only lateral 3½ of the nail buds. So that means on the palmar aspect, whole of the lateral 3½ of the palm and the lateral 3½ of the fingers, but on the dorsal aspect, only the nail buds laterally 3½ is innervated by median nerve. Now we have finished with the median nerve. Now I would like to tell the clinical anatomy, and then we will have the discussion of MCQs related to median nerve. Lesions of median nerve. So let's start. If I am talking about the lesions of median nerve, all the muscles are paralyzed. So exactly if there is a lesion of median nerve, just a minute. So if there is a lesion of median nerve, what will happen? All the muscles of the forearm is paralyzed. All the muscles of forearm is paralyzed except FCU and FDP. So except the flexor carpi ulnaris and flexor digitorum profundus, all the muscles has been paralyzed. So all the muscles that is the flexor carpi ulnaris and flexor digitorum profundus medial half. All the flexor group of muscles is paralyzed in case of injury of median nerve. Now also we can see Osner clasping test to be positive. We can see Osner clasping test is positive in this case. So when you tell the patient to clasp their fingers like this, what will happen? The index finger is not able to be flexed. The index finger is not able to be flexed. The reason is lateral half of the FDP is supplied by median nerve. Medial half of FDP is supplied by ulnar nerve. So the reason is that medial half is still working. So medial half is not paralyzed. So FDP muscle, that is flexor digitorum profundus, medial half is not paralyzed, and that is the reason that this medial part fingers can be clasped, but the lateral part cannot be clasped. Now also the patient will have ulnar deviation on the attempt of flexion of the wrist and inability to flex the terminal phalanx of the thumb. So the patient will have also inability to flex the terminal phalanx of the thumb. Why? Because of the injury of flexor pollicis longus. So this is clasping test which is positive. Osner clasping test is positive in case of median nerve injury. Okay. Now, so let's talk about few more tests which will be positive in case of median nerve. So the another test which I want everyone to understand is the abductor pollicis test. So when I am talking about abductor pollicis test, what do you mean by abductor pollicis test? Actually, we know that abductor pollicis brevis muscle, one of the muscle of thenar region, is innervated by median nerve. So this is the thenar region and this is hypothenar region. So close to the thumb, we have got the thenar region, and these are close to the little finger, we have a hypothenar region. Hypothenar muscles are innervated by ulnar nerve. Thenar muscles are innervated by median nerve. So if I am talking about abductor pollicis brevis, so one of the thenar muscle, the abduction of thumb is done by abductor pollicis brevis. So exactly, we will place, the patient will place their hand flat on the table, and a pen will be raised somewhat above it by the examiner, and they will ask to touch the pen. So for that action, thumb has to be abducted. Now abduction of thumb is not possible because abductor pollicis brevis is innervated by median nerve, and that is paralyzed due to injury of median nerve. So pen test is positive. That means pen test is positive in case of pen test will be positive. So please note down. Pen test is positive in case of median nerve injury. So to test the integrity of median nerve, you have to go for the pen test, and pen test will be positive in case of median nerve injury because of the paralysis of abductor pollicis brevis muscle. Got it? Now the other features of the lesion of median nerve. So lesion of median nerve when taking place at the level of elbow. So when it happens at the level of elbow, the thenar muscles of this region, the thenar muscles will be paralyzed, leading to the flattening of the thenar eminences. So you can see here there is flattening of thenar region. So here you can see these are the thenar. This is the region of thenar muscle. So this will be all flattened. So thenar muscles will be flattened. So there will be atrophy of thenar muscles. And also the thumb will be in adducted position. The thumb is in adducted position. So why the thumb is in adducted position? Because adductor pollicis, we know that adductor pollicis is supplied by, it's already known to us that adductor pollicis is supplied by ulnar nerve, and here only median nerve is injured. So adductor pollicis is still active, so adduction of thumb is there. So that is why the lesion is called as ape thumb deformity. That means in case of median nerve injury, thenar muscles will have the flattening, ape thumb deformity, abductor pollicis and opponent's pollicis will be paralyzed, and pen test is positive. Now the next important clinical syndrome related with median nerve injury is carpal tunnel syndrome. So when I am talking about carpal tunnel syndrome, most commonly entrapment, it's a most common entrapment neuropathy which is seen, and in this most common entrapment neuropathy, the median nerve is compressed below flexor retinaculum. So it is compressed below flexor retinaculum. So basically, I just wanted to show this image. So you can see this is the transverse carpal ligament. So the other name of transverse carpal ligament is, so this is the transverse carpal ligament. And we know that below transverse carpal ligament, the nerve which is traversing is the median nerve. So at times of increased fluid compression or any deformity in this region, there can be compression of median nerve, because the space which is lying below transverse carpal ligament, which is also called as flexor retinaculum, is the median nerve. So you can see this is the median nerve, and exactly if you will see this median nerve exactly, this is the flexor retinaculum. So exactly you can see, this is the flexor retinaculum. So this is FR, this is flexor retinaculum. So the space below the retinaculum, the space below flexor retinaculum, the space below flexor retinaculum is called carpal tunnel, and the median nerve can be injured in this case. Got it? The most common neuropathy is, if I am talking about the most common neuropathy, exactly this is the case of carpal tunnel syndrome. The compression of flexor retinaculum happens, and beneath the flexor retinaculum, the median nerve is traversing, it is compressed, and this condition is more commonly seen in diabetic patient over the 50 years, females, mostly in the dominant hand. And there are so many reasons of carpal tunnel syndrome. I would like to list it. So the reason of carpal tunnel syndrome and the reasons when the carpal tunnel space is narrowed. So the space which is lying below transverse carpal ligament or the flexor retinaculum can be narrowed in the following condition. It can be narrowed in the condition of the trophic changes of RA, that is rheumatoid arthritis, arthritic changes of seen in rheumatoid arthritis. Also in the cases of dislocation of lunate bone, complications of Colles fracture. Also in the case of soft tissue thickening, which is seen in the case of myxedema and acromegaly. And other cases will be edema, obesity and pregnancy. So exactly these are certain reasons where we can see carpal tunnel syndrome or carpal tunnel syndrome narrowing. So this will be seen in the case of arthritic rheumatoid arthritis changes, dislocation of lunate bone, soft tissue thickening, myxedema, acromegaly, edema, obesity and pregnancy. Now, carpal tunnel syndrome. Carpal tunnel syndrome. Carpal tunnel syndrome. So if I talk about carpal tunnel, so this is exactly the flexor retinaculum. So this is exactly the flexor retinaculum. And beneath the flexor retinaculum, you can see the nerve. So beneath the flexor retinaculum, you can see the nerve. So beneath the flexor retinaculum, the nerve has been seen, and this nerve is, what is this nerve? This nerve is the median nerve. So median nerve can be compressed. Median nerve can be compressed beneath flexor retinaculum, and this condition is called as carpal tunnel syndrome. This condition will be called as carpal tunnel syndrome. Got it? Okay. Now let's talk about, so we have been seen the cases. Now exactly what will happen in the carpal tunnel syndrome. So when we are talking about carpal tunnel, it get compressed in the wrist and results in the numbness and the pain. So the symptoms which will be seen in the carpal tunnel, is impairment of finer movement, so sewing, knitting, picking, pain. Also the patient will have paresthesia, numbness in the lateral aspect of the palm, lateral or radial side of the palm, and radial 3.5 of the fingers, also on the nail buds, lateral nail buds, and the patient will be having so much pain that he or she can wake up in the night. Now, carpal tunnel on examination, you can see the wasting of the thenar eminences. So, that is shown by the arrow. The wasting of thenar eminences is seen in the patient. Yes. So, that means thenar muscle is paralyzed. Other things will be, there will be in the radial, that means lateral part of the palm, there will be hyposthesia. Also, the skin over the thenar eminences is not affected. And why the skin over thenar eminences is not affected? The reason is palmar branch of median nerve is passing superficially. It is not passing below flexor retinaculum. Now, Tinel's test is positive. Now, this is the hand in the palm and you have to compress. So, you have to compress on the flexor retinaculum or on the anterior aspect of the wrist. So, when the compression is done, the sign and symptoms of the patient is aggravated, and this condition is seen in carpal tunnel syndrome. So, the Tinel's test is positive and there is aggravation of the sign and symptoms of carpal tunnel. Now, the other case, one more test is there, that is called as Fallon test. So, see this image. So, in this test, what happened? Dorsiflex the wrist like this and make a downward pranam. Okay, like this. So, what will happen in this case? What will happen? There will be again compression at the level of the wrist and more compression in the level of wrist. What will happen? The pressure over median nerve is increased, and this test is called as Fallon test, which is also positive in carpal tunnel syndrome. So, Fallon test, no sensory impairment over the palm. Why? Because we know that already the palmar branch is given superficial. Now, for example, the treatment, if I am talking about the treatment of the case, the treatment will be the region of carpal tunnel and treating that case. For example, if there is dislocation of lunate, there is a hypothyroidism, there is rheumatoid arthritis. So, whichever is the reason of pregnancy and obesity are physiological cause that can be basically goes by a time, or you can have certain modification exercises and certain modification in diet, then the carpal tunnel syndrome is gone. But if the case is much severe and there is a severe form of carpal tunnel syndrome and the patient has to wake up in the night and he or she is not able to sleep, then we will go with the surgical repair. So, endoscopic surgical carpal tunnel release is done. And in that case, cutting of the flexor retinaculum transverse carpal ligament is done and pressure over the median nerve is released. Now, other reasons of carpal tunnel syndrome or other reason of, so we have done with carpal tunnel syndrome. I would also like to tell you about the other reason of entrapment or the other reason of compression of median nerve. One of the reason is pronator syndrome. So, as I already told you, pronator syndrome is positive in median nerve because we know median nerve is passing between the two heads of PT, pronator muscle. So, there is a chance of being compression. So, exactly when the median nerve is passing in between the two heads of pronator teres, or it is traversing between the flexor digitorum superficialis or being deep to biceps aponeurosis, these are the certain reason where the median nerve can be compressed. So, if the median nerve is compressed in these locations, what will happen? There will be pain and tenderness. The patient will have, so the patient will have pain and tenderness or the proximal aspect of anterior forearm, weakness on the muscles which is innervated by median nerve, and there will be sensory impairment on the palm of the hand. So, these are certain features which is seen in the case of pronator syndrome. This is seen in the case of pronator syndrome. अभी नहीं, बाद में, afterwards. Now, so done with this. So, we have done with this. This is the case of pronator syndrome which we have done already. Okay, this is the case which has been done already. Okay, now, so let's solve the MCQ. So, let's solve the MCQs related to the topic. So, let's solve the MCQs related to the topic. Question number 1. A 45-year-old Caucasian females, presents to your office with numbness of right palm, and after taking a detailed, after taking a detailed history and doing a physical examination, you suspect a median nerve lesions. Oh, So after taking a detailed history and doing a physical examination, you suspect medial nerve lesion at the wrist. Before reaching the wrist, the medial nerve is coursing between which of the following structure? The options are biceps and coracobrachialis muscle, flexor carpi ulnaris and flexor digitorum profundus muscle, flexor digitorum superficialis and flexor digitorum profundus muscle. Okay. So, okay, olecranon process and medial epicondyle of the humerus, supinator muscle and head of radius. So, what you can see, 5 options are there, and basically this question is already telling you there is a medial nerve lesion at the wrist. So, exactly this question is about the course of medial nerve. So, it is reaching to the level of the wrist, and before that it is compressed between which two muscles. So, exactly Saif Ali has given one of the answer. So, Saif Ali, now what about others? Exactly medial nerve is compressed, my dear. Median nerve is compressed, so the course of median nerve is between two muscles. So no, Saf, it is not right. Make another attempt. The question is about median nerve, dear. The question is about median nerve, not ulnar nerve. Flexor carpi ulnaris is innervated by ulnar nerve. So median nerve, I have given you the hint. Now give me the right answer. So median nerve lesion at the level of the wrist. So basically we have to know the course of median nerve and then we will be able to solve it right. So I got an answer from, I got a right answer from Ifimoma. Okay, so Ifimoma has given a right answer. Absolutely correct. Please don't mind my pronunciation of your names. Okay. Okay, dear. So yes, the right answer is flexor digitorum superficialis and profundus. So basically, this is the right answer and this is the course of median nerve when it is traversing into the forearm. So see here, why first answer is not right? So basically biceps and coracobrachialis, this will be the location of musculocutaneous nerve. This will be the location of musculocutaneous nerve. Flexor carpi ulnaris and flexor digitorum is the location of ulnar nerve. This is the right answer because obviously medial nerve is related in this location. Olecranon and medial epicondyle is again wrong because this is also related to ulnar nerve. Supinator and head of radius is wrong because this is related to radial nerve. So definitely the right answer is C. So that is the reason the right answer will be C. Now medial nerve is traversing, entering the flexor retinaculum of the forearm under the cover of tendinous arch. So it is going under the cover of tendinous arch between the humero-ulnar and radial head of flexor digitorum profundus. So basically the course of median nerve, if I am talking about the course of median nerve, it is traversing between the humero-ulnar radial head of flexor digitorum profundus. As the nerve is descending, it will traverse between FDS and FDP and it will be closely applied to the posterior surface of the former muscle. So the course of this nerve will be in relation to FDP and FDS muscle. Now, biceps and coracobrachialis is not the right answer and the reason is that biceps and coracobrachialis is related with the musculocutaneous nerve, not the median nerve. Okay. Flexor carpi ulnaris and FDP is related to ulnar nerve, so it is wrong. Olecranon and medial epicondyle of humerus is also related to ulnar nerve. Supinator and head of radius is also related to radial nerve. So only we have got the right answer in relation to FDP and FDS. Now, all the branches of median nerve does not. So, which of the following muscle is not innervated by median nerve? So, you have to just tell me which of the following muscle is not innervated by median nerve. You have to just tell me which of the following muscle is not innervated by median nerve. So, we have got Saif Ali and Ifeoma. Both of you has given absolutely right answer. Absolutely right answer, and Helvin has also given the right answer. The correct answer is adductor pollicis. Why adductor pollicis? Because adductor pollicis is innervated by ulnar nerve. Adductor pollicis brevis is innervated by medial nerve, flexor pollicis brevis, opponens pollicis, and also the adductor pollicis will be innervated by ulnar nerve. Now, a patient tries to make a fist, but its lateral part of the fingers are remaining extended. So, can you tell me the nerve injured? So, its lateral part of the fingers are still not able to be flexed. So, what is the reason of the nerve being involved in this case? So, Helvin has given the answer. What about others? Aradhana Arora has also given the answer. And both of you are correct. Yes, the right answer is median nerve. And this is the condition of Benedict's hand. This is the condition of Benedict's hand. Absolutely correct. So actually, when you try to make a fist you have to flex the fingers. Okay, yes, you are also right. Ifoma, you are also right, dear. Now, Benedict's sign is seen as a result of injury of the musculatures of the hand. Basically, in case of medial nerve injury, we know the lateral part of the fingers. Lateral part of the fingers, the lateral part of the fingers, like flexor pollicis longus and flexor digitorum profundus, lateral part is getting innervation from deep branch of medial nerve. So, when the lateral part is injured, that means medial nerve is injured. The lateral two fingers and the thumb is not able to be flexed, and this condition is called as Benedict's sign, which is also positive. Benedict's sign is also positive in case of medial nerve injury. Now we have done with this. Now the next nerve which I want to start is the radial nerve. Is it okay? Can we start with the next nerve? So let's start with the radial nerve. So if I am talking about the radial nerve, it is formed by the continuation of posterior cord. Radial nerve is formed by the continuation of posterior cord, and its root value is C5, C7, C5, C6, C7, C8 and Q1. So it is actually why radial nerve is very important. It's the largest branch of brachial plexus. Radial nerve is the largest branch of brachial plexus. It is formed by taking contribution from C5, C6, C7, C8 and T1. Now I just want you to show the radial nerve formation. So you can just see this is the posterior division of all the three cords. So posterior division of all the three cords will join. Posterior division of all the three cords will join and lead to the formation of posterior cord. And here you can see one of the largest branch of the posterior cord, which you can see in this image, is the radial nerve. So you can see this is the radial nerve, which is the largest branch of posterior cord of brachial plexus, which is having the root value all C5, C6, C7, C8 and T1. Now let's solve the MCQ. Before solving the MCQ, what is important that you should have an idea of anatomy of radial nerve. So when I am talking about radial nerve, first thing is you have to know the formation of radial nerve. So the radial nerve is formed in which area? It is formed in the axilla. So it is formed in the axilla. And further course, if I talk about, it is passing behind the third part of axillary artery. So it is formed in the axilla and it is traversing behind the third part of axillary artery. It lies anterior to, and it is in its course it is lying anterior to. So it is important that in its course it is lying anterior to the muscles of the posterior axillary wall. So as I have already completed the axilla, and we have discussed that these three muscles, subscapularis, latissimus dorsi and teres major, these are the muscle which is forming the posterior wall of the axilla. So basically posterior wall of the axilla is the reason where these nerves are traversing. So posterior wall of the axilla is there. So basically we can tell that anterior to the posterior wall of axilla, the radial nerve is traversing. It is resting over subscapularis, the tendon of latissimus dorsi and teres major muscle. So I just want you to show the radial nerve. So this is the radial nerve which you are seeing, and you can see it is resting over subscapularis muscle. LD latissimus dorsi and PM, that is teres major muscle. So it is resting, it is running over the muscles of posterior axillary wall. Now after that it will leave the axilla, and you already know radial nerve will run along with profunda brachii artery, and it will pass through which gap of the scapula, you already know. Hello everyone. So are you able to listen to me? Aradhana is telling the voice is low. So what about the others? Let me just check by my own. So are you able to listen to me? Saf Ali is okay, and I also checked the voice is okay, dear. Please check your connection, dear Aradhana. So if I talk about radial nerve, it is traversing through the lower triangular space. It is traversing through the lower triangular space along with which artery? Profunda brachii artery. So it will pass through the profunda brachii artery. Now we can see here this diagram, and this is the teres major muscle. This is teres minor. So, and this is long head of triceps. So in between the long head of triceps and the humerus bone and above lies the teres major muscle, we have got a lower triangular space. So here we have got a lower triangular space, and in this lower triangular space you can see one artery and one nerve is traversing. So we have got a nerve which is traversing, that is the radial nerve, and we have got an artery which is traversing. The artery which is traversing is the profunda brachii artery. So basically we have got the nerve and we have got the artery which is traversing. So we have got profunda brachii artery and the radial nerve passing between the lower triangular space, traversing between the lower triangular space. Now after that it has to traverse in the arm. So we will see the further course. So if I am talking about the further course of the median nerve is, it will lie between, now the course will be, it will be traversing between the long and the medial head of triceps. So now the medial nerve is passing between the long head and the medial head of triceps. Thereafter it will run posteriorly in the posterior groove of the humerus in between lateral and medial. So it will traverse between the medial and the long head, then between the medial and lateral head of triceps, and after traversing to the posterior aspect, now the radial nerve is entering into the anterior compartment. So here you can see this is the radial nerve in the radial groove. It is in relation with these are the muscles, these are in relation with the triceps muscle. Firstly it will pass between the medial and that of the long head, then it will pass between the medial and lateral head. Now coming to the lower anterior aspect. So let's talk about more detail. So now let's talk about the lower anterior aspect. Further course of the radial nerve. After that course, the further course is, it is passing between the brachialis and brachioradialis muscle. So the further course is that it is passing between the brachialis and brachioradialis muscle proximally, and more distally we have got ECRL. What is the full form of ECRL? Anyone? What is the full form of ECRL? So ECRL means extensor carpi radialis muscle. Extensor carpi radialis longus muscle. So ECRL means extensor carpi radialis longus muscle. So it will be traversing between the brachioradialis and brachialis muscle. Actually radial nerve also gives proprioceptive fibers to that of brachialis muscle, and it will run between the brachialis and that of brachioradialis muscle. Thereafter it will run anterior to lateral epicondyle. So it will run anterior to lateral epicondyle. It will give two branches, superficial and posterior interosseous branch. So it will give So basically it is very important for you to note down. So basically it's very important for you to note down just anterior to lateral epicondyle. So just anterior to lateral epicondyle, it gives two branches. It gives superficial branch and it gives a deep branch. The name of deep branch is posterior interosseous nerve. The name of deep branch is posterior interosseous nerve. So I just want to recapitulate. The name of the deep branch of median nerve is anterior interosseous nerve, and the name of deep branch of radial nerve is posterior interosseous nerve. So I just want you to show, this is the radial nerve. So this is the medial epicondyle, this is the lateral epicondyle, and radial nerve, as you can see in this diagram, this hole is the radial nerve. Here it is traversing anterior. So here you can see the radial nerve. Here in this diagram you can see, if this is the radial nerve, you can see it is traversing anterior to lateral epicondyle and then dividing into two branches. One is superficial branch. The superficial branch of radial nerve, if I am talking about the superficial branch of radial nerve, the superficial branch of radial nerve will traverse laterally towards the anatomical snuff box, and the deep branch will pass between the supinator muscle. So it will pass between the supinator muscle. Now please note down superficial branch. So now please note down the superficial branch of radial nerve. If I am talking about the superficial branch of radial nerve, it will be running along the lateral aspect or the lateral side of the forearm radially, will cross the anatomical. So it will cross the anatomical snuff box. It will cross the anatomical snuff box and ultimately will reach the back of hand. And ultimately it will reach the back of hand. It will reach the back of hand. So here in this diagram, you can see radial nerve. This is the radial artery, but I am talking about the superficial branch of radial nerve. So this is the superficial branch of radial nerve, and here you can see the superficial branch of radial nerve is in relation to anatomical snuff box. So it is traversing where? It is traversing in the anatomical snuff box. Superficial branch of radial nerve traversing in anatomical snuff box. And in this diagram, you can see the radial nerve has been shown and its deep branch is going in between which muscle. So it is traversing to which muscle? So the deep branch is traversing in the supinator muscle. So by this diagram, it is quite clear the superficial branch, the division of radial nerve into superficial and deep branch occurs at the level of lateral epicondyle anteriorly. The deep branch will pass through the supinator muscle and the superficial branch will go run radially in the anatomical snuff box. Now let's talk about further course in the forearm. Now the further course in the forearm, the deep branch will traverse deeper to the supinator muscle and thereafter it will enter into the extensor compartment of forearm. So the deep branch will enter now in the extensor compartment of forearm and the deep branch of radial nerve will innervate all the extensor muscle. Only the brachioradialis and extensor carpi radialis longus is the muscle which is getting innervation directly from the radial nerve. So the deep branch of radial nerve is called as posterior interosseous nerve. So it runs along with the posterior interosseous artery and you can see all these muscles. So all these muscles are extensor group of muscles. So all these are extensor forearm muscles. All these are innervated by radial nerve. So actually branches, so it's very important to know the branches of radial nerve. So it is giving innervation to few muscles in the arm, that is triceps muscle. It is giving innervation to the muscles of forearm. So I would like to write that list of the muscles. So please write down. Radial nerve innervates so radial nerve innervates so radial nerve innervates following muscles in the arm. So it is innervating 3 heads of triceps muscle. It is innervating medial head of triceps muscle, it is innervating medial head of triceps muscle, it is innervating lateral head of triceps muscle, and it is innervating long head of triceps muscle. So actually these are the 3 heads of the triceps muscle which is innervated by radial nerve. Other than that, proprioceptive fibers are also given to brachialis muscle. It is also given to brachialis muscle. That means brachialis muscle is the muscle of anterior aspect of the arm, and we know that BVC muscle, that is brachialis, biceps brachii and coracobrachialis, all these 3 muscles will be innervated by musculocutaneous nerve. But if I am talking about brachialis muscle, it is a muscle which is also receiving its innervation. It is also receiving proprioceptive fibers from the radial nerve. Now talking about radial nerve further. So let's talk about the branches of radial nerve in forearm. So let's talk about the branches of the radial nerve in forearm. So in forearm, basically it is giving innervation to extensor group of muscle. So following muscles it innervates. It innervates brachioradialis muscle. It innervates extensor carpi radialis longus muscle. It innervates extensor carpi radialis longus muscle. It innervates extensor carpi radialis brevis muscle. Okay, extensor carpi radialis brevis. It innervates so many muscles. So I just want to write here in bracket that brachioradialis ECR, these are the 2 muscles which is directly innervated by radial nerve. These are directly innervated by radial nerve. But if I am talking about other group of muscle, they are innervated by deep branch of radial nerve, that is extensor carpi radialis brevis, supinator muscle, extensor pollicis longus, extensor pollicis brevis, extensor pollicis brevis muscle, abductor pollicis muscle, so abductor pollicis brevis muscle, or no, abductor pollicis longus. Abductor pollicis longus muscle, extensor pollicis brevis, extensor pollicis longus, extensor carpi radialis. Other muscles are, so just give me the list: extensor carpi, extensor digitorum and extensor digiti minimi. So please write down extensor carpi ulnaris is there, extensor digiti minimi is there, and extensor indicis is there, and extensor digitorum is there. So I have written just the name like this, so please don't get confused. So what is the full form of ECU? If you want, I can just write it. I will just write it. So extensor carpi, ECU means extensor carpi ulnaris. Extensor carpi ulnaris. EDM means extensor digiti minimi. Extensor digiti minimi. EI means extensor indicis. Extensor indicis. And ED means extensor digitorum. Extensor digitorum. So basically what happens if I am talking about these muscles, so basically all the muscle, please just remember that all the extensor group of muscle, if I am talking about all the extensor group of muscle, Medico, yes, we can remember as all extensors supplied by deep branch of radialis. Yes, Medico, all extensor except two, but please note down except two. Except the two extensor muscle, that is extensor carpi radialis longus and brachioradialis. Also, there is one small muscle that is anconeus. So, there is one small muscle that is anconeus, and this small anconeus muscle is getting innervation from nerve to anconeus. Nerve to, so this small muscle is getting innervation from nerve to anconeus, and nerve to anconeus is also a branch of radial nerve. Nerve to anconeus, and this is nerve to anconeus is also a branch from radial nerve. So basically many muscles are innervated. Yes, Medico, that is many muscles are innervated by radial nerve. But if I am talking about directly by radial nerve, two muscles are innervated. Two muscles are innervated directly by radial nerve, BR and ECRL. ECRL is extensor carpi radialis longus, BR is brachioradialis. Other than that, all extensor muscle like extensor carpi radialis brevis, abductor pollicis longus, extensor pollicis longus, extensor pollicis brevis, supinator muscle, extensor carpi ulnaris, extensor digiti minimi, extensor digitorum, extensor indicis. All are supplied by the deep branch. All are supplied by deep branch. And what is the name of deep branch of radial nerve? I already told you. Deep branch of radial nerve is called as posterior interosseous nerve. Now after that, I would like to show you this image. Why? Because here in this image, you can have an idea of cutaneous distribution of radial nerve. So you can see cutaneous distribution of radial nerve is, it is giving posterior cutaneous nerve of arm. So it is supplying posterior aspect of arm. It is giving posterior cutaneous nerve. It is supplying lower lateral cutaneous nerve of arm. Aspect of arm. It is giving posterior cutaneous nerve of forearm. Posterior cutaneous forearm. Posterior cutaneous nerve of forearm, and it is also giving innervation to dorsum of hand. So it is giving innervation to dorsum of hand, that is 3.5 except the nail bud. Please note down except the nail bud. So no, why not the nail buds? Can anybody tell me that if we are seeing this image and we are understanding the cutaneous distribution of radial nerve, which is on the lower lateral aspect of the palm, which is on the posterior aspect of the arm and posterior aspect of forearm and dorsum of the hand, but not the nail buds. Can anybody tell me why not the nail buds are given innervation? Medico, SAF, I have explained you. The nail buds are not getting innervation by this branch of radial nerve, and the reason is that the nail buds are getting innervation by median nerve. Medico is absolutely right, and absolutely right, Medico. You are absolutely right. Good one. Now we have finished with the radial nerve. Now I would like to explain few of the I would like to explain the clinical anatomy, and then we will solve the MCQs. Then we have done with all the nerves. Okay, so lesions of radial nerve. So one of the lesion is crutch palsy. So if radial nerve can be injured in the axilla, and that condition is called as crutch palsy. So when the compression of radial nerve occurs in the axilla, the resultant condition will be wrist drop. So what will happen? All the extensors, so in this case what will happen? All the extensor muscles will be paralyzed, and the patient will have inability to grip the object. So the loss of sensation will be also there on the posterior aspect of forearm, the posterior aspect of forearm, and the lateral aspect of the arm. So if I am talking about the summarization of the radial nerve injury in the axilla, which is high injury, what will happen? All the important structures will be injured. So all extensor group of muscle is injured, all the part of the triceps muscle is injured, loss of sensation on the dorsum of the hand, loss of sensation on the posterior aspect of forearm and the posterior aspect of arm, and lower lateral aspect of the arm. So that means if high up injury is in the axilla, all the branches of radial nerve is injured, is involved, and the patient will also have wrist drop. Along with this, the extension of the elbow and the extension of forearm, hands, digits will be affected. So exactly, now other case is the Saturday night palsy. So when I am talking about Saturday night palsy, so how you are understanding this condition? Actually, when I am talking about Saturday night palsy, for example, generally what happens, there is after Saturday there is a holiday, and on Saturday you had got a party whole night and you have drunk, so the person has drunk so much of alcohol and he or she is intoxicated. So they have just sat down on the chair and they have compressed the radial groove on the chair by sitting, and that compression of radial nerve in the spiral or radial groove will lead to the injury of radial nerve. But we know that the triceps has got three. Yes dear, we know that the triceps has got three heads: medial, lateral and long head. That means whole of the triceps is not injured, so extension, so that is why whole of the triceps function is not gone and extension of elbow is not impaired. The reason, if the injury is in the axillary region, the whole of triceps is also injured. But when I am talking about injury of the triceps is happening in the spiral groove or radial groove, that means the triceps can escape the injury. Okay. The patient will have wrist drop. The patient will also have the wrist drop, and also the patient will have sensory loss in the back of forearm. Dorsum of the hand on the lateral aspect will be affected. Lateral 3.5 of the dorsum is also affected till the level up to the nail buds. So the nail buds is not affected, and all other all other parts will be affected. Only the nail bud is not affected because medial nerve is not injured and triceps escapes the injury. The reason why it escapes the injury is that the triceps is getting innervation from above level in the axillary region itself, so it escapes the injury, and extension of elbow is weakened but full loss of extension of elbow is not there. Now talking about the injury, so now talking about the injury of the deep branch of deep branch of radial nerve, and we know that deep branch of radial nerve is posterior interosseous nerve. So if we have to talk about the deep branch of radial nerve, it is the posterior interosseous nerve. So okay, I am audible. So that means only the deep branch, that is posterior interosseous nerve, is injured. We know that posterior interosseous nerve is traversing in between the two heads of supinator muscle. So that means brachioradialis, extensor carpi radialis escapes the injury and the other extensors will be paralyzed. So that means the brachioradialis and extensor carpi radialis escapes the injury and other extensors are paralyzed. Why these two muscles escapes the injury? The reason why these two muscles escapes the injury is these two muscles, that is brachioradialis, extensor carpi radialis longus, these two muscles are directly getting innervation from radial nerve. So these two muscles are directly getting innervation from radial nerve. Now, extension is possible, but with radial deviation. Slight effect of wrist extension is affected, but slightly possible with radial deviation, and there will be no sensory loss. Why no sensory loss? Because the cutaneous innervation is not affected, only the deep branch is affected, that is posterior interosseous nerve. Now, let's talk about nurse-made elbow. So, when I am talking about nurse-made elbow, the other name which is given to nurse-made elbow is, it is also called as tennis elbow. No, sorry, it is also called as student's elbow. So, it is also called as pulled elbow. Sorry, it is also called as pulled elbow. So, radial head subluxation. The radial head subluxation is the nurse-made elbow, and it is actually commonly seen in case of children. Small children of age of 1, 4, 5 years, generally what happens, the radial head subluxation can be damaged. Radial head subluxation can be seen in these children because of wrong practice of swinging them with their wrist or hand. So actually some of the some parents and also some of the caregivers, they have got a wrong practice of swinging their children, and we know that their annular ligament and head of radius can slightly slip out of the annular ring, and this will lead to the case of pulled elbow or radial head subluxation, and this can lead to the injury of the radial nerve. So injury of the radial nerve happens, so the muscles of extensor compartment is paralyzed and the patient will have wrist drop. So the patient will have wrist drop, deep branch of radial nerve will be injured and the sensory supply will be still preserved in this condition. Now to summarize, so before proceeding with the MCQs related to radial nerve, I would like to summarize what all we have completed. So in the radial nerve, you have to know these three important points. If the triceps is paralyzed, what is the level of injury? The level of injury is in the axilla. If triceps is paralyzed, the level of injury is in the axilla. If brachioradialis is paralyzed with normal triceps, the injury is at the level of radial groove. If brachioradialis and triceps both are normal, the injury is beyond the level of lateral epicondyle. If triceps is paralyzed, the injury is at the level of axilla. If brachioradialis is paralyzed with normal triceps, okay, triceps injury is at the level of radial groove. And if both are normal, brachioradialis and triceps both is not paralyzed, that means the level of injury is beyond the level of lateral epicondyle. So my dear students, we have done with the important nerves and we have seen so many clinical aspects related to the topic. Now I want to solve few MCQs along with you. So let's start with the first MCQ. A patient presents to the emergency department. The patient is presenting to the emergency department with weak wrist extension. Extension of wrist is weak. On physical examination, sensation to the arm is intact. The affected nerve was mostly likely to be injured at which of the following location? The option given is carpal tunnel, hook of Hammett, surgical neck of humerus, head of radius and coracobrachialis muscle. So there are 5 important locations. So a patient presents to the emergency department. So you have to firstly highlight the keywords. So the keywords here are: the patient is having weak wrist extension. Sensation is okay. The affected nerve is most likely injured on which of the following location? So this is the keyword which I have highlighted. Medico has given his answer, but weak wrist extension is there. So that is the hint which will give you the right answer. What about others? What about others, dear? What about others? What is the right answer, dear? What is the right answer here? I have already highlighted the keywords. I got a right answer from Aradhana, Aurora, and I have got a right answer from Medico. Yes, head of radius. Head of the radius is the level where deep branch of radial nerve can be injured. So definitely if I have to mark a right answer, I will go with head of radius as the right answer. Carpal tunnel is not the right answer because at the level of carpal tunnel, which nerve is injured? The nerve being injured is the median nerve. The nerve being injured is the median nerve. Hook of Hammett is also not the right answer because at this level, the ulnar nerve is injured. Surgical neck of humerus is also wrong because at the level of surgical neck of humerus, axillary nerve is injured. Head of radius is the right answer because this is the level where radial nerve is injured. Coracobrachialis muscle is also the wrong option. Why? Coracobrachialis muscle, also this is the level where the median nerve is injured. So BBC, if that means no, coracobrachialis is also wrong option. Why? I will tell you, because coracobrachialis is innervated by musculocutaneous nerve. Musculocutaneous nerve. Actually, musculocutaneous nerve give innervation to BBC. It gives innervation to 3 muscles: biceps brachii, brachialis and coracobrachialis. So if musculocutaneous nerve is injured, then only these 3 muscles are injured. Yes, brachioradialis. Brachioradialis is injured by radial nerve injury, directly radial nerve injury. But here the injury is at the level of head of radius. So deeper branch is mainly involved in the radial nerve. Okay. So we already know this is a case of radial head subluxation and nursemaid elbow. Why? Because the level of injury is at the head of radius that has slipped in the annular, that has slipped from the annular ligament, and because of the slipping from the annular ligament, what it causes? It causes the radial head subluxation, and ultimately what will happen? This will lead to the injury of deeper branch of radial nerve. This will reach to the injury of deeper branch of radial nerve. Okay. Okay. So radial head subluxation can damage the deep branch of radial nerve, leading to the weakness or paralysis of forearm extensor compartment muscle. Wrist drop commonly results from the radial nerve injury. The deep branch of radial nerve does not carry any somatic sensory innervation. So it is not carrying any somatic sensory innervations. Okay. Now here carpal tunnel is not the right answer. The reason why carpal tunnel is not the right answer, because when carpal tunnel is involved, there will be a condition of compression of, there lies the, so if the carpal tunnel syndrome, when we are talking about carpal tunnel syndrome, in that level, there will be compression of median nerve, and median nerve is compressed in fibro-osseous tunnel exactly beneath the flexor retinaculum. The tunnel may be narrowed. The tunnel may be narrowed by arthritic changes in the wrist. That is in the case of rheumatoid arthritis. So it will be damaged in the case of rheumatoid arthritis. And the other reason will be anterior dislocation of the lunate collis fracture. Soft tissue edema will be there in case of myxedema, acromegaly. And also there will be the other reason of compression of median nerve will be in the regions of edema, obesity and pregnancy. Carpal tunnel leads to impairment. So if the carpal tunnel syndrome is there, there will be lesions and there will be impairment of finer movement, swing, knitting, picking, pains, paresthesia, attacks of the pain, tingling, numbness of the radial 3.5 of the digits will be affected. Okay. Now, if I am talking about the hook of hamate, at the level of hook of hamate in the wrist, the ulnar, we know that ulnar nerve passes between the hook of hamate and the pisiform bone. So, exactly the ulnar nerve is located in the Guyon's canal. So, it can get compressed in the Guyon's canal. It can get compressed in the Guyon's canal. So, ulnar nerve at this level of compression can lead to this aesthesia of the ulnar side and can lead to the injury of the intrinsic muscles of the hand. Also, surgical neck of humerus is not the right answer because at this level, axillary nerve is injured. Coracobrachialis is getting innervation from musculocutaneous nerve. Now, a 25-year-old male fractured his right tibia in the motor vehicle accident. His right leg is fixed in a cast and he requires crutches to ambulate. 2 weeks later, he presented with the difficulty of extending his wrist. So, injury to the following nerve is most likely responsible for suprascapular nerve injury, long thoracic nerve injury, axillary nerve injury, accessory nerve injury or radial nerve injury. So, basically the important keywords which is given here, that the accident has happened and he has to use crutches to ambulate. That means the level of injury is in the axilla. That is quite clear. The level of injury is in the axilla and we know that difficulty in extension of wrist is the keyword. So, definitely radial nerve is the right answer, and Medico and Aradhana, all of you have given absolutely right answer. Thumbs up goes for you. Absolutely correct. Saif Ali has also given the right answer. So, basically, yes. Suprascapular nerve is wrong because it will give injury to the supraspinatus and infraspinatus muscle. And we know that supraspinatus muscle, if affected, will affect the initial abduction of arm, and infraspinatus is responsible for lateral rotation of arm. Long thoracic nerve gives innervation to serratus anterior muscle, which is not affected. Axillary nerve is giving innervation to deltoid muscle. Spinal accessory nerve is not affected because it will give innervation to sternocleidomastoid and trapezius muscle, which is not involved in this case. Now, coming to question number 3. A 30-year-old man underwent excision of right radial head. Following surgery, the patient develops inability to extend the finger and the thumb of the right hand. He did not have any sensory deficit. Which of the following is most likely the cause of injury in this case? So the patient is having excision of right radial head. Patient is not able to extend the fingers and the thumb. The patient is not able to extend the fingers and the thumb. So basically, which will be the right answer? Injury is to the common extensor origin. Injury is to posterior interosseous nerve. Injury is to anterior interosseous nerve, high radial nerve palsy. So I am getting right answer from all of you. So many students has given the right answer. All the best and great. Thumbs up goes to all of you. Right answer is posterior interosseous nerve, which is the deep branch of radial nerve. And if the deep branch of radial nerve is injured, that means all the extensor group of muscles is injured. Common extensor origin is not right because it will be injured at the level of lateral epicondyle. Injury to anterior interosseous nerve is the branch of medial nerve and the flexion will go, and high radial nerve palsy will cause all of the injuries of the extension, not only the deep injuries. Which of the following is the correct pair? Which is the correct pair? So which is correctly paired with its nerve supply? Option 1, flexor pollicis longus and anterior interosseous nerve, flexor digitorum profundus and anterior interosseous nerve, extensor carpi radialis longus and posterior interosseous nerve, brachioradialis and posterior interosseous nerve, abductor pollicis longus and anterior interosseous nerve. So I am so happy for the students, Nikita Minaz and others, Ifoma, Safali. So all of you have given a perfectly right answer. Absolutely correct, dear. Yes, you are absolutely correct. This was a very conceptual question which you have solved. Yes, we know that flexor pollicis longus is innervated by deep branch of anterior interosseous nerve. So this is affected by deep branch of anterior interosseous. This flexor digitorum profundus anterior interosseous nerve is partially correct. It is partially correct, not fully. Why? Because medial part will be innervated. Because medial part will be innervated by ulnar nerve. So why this B option is wrong? It is partially correct because medial part will be affected by ulnar nerve. So extensor carpi radialis longus is directly by radial nerve, not posterior interosseous nerve. Brachioradialis is also directly by radial nerve. This will be both with ulnar plus AIN. And abductor pollicis longus is by posterior interosseous nerve, not anterior interosseous nerve. Now, radial nerve innervates which one muscle of extensor? So radial nerve is innervating one muscle, which is a muscle of extensor compartment, which is also having a function of flexion. Can you tell me which is that muscle which is getting innervation? Radial nerve innervates muscles in the extensor compartment of forearm, but it also innervates which of the following? Radial nerve innervates muscles in the extensor part of forearm, but it also innervates which of the following muscle? Yes, brachioradialis is absolutely right answer. Brachioradialis is absolutely the right answer because it is also causing flexion. The reason is it is also causing flexion of forearm. So done with this, and I would like to give you a break. Again, we will meet after this break. Hope the session. So we'll continue more. Actually, I have to start with the second part of upper limb. We have finished the nerves, brachial plexus, and so many important topics. I would like to give you a break, and again we will start with the new topics. Okay, dear. Okay. Okay, take a break, lunch break of 25 minutes. Lunch break of 25 minutes. Okay. यार no no what you are doing yeah why you came to the main screen So am I audible? Let me just check. So yes, am I audible so that we can start the session? Okay. Okay. Okay, so we have covered up all the nerves. So I am starting with the second part of the upper limb. Okay, so we will start with the second part of upper limb. So it's important that we should go with the details of the second part. Just a minute. So here you have to know about the cubital fossa and so So here we will start with one of an important topic, that is cubital fossa. So already in the median nerve we have seen the region of cubital fossa, but we have not talked about the structures lying inside and the roof and the floor in detail. As cubital fossa is an easy topic, but it is also very important, and if I see the previous year of examination, so many questions has been asked from this topic. So many questions has been asked from this topic. So I want everybody to know the details of cubital fossa. Okay, let's start. Let me just check. Snowflake, Aradha, Arona, good afternoon. Nikita, Medico, Punit, everyone. So let's talk by cubital fossa. So if we talk about cubital fossa, this triangular area which you are seeing, this triangular area which you are seeing, this triangular area which you are seeing is the cubital fossa. So this triangular area is the cubital fossa. And if we have to talk the details of the cubital fossa, the base. Okay, so let's talk about the base. So if I am talking about the base of cubital fossa is formed by a line joining. So there is an imaginary line which is joining the medial and lateral epicondyle. So if we are talking about a line joining medial and lateral epicondyle, so we will have, so if we are talking about the lateral and medial epicondyle, this is an imaginary line which is passing from medial and lateral epicondyle, and this triangular area which you are seeing is the area of cubital fossa. This is the area of cubital fossa. So if I am talking about the structures being formed, if we are talking about the structures being formed, so we will have this as the, so see here, if we will talk about the area and the structures, so we will have the structures here. The brachioradialis is the structure. This is the brachioradialis muscle. And this is the pronator teres muscle. This muscle which you are seeing is the PT muscle. So this is PT and this is BR. So what you can see, that pronator teres muscle is forming the medial boundary and brachioradialis is forming the lateral boundary. And here you can see the cubital fossa which is located here, and an imaginary line is passing through the lateral epicondyle and the medial epicondyle. And the depressed triangular area is the cubital fossa. Now we will talk about the contents lying inside. So I just want you to show this image where you can see the structures lying inside. So if we have to know about the contents of cubital fossa, so you have to just know about this content by the mnemonic MBBR. So the mnemonic is MBBR, and we have to know the structures in the cubital fossa if you move from medial to lateral. So the most important structures medially will be the median nerve, then we will have the brachial artery, then we will have the biceps tendon, this is the third structure, and the fourth structure will be the radial nerve. This is the biceps tendon and this will be the radial nerve. So we have got four structures as you move from medial to lateral as the content of cubital fossa. So what is important for you to know the content, and you have to also know the structures lying inside. So please write down the details of cubital fossa. So if I am talking about the cubital fossa, you have to know the structures which is lying in the cubital fossa. So firstly, we'll talk about the boundaries. First thing is to know about the boundaries. First thing is to know the boundaries of cubital fossa. So boundaries of cubital fossa is laterally it is bounded by medial border of brachioradialis, medial border of brachioradialis, medially it is bounded by lateral border of pronator teres, and base is formed by, if I talk about the base is formed by imaginary line passing from medial and lateral epicondyle. So base is formed by imaginary line connecting, imaginary horizontal line connecting medial and lateral epicondyle of humerus bone. The apex. The apex is meeting point of brachioradialis and pronator teres muscle. Now the floor and the roof. So we have done with the borders. The next important thing is to know the floor and the roof. Floor, roof and the content. So write on roof. So roof of cubital fossa is formed by, if I am talking about the roof of the cubital fossa, we have got many important structures which is lying in the roof, and we have to know the structures residing in the roof. So the roof is formed from superficial to deep. So from superficial to deep, the roof structures are following. So from superficial to deep, the roof structures are following. So from superficial to deep, the structures are, we have got skin, we have got superficial fascia, and if I talk about the superficial fascia, it is containing many important structures. So in the superficial fascia, there is median cubital vein which is connecting the, so we have got median cubital vein which is connecting the basilic and that of cephalic vein. So we have got median cubital vein, we have got medial cubital vein which is connecting the basilic vein and the cephalic vein. So other than that, it also contains, the two cutaneous nerves of the forearm, the medial and lateral cutaneous nerve of the forearm. So it also contains medial and lateral cutaneous nerve of forearm. So it contains, the roof contains medial and lateral cutaneous nerve of forearm. It also contains medial and lateral cutaneous nerve of forearm. Done with this? Now it's important to know the contents and the floor. So floor is formed by two muscles. So I would like to everybody to please note down the floor. So if you will see this image, and if I am enlarging this image, what I will write here, I will write here B for brachialis and this S for the supinator muscle. So B and S, B for brachialis and supine. So upper part of the cubital fossa floor is formed by brachialis muscle, and the lower part of the floor of cubital fossa is formed by supinator muscle. So please note down floor. Floor of cubital fossa is formed by, so floor of cubital fossa is formed by Floor of cubital fossa is formed by two muscles. Floor of cubital fossa is formed by two muscles. We have got brachialis muscle, which is forming upper part of floor, and we have got supinator muscle, which is forming lower part of the floor, Okay, so this is about the details of the floor, the two muscles, supinator and brachialis. Now talking about the contents, so let's talk about the contents of cubital fossa. The next is to know the contents of cubital fossa. So if I am talking about the contents, you have to know all important contents which is residing in the cubital fossa and there is a very good mnemonic for it which we have already done also. So the content are, for the mnemonic of the content we have got MBBR. So here M is like there B and here R. So when I am talking about M, it means median nerve. When I am talking about the M, it means median nerve. Okay, when I am talking about M, it's the median nerve. B is for brachial artery, another B is for biceps tendon, and R is for radial nerve. So these are the structures which is forming the content from medial to lateral. The structures is forming the content from medial to lateral, and the contents are median nerve as the medial most content, B for brachial artery, and another B for biceps tendon, and R for radial nerve. So these are the four contents of the cubital fossa from medial to lateral. So done with this, the next topic is flexor retinaculum. The next topic is flexor retinaculum. So it's also important for us to know about the attachment. So what all things we have to know about the flexor retinaculum? The important points which you have to know. Actually, these are small topics. Those who are live, I just want to tell them. These are small topics, but these are highly important topics. Why? Because questions are definitely asked from this topic. So it's an easy topic, but you can't leave this topic. So let's talk about the flexor retinaculum. So in this diagram, you can see the green color structure which has been shown to you. This is the green color structure which has been shown to you. This is the flexor retinaculum, and the space lying below. The space lying below the flexor retinaculum is called as carpal tunnel. So attachment flexor retinaculum of the, so if I am talking about the flexor retinaculum is having, so if I am talking about the flexor retinaculum, it's having an attachment. So these are very easy and very important topic. So that is highly important that you should be well aware of this topic, because this has been asked several times in the examination. So it is important that you should know the details of these topics. So when I am talking about the flexor retinaculum, it's a modification of deep fascia. So what is flexor retinaculum? Is a modification of deep fascia, and it has got an attachment. So it has got a medial attachment and it has got a lateral attachment. So here we will have, this is the lateral aspect, this is the medial aspect. So when I am talking about the medial aspect, it is attached to scaphoid and trapezium. When we are talking about the medial aspect, it is attached to two rows of the bone. So it is attached to the proximal and distal row of the carpal bone. So it is attached to pisiform and hamate. And when I am talking on lateral aspect, it is attached to scaphoid and trapezium. It is attached to scaphoid and trapezium. I would like to firstly explain and then we will come up with the explanation. Now the Y-shaped ligament is the flexor retinaculum. And you can see many structures are passing superficial to it. So we have got ulnar nerve, we have got ulnar artery, we have got palmaris longus, we have got palmar cutaneous branch of ulnar and that of median nerve. So all these structures which has been shown in this diagram, they are passing superficial to flexor retinaculum, and deep to flexor retinaculum an important nerve is passing, that is median nerve. Other than that, we have got the tendon of flexor digitorum superficialis and profundus and flexor pollicis longus. I just want everybody to note down about the flexor carpi radialis. So if you will see this flexor carpi radialis muscle, you can appreciate in this diagram that this flexor carpi radialis muscle is neither passing deep nor passing superficially. So what you can understand from this image, that flexor carpi radialis is neither passing superficial nor passing deep to flexor retinaculum, but it is traversing in between the flexor retinaculum. So that is highly important for you to understand. Is it okay, everyone, those who are live? Actually, these are very much important topic, and these are more important questions will come from these topics. So please write down about attachment and structures passing superficial and deep to flexor retinaculum. Write on the heading flexor retinaculum. So first thing is attachment. So medially it is attached to pisiform and hook of hamate, pisiform and hook of hamate. Laterally it is attached to scaphoid and trapezium bone, scaphoid and trapezium bone. Scaphoid and trapezium bone. Now the structures passing, now it is important for you to know the structures passing which is superficial. So you should be knowing about the structures passing superficial and structures passing deep to flexor retinaculum. So you can just write down. So it's very important that you should be knowing the structures passing superficial and structures passing deep to flexor retinaculum. Okay, dear? So please write on the list. Aradhana, Snowflakes, Medico, all of you, please write on the so write on the heading. Structures passing superficial to flexor retinaculum. Structures passing superficial to flexor retinaculum. So if I am talking about the structures passing superficial to flexor retinaculum, the list of structures are ulnar nerve, ulnar artery, palmar cutaneous branch of ulnar nerve, palmaris longus tendon, and also the palmar cutaneous branch of median nerve, and the other structure is palmar cutaneous branch of median nerve. So also we have got palmar cutaneous branch of median nerve, palmar cutaneous branch of median nerve. So basically structures, these are the structures which is passing superficial to flexor retinaculum. We have got ulnar nerve, ulnar artery, palmar cutaneous branch of ulnar nerve, palmar cutaneous branch of median nerve, and in between palmar cutaneous branch of ulnar nerve and ulnar artery, we have also got the palmaris longus tendon. We have also got the palmaris longus tendon. Okay. We have also got the palmaris longus tendon. Now let's write this. So I would also like to write the structures passing deep to flexor retinaculum. Write on the heading. Structures passing deep to flexor retinaculum. Structures passing deep to flexor retinaculum. So the structures passing deep to flexor retinaculum is following. So we have got an important nerve which is passing deep to it. That is median nerve. we have got also the important structure which is passing deep to it. The other important structures which is passing deep to it will be there is median nerve which is passing deep to it, and the other structure which is passing deep to flexor retinaculum will be tendons of flexor digitorum superficialis, tendons of flexor digitorum profundus, and also the tendon of flexor pollicis longus muscle, tendon of flexor pollicis longus. So these are the structures which is passing deep to flexor retinaculum. Now, one of the important structure I want to write here, tendon of flexor carpi radialis, tendon of you can write tendon of flexor carpi radialis neither passes, so tendon of flexor carpi radialis neither passes deep neither passes deep nor passes superficial to flexor retinaculum, nor passes superficial to flexor retinaculum. Okay, done with this. So, nor passes superficial to flexor retinaculum. Now, I would also like to tell, actually, if you will see this diagram, this ulnar nerve and ulnar artery will be covered by so here there will be ulnar nerve and ulnar artery. If I talk about ulnar nerve and ulnar artery, okay, so if I am just talking about ulnar nerve and ulnar artery, this is covered by a superficial slip of flexor retinaculum, and this superficial slip of flexor retinaculum is called as volar carpal ligament. What is it called as? Volar carpal ligament. So students, are you understanding? Any doubt? Please ask me. So this is called as volar carpal ligament. Now the next topic is an easy topic only, extensor retinaculum. So exactly actually if I talk about the whole of the details of extensor tendon, so actually if I talk about the extensors muscles, it is very important for you to understand that there is 6 extensor compartment and there is extensor tendons which is passing through these individual extensor compartments. So we have got 6 extensor compartment at the level of wrist, and you have to know the extensor tendons which is passing through each individual compartment. So this is the first. So what you can see, this is the first compartment, this is the second compartment, this is the third, this is the fourth compartment, this will be the fifth, and this will be the sixth compartment. So this is the transverse section which is done at the level of the lower forearms. Okay, the radius and the ulna has been dissected out. So this is the first compartment, this is the second, this is the third, this is the fourth, this is the fifth, and this is the sixth. So basically you have to know individual compartments and you have to know the structures passing through each of these compartments. So you have to know about the structures passing through each of these compartments. So here we have got tendons which is passing through these compartments. So I will explain each of it. So this is the first compartment through which 2 tendons are passing. The tendon of extensor pollicis brevis and abductor pollicis longus. So the tendon of abductor pollicis longus, extensor pollicis brevis. Actually, abductor pollicis longus, extensor pollicis brevis, these are anterolateral boundary of anatomical snuffbox, and this is passing through the first extensor compartment. Extensor compartment. So actually what happens, we have got many extensor tendons which will go towards the fingers and all. So when they pass through this at the level of the wrist, there is extensor retinaculum, which is a modification of deep fascia, which will keep this extensor tendon together. So 5 septas arise, 5 septas are given from the extensor retinaculum, and this will divide the whole space into 6 compartments, and individually you have to know the structures passing through this 6 compartment. So the first compartment, the structure passing is abductor pollicis longus and extensor pollicis brevis, and through the second compartment we have got extensor carpi radialis longus and extensor carpi radialis brevis. So the third compartment, extensor pollicis longus, which has been asked in the previous year of examination. Fourth compartment, we have got the tendon of extensor digitorum and also the tendon of extensor indicis. Along with it, we have got so along with it, if you will talk about, we have got anterior interosseous artery and nerve. So it is important that there is anterior interosseous artery and the nerve which is also traversing through this compartment. So I will write it for you, don't worry. So there is an anterior interosseous nerve and there is anterior interosseous artery and posterior interosseous nerve which is passing through this fourth compartment. Through fifth compartment, we have got extensor digiti minimi and ECU is passing through the sixth extensor compartment. So write down 6 extensor compartments. Six extensor compartments. So I would like to like everybody to note down that you should be aware of the 6 extensor compartment and the structures passing through this individual extensor compartments. This is the 6 extensor compartment. So when I am talking about 6 extensor compartment, we will have following structure. So we will have the first extensor compartment through which abductor pollicis longus and extensor pollicis brevis is traversing. So you can write down the full form. What is the full form of APL? APL is abductor pollicis longus. What is the full form? APL is abductor pollicis longus. APL is abductor pollicis longus. EPB is extensor pollicis brevis. Is extensor pollicis brevis. So we have got two tendons which is passing through the extensor compartments. So we have got first compartment through which abductor pollicis longus and extensor pollicis brevis is passing. For the second compartment, if I am talking about the second compartment, we have got two tendons passing, that is ECRL and we have got ECRB. That is extensor carpi radialis longus. That is extensor carpi radialis longus and extensor carpi radialis brevis. So exactly what happens, the first, so if I am talking of anatomical snuff box, the first, if I am talking of anatomical snuff box, the first compartment is having two tendons, abductor pollicis longus, extensor pollicis brevis. The second compartment is having ECRL and ECRB, and the third compartment is having extensor pollicis longus. Only one tendon, that is extensor pollicis longus. So my dear students, it is also important for you to know the fourth compartment and the structures passing through these compartments. So let's talk about the fourth compartment. So if I am talking of the fourth compartment, four structures are passing. That is extensor digitorum, extensor indicis, anterior interosseous artery, will pass, and posterior interosseous, yes Punit, and posterior interosseous nerve will pass. Posterior interosseous nerve will pass. Okay, Punit, yes, so we are talking about extensor compartment and writing all. So that means 4 structures are passing through the 4th extensor compartment. ED stands for extensor digitorum. EI stands for extensor indicis. And one artery, that is anterior interosseous artery, and one nerve is posterior interosseous nerve. Now talking about the 5th compartment, the structures passing through the 5th compartment is extensor digiti minimi. Is the extensor digiti minimi muscle, and through the 6th compartment the structures passing is extensor carpi ulnaris. Is extensor carpi ulnaris. So we have got extensor carpi ulnaris through the 6th compartment. So we have got all the 6 extensor compartments, and we can see all the structures passing through this individual extensor compartments. Oh yes, Puneet, good afternoon dear, good afternoon. Good afternoon, and let's so I am discussing the extensor compartment. We have already covered the extensor compartment. Now I would like, so we are discussing the, so we can use this image only. So I will just rub this another one because one image is enough for it. So the next topic which I want you to teach is anatomical snuff box, a very easy topic but very important. Actually, if I talk about the previous year of FMG examination, so if I am talking about the previous year of FMG examination, they have asked so many questions from this topic. So there has been a topics, so many times this question has been asked. So that is very important that you should be aware of this topic. Yes, anatomical snuff box. Yes, you are right, dear, anatomical snuff box. So let me enlarge it. So if I am talking about anatomical snuff box, so see here, this is anatomical snuff box. So we have got two tendons here. So let me just show you the two tendons. So we have got here you can see there is one tendon. This is the extensor pollicis longus tendon, and here we have got abductor pollicis longus and extensor pollicis brevis tendon. So we have got extensor pollicis brevis, abductor pollicis longus. These two tendons are forming the anterolateral boundary, and extensor pollicis longus is forming posteromedial boundary. Yes, Punit, you are right. And the floor is having, the anatomical snuff box floor is having the scaphoid bone and that of trapezium, and the artery which is running into it is the radial artery. Actually, you should also know the contents of the, so it is also important that you should know the contents which is residing in the roof. So if I am talking about the roof is having, if I am talking about the roof of anatomical snuff box is having cephalic vein crossing and the superficial branch of radial, superficial radial nerve is also lying there. So superficial radial nerve is also lying as the content for anatomical snuff box. Okay, dear. If any of the students is not understanding anything, please let me know. Okay, so write down. So write down boundaries of anatomical snuff box. Boundaries of anatomical snuff box. So boundaries of anatomical snuff box. So if I am talking one from, yes, Punit, you are absolutely right. So we have to know about the boundaries of anatomical snuff box. So let's talk about the boundaries. Boundaries of anatomical snuffbox. So boundaries are posteromedially, so posteromedially it is bounded by which two tendons? Posteromedially just one tendon, extensor pollicis longus. Anterolaterally we have got two tendons, abductor pollicis longus and extensor pollicis brevis. Abductor pollicis longus and extensor pollicis brevis. Content. If I talk about the content of anatomical snuff box is radial artery. Yes, Punit, you are absolutely right. Yes, Punit, you are absolutely right. Floor. Floor contains, floor is made of, it is having the bones, it is having scaphoid bone and it is having trapezium. So it is having scaphoid and floor is having scaphoid and trapezium. Floor is having scaphoid and trapezium. Now if I talk about the roof of anatomical snuff box is having skin and superficial fascia. The skin and superficial fascia. And we have to know the contents which is lying in the superficial fascia. It's also important that you should know the contents which is lying in the superficial fascia of anatomical snuff box. So the structure crossing the superficial fascia is the cephalic vein which is crossing, and we have got the superficial branch of, radial nerve, superficial branch of radial nerve. Okay, so we have got the superficial branch of radial nerve which is crossing the roof, Got it? So this is about the boundaries of anatomical snuff box. Now I would like to tell, and one more clinical aspect is related to it, the clinical significance. So if I have to tell the clinical significance of anatomical snuff box, so if I am talking about the clinical significance of anatomical snuff box, the clinical significance is that the radial artery which is palpated. So we have seen here that this is the radial artery which is palpated in the region of anatomical snuff box. So the radial artery is, pulsation of radial artery can be felt in the anatomical snuff box, and tenderness, if there is pain and tenderness in anatomical snuff box, we know the floor is having scaphoid bone and trapezium. So the scaphoid bone is most commonly injured in anatomical snuff box, and if the scaphoid bone is injured, what will happen? The peculiar blood supply is there in the scaphoid bone. So if I talk about scaphoid bone, it is having a peculiar blood supply from dorsal aspect. So the complication which is associated with the anatomical snuff box will be avascular necrosis of scaphoid bone. Now this is showing you the mid palmar and the thenar spaces. So actually I will also talk about these spaces in detail afterwards. So I just want spaces of hand. I will spaces of hand. So I will include the spaces of hand as a separate topic because I have got so many images after that. But before that, can we solve few MCQs? All of you, all the students, those who are live, can we solve few MCQs related to the upper limb? So let's solve few MCQs related to the topic. Yeah. So sorry. Now structures. So Puneet, Snowflake, Aradha, Saif Ali, Nikita, Medico, Aurora. Please mark the right answer. The structures related to deltopectoral groove. I got an answer from Punit and Punit has marked absolutely right answer. So Pinith has marked absolutely right answer. The correct answer is cephalic vein. I would like to show you an image for which will help you to understand why cephalic vein, which will help you to understand that cephalic vein is lying in the deltopectoral groove. When I am talking about deltopectoral groove, there is a groove which is formed between the deltoid muscle and the pectoralis major muscle. So here you can see this image, in which we can outline this. This is the deltoid muscle. This is the deltoid muscle, and this is exactly the pectoralis major muscle. This is exactly the pectoralis major muscle, and in between these two muscles, so in between these two muscles, if we will talk, in between these two muscles, the vein which is traversing, so see the vein which is traversing, so the vein which is traversing is the cephalic vein. So this is the vein which is traversing between these two muscles, and this is the cephalic vein. So the correct answer is cephalic vein. So the correct answer is cephalic vein. Okay. Now talking about the second, clavipectoral fascia is derived from which ligament? So the question is, clavipectoral fascia is derived from which ligament? Clavipectoral fascia is derived from which ligament? Actually, I didn't told you about clavipectoral fascia. Let me just know if anybody can answer. Otherwise, I will explain you this topic. That is clavipectoral fascia. I will explain you the topic of clavipectoral fascia. Clavipectoral fascia is derived from which ligament? Anyone who wants to answer? Costocoracoid, costocoracoid. So let me see. Only Punit has given the answer. What about others? Punit has given the answer. What about others? So Punit has given absolutely right answer. A great thumbs up goes for him. Absolutely correct. So Punit has given absolutely right answer. Yes. Clavipectoral fascia is derived from costocoracoid ligament, and this is absolutely right answer. This is absolutely right answer. So I just want everybody to understand this image. Actually, clavipectoral fascia, I will explain clavipectoral fascia in brief so that it becomes easy for you to understand. So let's talk about clavipectoral fascia in brief. So when I am talking about clavipectoral fascia, first thing is that you should know it is a fascicle sheath. So you can see this image and you can understand that it is a fascicle sheath. So exactly this, let's use a green color for this. This is the investing. So this is the investing layer of deep cervical fascia. This is investing layer of deep cervical fascia. Okay, and if we talk about this, it is lying deep to the clavicular head of pectoralis major muscle, and exactly this is filling the gap between the pectoralis minor and that of the subclavius muscle. So lower to the so here we have got this as the clavicle. So this is as the clavicle. So here we have got this structure as the clavicle. So lower to the clavicle, what you can see, it has enclosed one muscle, subclavius muscle, and then again enclosed pectoralis minor muscle, and lower down it has merged with the axillary fascia. So it has merged with the axillary fascia, and here you can see the pectoralis major muscle is covered by pectoral fascia. So clavipectoral fascia is vertically extending below the clavicle and lower down merging with axillary fascia, and it is enclosing two muscles. So one is the two muscle enclosed by it. So it is enclosing two muscle. The one is the subclavius, another is the pectoralis minor muscle. Now that was a vertical tracing. Now I will show you another diagram where you can see this is the clavicle and the first rib. So you can see, so here in this image you can see this is the clavicle, and below it this is the first rib. So here you can see this is the so here exactly Now, the small muscle is the subclavius muscle. This small muscle is the subclavius muscle. This is subclavius muscle. Now, if we talk about the horizontal extent, so medially you can see the clavipectoral fascia is merging with the intercostal space of first second rib and with the costoclavicular ligament. Laterally, it is merging with coracoclavicular ligament. And if I talk about the extent, so exactly what happens? The thick upper part of the fascia, which is extending from costochondral junction to coracoid process. So if I am talking about the thick upper part of the clavipectoral fascia, which is extending from costochondral junction to that of the coracoid process, this part of the ligament is called as costocoracoid ligament. So that is important. So please write down. Then we should also know the structures piercing clavipectoral fascia. So please write down the clavipectoral fascia. So write down the details of clavipectoral fascia. So heading will be clavipectoral fascia. The heading will be clavipectoral fascia. So if we talk about clavipectoral fascia, it's a strong fascicle sheet. So it is a strong fascicle sheet. It is a strong fascicle sheet deep to clavicular head of pectoralis major muscle. It is filling the gap between the pectoralis minor and that of the clavicle. So vertical. Now the vertical extent. Vertically it extends below clavicle enclosing subclavius and pectoralis minor and below it merges with so it is merging with which structure? So below it is merging with axillary fascia. So this is about the extent vertical. Now what we have to understand, also we have to understand the horizontal extent, because the question which has been asked from this topic was about the horizontal extent. Yes, Mr. Jayant, hello. Yes, Mr. Jayant, hello. So let's talk about also the horizontal extent, because that will give us the right answer. So, and then we'll talk about the structures piercing clavipectoral fascia. So write down the horizontal extent. So the horizontal extent. So we will talk about the horizontal extent. Let's talk about the horizontal extent. So if we talk about horizontal extent, okay, so medially, if we talk about horizontal extent, medially it is attached to medially clavipectoral fascia. It is, if we talk about medial attached, so medially it is attached to first rib and costoclavicular ligament Other than that, it medially blends with intercostal membrane of upper two intercostal space, upper two intercostal space, upper two intercostal space. So this is about medial extent. Now laterally, if I talk about its extent, so laterally, if we talk about the extent, so laterally, so medially it is blending with intercostal space, and laterally, if we talk about laterally, it is attached to the coracoid process of scapula, blends with, and it blends with the coracoclavicular ligament, coracoclavicular ligament. But if we talk about the upper part of clavipectoral fascia, that is formed costocoracoid ligament. So also you can write upper part of, this is very important and has been asked in the MCQ, which we have just now explained. Just now Puneet has also given the right answer for that question. So upper part of fascia, upper part of clavipectoral fascia extending from first rib. So it is extending from the first rib to the costochondral junctions, to the costochondral junction, to coracoid process of scapula. So coracoid process is termed as costocoracoid ligament. It is termed as costocoracoid ligament. It is termed as costocoracoid ligament. It is termed as costocoracoid ligament. Got it? It is termed as costocoracoid ligament. Done? Now let's talk about next MCQ. So can anybody give me the right answer? Which of the following statement is false statement? So everyone, those who are present, please mark the right answer. False statement about ulnar nerve. Which of the following is a false statement about ulnar nerve? Please mark the right answer. Puneet is telling B. No, we have to know the false statement, dear. False, wrong statement. Puneet, that is the right one, no? That is right one, dear. We have to know the B is right. Yes, B is right. And C fibers is from lateral cord. A is also right. So, which is the wrong statement? I have explained it also. C7 fibers is derived from lateral cord only. C7 is a part of lateral cord only. No, that is not the right answer. Absolutely wrong answer. Which is the absolutely wrong option? Which is absolutely wrong option? Those who have attended the previous session of mine, when I was explaining you radial nerve, you must be knowing that radial nerve is passing between the two heads of supinator muscle. So basically the most incorrect statement is D. So the right answer will be D. So what will be the right answer? The right answer will be D. Is it okay? Yes, Puneet, because radial nerve is passing. Radial nerve passes between the two heads of supinator muscle. So if you will see, the ulnar nerve and ulnar artery, it is passing in relation to flexor digitorum. So ulnar nerve and ulnar artery is passing in between the flexor digitorum profundus and FCU, flexor carpi ulnaris. Flexor carpi ulnaris. So this we have done. Here you can see this diagram where you can understand this is the supinator muscle. This is supinator muscle. And can you see PIN? What is PIN? PIN, what is the full form of PIN? It is posterior interosseous nerve. It is posterior interosseous nerve. And posterior interosseous nerve is passing between supinator muscles. So the right answer is D. So the right answer is D. So the right answer is D. Yes, yes, Puneet, now you got it right. So posterior interosseous nerve passes between the two heads of supinator muscle. So we will mark supinator as the right answer. Now coming to the next, arteries forming anastomosis around surgical neck of humerus. So the artery which is running along the surgical neck of humerus is a branch of which artery? First part of axillary artery, second part of axillary artery, or third part of axillary artery? So please mark the right answer. Arteries which is forming anastomosis around the scapular, about the surgical neck of humerus is branch from which part of axillary artery? So the hint is the artery which is related to surgical neck of humerus you have to know, and then you have to tell me it is a branch of which part of axillary artery. Okay, dear. So which is the right answer? No, it's from the third part. The right answer is third part of axillary artery. The artery forming surgical neck anastomosis is which artery? Is the posterior circumflex humeral artery and the anterior circumflex humeral artery. And we know that posterior circumflex humeral, anterior circumflex humeral artery is a branch of third part of axillary artery. So here you can see in this diagram, let me just enlarge. Can you appreciate here that the posterior circumflex humeral and the anterior circumflex humeral, these are the arteries which is forming anastomosis around surgical neck of humerus. This is forming anastomosis around surgical neck of humerus. This is forming anastomosis around surgical neck of humerus, the posterior circumflex humeral and the anterior circumflex humeral. So these two arteries are the branch of third part of axillary artery and leading to the formation of surgical neck of humerus. Surgical. So this is forming anastomotic network around surgical neck of humerus. This is forming an anastomotic network around surgical neck of humerus, and these two are the branches of third part of axillary artery. Now, bicipital aponeurosis is lying over which structure in the cubital fossa? Bicipital aponeurosis is lying over which structure in the cubital fossa? Anyone? Bicipital aponeurosis lies over which part of in the cubital fossa? So we know that biceps tendon flattened to form bicipital aponeurosis. It is covering which structure? It is covering brachial artery, anterior interosseous artery, radial nerve, or median cubital vein. Very important. Please mark the right answer. So please mark the right answer, dear. Bicipital aponeurosis lies over which structure in the cubital fossa? Anyone? So actually, I just want you to show this image. Here you can see brachial. So Punit is saying brachial artery. It's absolutely right answer, Punit. You are absolutely right. Yes, it's absolutely right answer. C is absolutely right answer, Punit. You are absolutely correct. See here, this structure which you are seeing is the bicipital aponeurosis. This is an extension from biceps tendon. So this is an extension from, so this is the bicipital aponeurosis, and you can clearly see here it is an extension from biceps tendon. Now, if you will see this image, you can see bicipital aponeurosis is running over which two structures? So it is running over brachial artery and median nerve. So it is running over brachial artery and median nerve. So you have to choose one answer. So this is the bicipital aponeurosis, and this bicipital aponeurosis is running or covering the brachial artery and median nerve. So definitely if we have to go with one answer, we will go with brachial artery. We'll go with brachial artery. Now, third extensor compartment of wrist contains which of the following tendon? Third extensor compartment of wrist contains which of the following tendon? So the question is, third extensor compartment of the wrist is containing which of the following extensor tendon? If you remember, I have told you about all the 6 extensor compartment and I have given you the list of structures passing through individual extensor compartment. Now through the third extensor compartment, you have to tell which structure is traversing through the third extensor compartment. Third extensor compartment. Which structure passes? Please mark the right answer, dear. Third extensor compartment of wrist contains which tendon? Absolutely correct. Yes, dear. The extensor pollicis longus is absolutely correct answer. Yes, dear. Yes, absolutely correct. Jay Chandra and Punit, both of you are absolutely correct. Now you can take a few seconds to read this MCQ. I will read it for you and then you can mark the right answer. So let me read it for you. It's a very important question. It's a clinical and image based question. A 56-year-old man come to emergency department because of persistent left wrist pain. So because of persistent left wrist pain, while walking his dog 5 hours ago, he fell forward to the ground and landed on his outstretched left hand. Examination shows mild swelling over the dorsum of the left hand and there is preserved range of motion. There is point tenderness. So there is point. Jay Chandra Mohan ma'am, can you please provide the annotated notes? Yes, dear, that will be shared with the team and you can contact the team for the notes. Okay. There is point of tenderness present over the anatomical snuff box and X-ray of his left wrist is shown. Can you tell the greatest risk of developing the complications? Okay. So the option is avascular necrosis, carpal tunnel syndrome, Dupuytren contracture, osteomyelitis, compartment syndrome. So what will be the, so basically I will highlight the keywords. The keywords is the lesion is in the anatomical snuff box. So the lesion is in anatomical snuff box. So what will be the complication? So tenderness is, there is tenderness in anatomical snuff box. So what will be the complication in this case? So I just want also to show you this X-ray. No, Puneet. So see here, this bone is which bone? This is which bone, dear? This is U for ulna and this is R for radius. And these are carpal bones. So anatomical snuff box is injured. So you can see anatomical snuff box is injured. So one of the bone is injured here. So what is the mnemonic for the carpal bones? Scaphoid bone is injured. Yes, Punit, you are right that the scaphoid bone is injured. So this is S for scaphoid bone. L for lunate. C looks too pretty. Try to catch her. So this is trapezium and this is TRI, tricutal. This is C for capitate and this is H for hamate. So C looks too pretty, try to catch her. So most common fractured bone in the anatomical snuff box will be the scaphoid bone. Yes, Punit, C looks too pretty, try to catch her. So here C for scaphoid, L for lunate, try to catch her, tricutal, pisiform, trapezium, trapezoid, capitate and hamate. So here the bone which is fractured at this location is the scaphoid bone which is fractured at this location. So when the scaphoid bone is fractured, what will be the complication? Now tell me the right answer. What will be the complication? I have explained you in the anatomical snuff box. I have explained you in the anatomical snuff box. Yes, carpal tunnel is related with median nerve, dear. So the complication associated here will be avascular necrosis. I will explain why. Because scaphoid bone, which bone is forming the floor of anatomical snuff box? Scaphoid bone. So scaphoid bone is forming the floor of anatomical snuff box, and when it is injured, when the scaphoid bone is injured, what will happen? If the scaphoid bone is injured, what will happen? The fracture occurs, and we know that scaphoid bone has got a peculiar type of arterial supply. So it is having a peculiar type of arterial supply which is reaching from the distal pole in some cases. So what will happen? This will lead to a complication of avascular necrosis. So write down the name of carpal bone. So the proximal. So we have carpal bones in the proximal row and we have carpal bones in the dorsal row. So there is a proximal row of carpal bone and there is a dorsal row of carpal bone. So if we are talking about the proximal row of carpal bones, then the part is C looks too pretty. C looks too pretty. Try to catch her. So here S for scaphoid, L for lunate, T for tricutal, and P for pisiform. P for pisiform. T for trapezium, another T for trapezoid. C for the largest carpal bone, capitate, and H for hamate. So this is the relation of carpal bones as you move from lateral to medial. So this is how the carpal bones are arranged if you move from lateral to medial. So this is the relation of carpal bones as you move from lateral to medial. So there is two rows, there is proximal and there is distal row. So the mnemonic is C looks too pretty, try to catch her. C for scaphoid, L for lunate, T for tricutal, P for pisiform, dorsal row, trapezium, trapezoid, capitate and hamate. Now, why the answer is avascular necrosis? Can you see this image? So when I am enlarging this image, you can again see that this is the, so you can again see this is the radius bone and this is the ulnar bone. These are the carpal bones. So here the fracture has been taken for the scaphoid bone and you can see the dorsal scaphoid branch, radial artery dorsal scaphoid branch is reaching from the dorsal aspect. So when it is fractured, what will happen? Blood supply scaphoid bone is affected and this will lead to the condition of avascular necrosis. Now, interosseous recurrent artery is a branch of, interosseous recurrent artery is a branch of, interosseous recurrent artery is a branch of, question number, interosseous recurrent artery is a branch of anterior interosseous artery, posterior interosseous artery, common interosseous artery or radial artery. Please mark the right answer. Interosseous recurrent artery is a branch of which of the following? So here goes a thumbs up for Puneet and he is absolutely right. I think he was present when I was explaining this point. So very good Puneet, very good. It is a branch from posterior interosseous artery. Yes, it's a branch from posterior interosseous artery. So very nice dear Puneet. So here you can understand interosseous recurrent artery is a branch from posterior interosseous artery. Posterior interosseous artery is a branch from common interosseous artery. And common interosseous artery is a branch of ulnar artery. Common interosseous artery is a branch of ulnar artery. And common interosseous artery is a branch of ulnar artery. Absolutely correct. The same thing has been shown in this image. Interosseous recurrent artery, branch of posterior interosseous artery, which is a branch from common interosseous artery, and common interosseous artery is a branch from ulnar artery. Now, carpal tunnel contains all the important structure except which of the following is not exactly inside the course from medial epicondyle humerus? Yes, dear? Okay. Now, can you tell me carpal tunnel contains all of the following structure, but one of the structure is that is neither going superficial nor going deep to the flexor retinaculum, but it is passing in between the flexor retinaculum. So, I have explained in the topic of flexor retinaculum. So, carpal tunnel is containing all of the following structure, but one of the structure is passing in between the flexor retinaculum. What is that structure? What is that structure? That structure, Puneet is absolutely right, and he is live in the session, so he is able to solve all the MCQs. Very good, Puneet. Yes, you are absolutely right. That is flexor carpi radialis, which is neither passing above nor passing below, but passing to and fro the flexor retinaculum. Absolutely correct. You can see this. This is flexor retinaculum, Y shape. This is the flexor retinaculum, Y shaped structure. So this is the flexor retinaculum Y-shaped structure, and there is one tendon which is passing. So you can see this tendon, and this is the tendon which is passing in gap between the flexor retinaculum. So this is a tendon which is passing in gap between the flexor. So this is flexor carpi radialis, and you can see it is passing in between flexor retinaculum. Absolutely correct. Yes, Punit, digitorum is both present. Digitorum is both present. Now, content of mid-palmar space is all except. Content of mid-palmar space is all except. So, I will explain the mid-palmar space. If you are not knowing, don't worry. Just try to give the right answer. If you are not able to write it correct also, I will come with the explanation. Mid-palmar space. Content of mid-palmar space is all except. Content of mid-palmar space is all except. A? No, no. The right answer is first lumbricals. The right answer is first lumbricals. So don't worry. I have not explained this topic yet. So I will explain this topic also. Don't worry. I will explain, then you will get the right answer. See here. Actually, to understand this topic, you have to understand that this is the hand, palm. This region is thenar space, which is lying in relation to thumb, and this is the mid palmar space. This is thenar space, and this is the mid palmar space. So exactly, if we are talking about the structure, so exactly there is medial palmar septum, there is lateral palmar septum, and there is intermediate palmar septum. Okay, so this space which is lying in between the medial and intermediate palmar septum, this space is the mid palmar space, and this is the thenar space. This is the thenar space. I will use different color for this. So this is the mid palmar space, and this is the thenar space. So here what happens, the thenar space, so in blue color is the thenar space. So this is the thenar space, and this is the mid palmar space. So basically what you see, that this is the yes, Punit, now you are right. So it is the mid palmar, and this is the thenar space. So basically, if you will see this finger also, you can understand. So that means laterally we have thenar space, though FDP tendon lateral for index finger and flexor pollicis longus will be related to thenar, and mid thenar space, mid palmar space will be related to the medial fingers. So actually first lumbrical is arising from first lumbrical. So first lumbrical will be lying laterally and will be the content of thenar space. This will be the content of thenar space. This will be the content of thenar space. Okay. So that is why we will mark this as the right answer. Actually, I have kept this topic in the spaces of the hand. So separately also I will take a class on this topic. So don't worry, we are coming to it. Now I just want everybody to go with the topic of shoulder joint. So important points about shoulder joint. Is it okay? Everyone? Let's complete the next topic, the shoulder joint. So shoulder joint is a highly mobile joint. So if I am talking about type, it is a ball and socket type of synovial joint, and you can see the glenoid cavity is quite shallow. Actually, the glenoid cavity is deepened by the glenoid labrum so that it can articulate with the head of humerus. So this is the glenoid cavity and it is quite shallow. And this will articulate with the head of humerus to form glenohumeral joint, which is the other name of shoulder joint. So it is articulating with the head of humerus. So if I talk about the joint, so you can just write glenohumeral joint, which is the shoulder joint. It is a type of ball and socket type of sign. It is a type of ball and socket type of synovial joint. It is ball and socket type of synovial joint. So it is ball and socket type of synovial joint. It is ball and socket type of synovial joint. Now we will see the important ligaments. So it is important that you should know all the ligaments of the shoulder joint. So for understanding the ligaments, we have got fibrous capsule, we have got glenohumeral ligament, we have got coracoacromial ligament, we have got transverse acetabular ligament. So transverse humeral ligament. So many ligaments are there. So firstly, in this diagram you can see the fibrous capsule. So here you can see this is the fibrous capsule. So fibrous capsule is loosened inferiorly, otherwise it is attached to the anatomical neck region and it is loosened inferiorly. So it is loosened inferiorly, as you can see. This is the fibrous capsule. Which is communicating with the subscapular bursas. So if I talk about the attachment of fibrous capsule, it is lying beyond the glenoid labrum and it is extending downwards 1.5 centimeters. So only the inferior aspect of shoulder joint is less stable. So actually one of an important point about shoulder joint is it is highly mobile joint in our body. So it is the least stable. It is not stable much, but it is a very mobile joint in our body. Other than that, when you see the interior of the joint, when you see the interior of the shoulder joint, so when you see the interior of the shoulder joint, you can see following ligaments. So in the interior, you can see the glenohumeral ligament. So this is the superior glenohumeral ligament. This is the superior glenohumeral ligament. This is the middle and inferior glenohumeral ligament. This is the middle and inferior glenohumeral ligament. This is superior glenohumeral ligament. This is the middle and inferior glenohumeral ligament. Okay. So glenohumeral ligament is giving strength. So when I am talking about the glenohumeral ligament, which is having three parts, superior, middle, inferior glenohumeral ligament, actually it is giving strength to the anterior aspect. It is giving strength to the fibrous capsule. Other than that, we will also have the glenoid labrum. So this is the glenoid cavity. It is surrounded by glenoid labrum which is made of fibrocartilaginous ring, which is deepening the glenoid fossa and increasing the stability of shoulder joint. And superiorly, we have got the coracoacromial ligament. Superiorly, the coracoid process and the acromial process is connected by coracoacromial ligament. This is coracoacromial ligament. So here you can see the fibrous capsule is having a gap. So this is the long head of biceps brachii and it is passing through the fibrous capsule. So long head of biceps brachii is forming through the fibrous capsule. So coming to few ligaments. So please write on the details of the ligaments. So firstly, write on the name of the ligaments of shoulder joint. Write on the name of heading, you write down ligaments of shoulder joint. So firstly, it is important that you should know the name of all the important ligaments of shoulder joint. So what is important for you is to know the name of all the ligaments of shoulder joint. The names are fibrous capsule, then we have got glenohumeral ligament, then we have got coracohumeral ligament, then we have got coracoacromial ligament, and lastly we have got transverse humeral ligament. Okay, so these are the important ligaments of shoulder joint, and you have to know basic features of these ligaments. So you have to just know the basic features of these ligaments. So let's talk about these ligaments. Yes, you are right, Puneet. It is a ball and socket type of synovial joint. So yes, dear. So let's write about this. So the first ligament is fibrous capsule. So if I talk about fibrous capsule, the fibrous capsule surrounds the glenohumeral. The fibrous capsule surrounds the glenohumeral ligament, and attached medially to the margin of glenoid cavity beyond glenoid labrum, and inferiorly extends downwards. So inferiorly it is extending downwards approximately 1.5 centimeters. So only the inferior aspect of shoulder joint is not stable, and exactly so only dislocations of shoulder joint is quite common. Now here, if you see the interior aspect, you can definitely see the superior glenohumeral ligament. You can see the edge of middle and inferior. So here you can see the middle and inferior glenohumeral ligament has also been shown. So this is superior glenohumeral ligament, this is middle glenohumeral ligament, and this is the inferior glenohumeral ligament. So glenohumeral ligament is having three parts. So you can see it is. So exactly if I talk about glenohumeral ligament, it is giving support to the interior of, it is increasing the stability of shoulder joint, and it is actually giving stability. So these are thickening of the anterior. So in other words, if I have to define the glenohumeral ligament, it is of three types: superior, middle and inferior. So exactly it is the thickening of the fibrous capsule and the anterior aspect and giving support to the fibrous capsule. So here I just want, and this, in this diagram you can see the glenoid labrum. So here you can see the glenoid labrum has been shown. So basically the glenoid labrum is there, which is deepening this cavity. So we have got the glenoid labrum here. On superiorly, if you will see, so superior aspect, you can see the coracoacromial ligament. So this is the coracoacromial ligament which is giving superior support. So here you can see this is the coracoid process. This is the coracoid and acromial process. This is C for coracoid and this is A for acromial process, and both of these are connected by coracoacromial ligament. That means coracoacromial ligament is giving superior support to that of the shoulder joint. So we will talk about this ligament. So write down about the ligaments. So the second ligament is glenohumeral ligament. Is the glenohumeral. The second ligament is glenohumeral ligament. So when we are talking about the glenohumeral ligament, these are the three thickenings. These are three thickenings of anterior aspect of, these are the three thickenings of the anterior aspect of fibrous capsule, Okay, giving the support. So basically it is of three types, A, B, C, you can write. So it is of superior glenohumeral ligament, middle glenohumeral ligament, and inferior there is superior glenohumeral ligament, there is middle glenohumeral ligament, and there is inferior glenohumeral ligament. Okay, now we have done with this. Now we will talk about the third ligament, that is coracohumeral ligament. The next is coracohumeral ligament. So when we are talking of coracohumeral ligament, it's strong band. So it is basically connecting, this ligament is connecting the coracoid process of the scapula with that of the greater trochanter or greater tubercle, with that of the greater tubercle of the humerus. Connect with the greater tubercle of humerus. The fourth is transverse humeral ligament. Transverse humeral ligament. So transverse humeral ligament is bridging the gap of, so it bridges the gap of bicipital groove. It is bridging the gap of bicipital groove, and exactly the bicipital groove between the GT and LT, that is the greater and the lesser tubercle. So it lies between the GT and LT, that is greater and lesser tubercle, and beneath it passes the long head of biceps brachii. So beneath it passes the long head of biceps brachii. And the fifth ligament will be coracoacromial ligament. And as I already told you, coracoacromial ligament is connecting the coracoid and acromial process. So it is giving superior support to the shoulder joint. So it is basically giving superior support to the shoulder joint. Okay. So my dear students, are you understanding? Any doubt? Please let me know. Yes, Paul, Phoenix, you are right, and also Punit. So yes, so we have done with this ligament, but factors stabilizing the shoulder joint. So one of an important factors which is stabilizing the shoulder joint is rotator cuff muscle. What is it? It is the rotator cuff muscle, which can be known by the mnemonic SITS. So here SIT is for SITS. So SIT for supraspinatus, infraspinatus, and T for teres minor attached onto the greater tubercle, and on lesser tubercle we have got subscapular. So actually this four muscle which is called as SITS, SITS, this four muscle which is termed as SITS is important. Why? The reason why it is important I will tell you, because these are called as rotator cuff, which is keeping the head of humerus medially towards the shallow glenoid fossa. So one of the important support of glenoid fossa is the glenoid labrum, other is the rotator cuff muscle, and other is superior support is given by coracoacromial ligament along with the coracoid and acromial process. So here SIT SITS stands for, so here rotator cuff muscle. So rotator cuff muscle, the mnemonic is SITS. So here S stands for supraspinatus muscle, I for infraspinatus muscle, T for teres minor muscle, S for subscapularis muscle. So basically these three muscles are inserting into greater tubercle of humerus, and this is on the lesser tubercle of humerus. So they are keeping the head of humerus medially pulled along the glenoid fossa. So this is giving additional support to the shoulder joint. Yes, Puneet. And the so actually Punit has raised a very important point, that subscapularis muscle tendon is called as the forgotten tendon. Yes, you are absolutely right. It is the forgotten tendon of rotator cuff. The reason is that if you will see the literatures and books, the mention of subscapularis muscle is least important. They have given least important to subscapularis muscle tendon, but it is not the case. It is very important rotator cuff muscle, giving support to the head of humerus. So it is also regarded as the forgotten tendon. Absolutely correct, Punit. You are absolutely correct. So subscapularis muscle is also called as the forgotten tendon. Yes, this is musculotendinous support to the shoulder joint. Now movements. So now a very important topic which everyone should understand is the movement of shoulder joint. So if I am talking about the movement, so arterial supply and all will be the corresponding arteries. What are the arteries which is giving its support? So we know that arteries are like suprascapular artery, the subscapular artery, the anterior and posterior circumflex scapular artery. Nerve is by axillary nerve, suprascapular nerve, musculocutaneous nerve. Now what is very important is to know the movements of the shoulder joint, because shoulder joint is a highly mobile joint. So it will have movement in the three plane. Shoulder joint will have movement in the in the three planes, antero-posterior, in the vertical, and in the transverse plane. Actually the movement is occurring is flexion, extension, abduction, adduction, medial rotation, lateral rotation, and combination of these movements are called as circumduction. So I just want everyone to understand the movements and the muscle causing this movement. So let's start with this. Let's start with the topic of movements of shoulder joint. So the first movement which I want everyone to understand is the flexion. So we have to know which all muscle is causing flexion of shoulder joint. So we have to know which all muscle is causing flex. So we have to know the main muscle causing flexion of shoulder joint and the accessory muscle causing the flexion of shoulder joint. So main muscles or the prime movers of shoulder joint is following. So main muscle causing shoulder movement is pectoralis, major muscle. pectoralis major muscle, then we have got the deltoid muscle. Actually, deltoid muscle, anterior fibers are causing. Deltoid muscle, anterior fibers are causing flexion. Pectoralis major muscle, clavicular part is causing. Clavicular part is causing the flexion of shoulder joint. And if we talk about accessory muscle, so if this is about the flexion, and if we talk about the accessory muscle, so if we talk about the accessory muscle, so accessory, this was the prime flexors of the shoulder joint. Now if we talk about the accessory muscle, the accessory muscles are biceps brachii, coracobrachialis muscle, and also so these are the accessory muscle. Now talking about the second movement, that is extension. The second movement is extension of shoulder joint. The second movement is extension of shoulder joint. The second movements are extension of shoulder joint. So if we are talking about the extension of shoulder joint, we have got following muscle causing extension. We have got deltoid muscle. So we have got the deltoid muscle causing extension. So which part of the deltoid muscle? Mainly the posterior fibers of the deltoid muscle, posterior fibers of the deltoid muscle, and also latissimus dorsi muscle. Dorsi muscle. They are the prime extensors of shoulder joint. Now coming to the other movements, so we will also share the other movements of shoulder joint like medial rotation, lateral rotation, adduction and abduction. So abduction movement of shoulder joint has got a high range of movements. So it is very important that range is more, that you should know all the abductors of shoulder joint. So many times the MCQs has been asked from this topic. So we have got the third movement, adduction of shoulder joint, and abduction of shoulder joint. So adduction movement is mainly done by, if I am talking about adduction movement, it is mainly done by latissimus dorsi and the sternocostal fibers of pectoralis major muscle. So pectoralis major muscle, sternocostal fibers. Latissimus dorsi. Adduction is also done by teres major and coracobrachialis muscle. Other than that, abduction. So let's talk about the abduction. So when we are talking about abduction, the muscle causing abduction is 0 to 15 degree of abduction, that is initiation of abduction. So if I am talking about initiation of abduction, 0 to 15 degree of abduction is done by supraspinatus muscle. It is done by supraspinatus muscle. 15 degree to 90 degree of abduction is done by middle fibers of deltoid. Middle fibers of deltoid muscle, that means the acromial fibers of deltoid, and greater than 90 degree, that is till 180 degree of abduction. This is primarily done by mainly by the serratus anterior and trapezius muscle. So it is done by serratus anterior muscle and the trapezius muscle. Now what about medial and lateral rotation? So one more movement is remaining, that is medial rotation and lateral rotation. So let's see. So we have got fourth and fifth movements. So let's write medial rotation. So medial rotation and lateral rotation. So medial rotation is primarily done by subscapularis muscle and also by teres major muscle. Teres major muscle. And also by the medial rotation is also done by deltoid anterior fibers. So you can see this deltoid muscle is having so many actions to perform. Lateral rotation is done by teres minor muscle, infraspinatus muscle, and deltoid posterior. And deltoid posterior fibers. So done with this. So we have done with the whole actions of the shoulder joint. So actually I just want you to show this image. Why? Because here you can understand the topic dislocation of shoulder joint. So actually anterior dislocation is quite common as shown in the image also. And you can see the head of the humerus is lying inferiorly. Posterior dislocation, anterior dislocation and posterior dislocation are seen, and mainly the dislocation occurs when the axillary nerve is injured. So we will have the axillary nerve injured in the case of dislocations. Now another one of the important point is supraspinatus syndrome, which is called as painful arch syndrome. So basically painful arch syndrome, what do you mean by painful arch syndrome? I will tell you the movements. So dislocation of shoulder joint can cause inferiorly because, so one more thing before proceeding to the next clinical aspect, dislocation is quite very common. Why very common? I have seen the case of recurrent dislocation of the shoulder joint. The patient is able to move it out and then again keep it inside. Now dislocation is quite common in the shoulder joint because inferiorly the shoulder joint is least supported. Inferiorly it is least supported. So dislocation of shoulder joint mostly occur inferiorly because the joint is least supported in its inferior aspect, and the injury is often involved with axillary nerve. However, clinically anterior posterior dislocation is described whether the humerus head has descended anteriorly or posteriorly. Now frozen shoulder is a condition which is seen in case of middle-aged women and when in the case of diabetic, and there is adhesive capsulitis. The fibrous capsule of the shoulder joint has become adhesive. Painful arch syndrome is also called as supraspinatus arch syndrome. The 5 reasons are there. The causes of painful arch syndrome is 5, which has to be known to you. Tear in the supraspinatus muscle. Supraspinatus muscle is actually lying below the coracoacromial ligament, and it can get suppressed, compressed by this. There is bursa also lying above it. Calcified deposit in the tendon of supraspinatus, injury to greater tubercle and supraacromial bursitis. These are the 5 regions of painful arch syndrome. So initial is the pain-free, and the distal aspect also is painful. The middle range of movement or abduction is quite painful in the case of supraspinatus syndrome. Osteoarthritis is less common in shoulder joint. So why osteoarthritis is less common in shoulder joint? Actually the reason is that you can see this is the lipping. You can see the joint capsule space. Joint space is quite reduced. So joint space is quite reduced, and osteophytes are formed and joint space is quite reduced. So the movement of shoulder joint becomes quite painful in the case of osteoarthritis, and the most common joint where the osteoarthritis is common is the knee joint, is the case of knee joint and hip joint. And basically full replacement, total knee replacement and total hip replacement is able to relieve the patient of this painful movement. So new bone small chipping is called osteophytes, and the friction and the synovial fluid has been decreased in case of osteoarthritic conditions, and the movements of the shoulder joint becomes quite painful, but it is less common as compared to hip joint and knee joint. Now briefly we will talk about the other joints. Now, briefly, I will talk about the other joints of the upper limb. So, we have got sternoclavicular joint, acromioclavicular joint, elbow joint, wrist joint, intercarpal, metacarpophalangeal joint, so and radio-ulnar joint. So, I will just tell you about the type of joint, which is very important. So, okay, yes, saddle. Yes, I will tell you sternoclavicular joint is saddle. So, let's talk about this. So, please write down the types of shoulder joint. Types of other joints. So, please write down. Shoulder joint has been done in inferiorly. If we will see, that is least supported part in the shoulder joint. So, write down sternoclavicular joint. So, sternoclavicular joint, he is absolutely right, Paul. Paul, you are absolutely correct. The type of sternoclavicular joint is, it is a saddle type of synovial joint. So, it is saddle type of synovial joint. Now, acromioclavicular joint. Acromioclavicular joint is plain type of synovial joint. Acromioclavicular joint is plain type of synovial joint. Elbow joint is hinge joint. Elbow joint is hinge variety of synovial joint. Then wrist joint. What is wrist joint? The other name of wrist joint is radiocarpal joint, because ulna is not taking part. In the case of wrist joint, ulna is not taking part, so it is also called as radiocarpal joint. And wrist joint is functionally example of ellipsoid variety of synovial joint. Functionally, it is an example of ellipsoid variety of synovial joint. It is a variety of ellipsoid variety of synovial joint. Then metacarpophalangeal joint. Metacarpophalangeal joint. So when I am talking about metacarpophalangeal joint, it is also ellipsoid variety of synovial joint. It is also ellipsoid variety of synovial joint. It is also ellipsoid variety of synovial joint. Yes, Paul, I will tell you. Yes, Paul, a very good question by Paul is coming up. Interphalangeal joint is hinge variety of synovial joint. Yes, I am coming to that point here. So, write down. Yes, Paul is asking few more. Yes, very good, Paul. Interphalangeal joint is hinge variety of synovial joint. Hinge variety of synovial joint. So yes, it's a hinge variety of synovial joint. Interphalangeal joint is hinge variety of synovial joint. And I would also like to tell you about carpometacarpal joint, which is plain type of synovial joint, and first carpometacarpal joint of thumb is again saddle type of synovial joint. So please write down carpometacarpal joint is again plain type of synovial joint. First carpometacarpal joint is, but first carpometacarpal joint is, but first carpometacarpal joint of thumb, that means first carpometacarpal joint of thumb is saddle variety of synovial joint. It is saddle variety of synovial joint. It is saddle variety of synovial joint. It is saddle variety of synovial. Intercarpal joint is also plain type of synovial. If you want to note down, you can note down. Intercarpal joint is also plain type of synovial. Intercarpal joint is also plain type of synovial joint. Okay, it's also a plain type of synovial joint. Now, a very important topic is surgically important spaces of hand. A very important topic is surgically important spaces of hand. Surgically important spaces of hand. Surgically important spaces of hand. So, when we see this transverse section, you can see two important spaces which I want definitely to be known to you. So, one of this space is thenar space and the other one is mid-palmar space. So, this is mid-palmar space. So, this is mid-palmar space and this is thenar space. Okay, so this is mid-palmar space and this is thenar space. So, there is subaponeurotic subcutaneous space, there is web space, there is lumbrical canal, there is spaces in the fora. So, we will talk individually, pulp space, individual spaces. So, basically two important spaces are there which has to be known to you. So, in this image you can see exactly below the thumb, here we have got the thenar space and below this fingers we have got the mid-palmar space. So, this is exactly the mid-palmar space and this is exactly the thenar space. This is exactly the thenar space. This is TS for the thenar space and this is MPS for the mid-palmar space. So, we have got mid-palmar space and we have got the thenar space. The details has to be known to you. You have to know about the boundaries of these spaces and you have to know about the content of these spaces and let me first explain. So, actually here also you can see MPS is the mid-palmar space and TS is the thenar space. Now, actually this image is very useful for you to understand the boundaries of these spaces. So, I think it is clear to you. Please understand this is a very conceptual topic which actually I want you to understand because if you will see this image then only you can understand. So, let me just enlarge the space. So, exactly what you can see is the transverse section at the palm. So, transverse section at the palm. So, basically I would like to highlight it. So, I would like to highlight the mid-palmar space and I would like to highlight the thenar space. Now, see here in this diagram the pink color area is the mid-palmar space. The pink color area is the mid-palmar space and the blue color area is the thenar space. One by one you have to know the spaces. See here. So, when I am talking about the mid-palmar space anterior aspect. So, if you will see anteriorly, the anterior wall will be the palm, the palmar aponeurosis will be lying there. Okay, digital nerves and the vessels, skin superficial fascia, digital nerves and vessels of the medial 3.5 of the fingers, and also the tendons of the medial fingers. So, we will have the tendons here. So, we will have the tendons here. So, you can see the tendons of the medial 3 fingers of flexor digitorum superficialis and flexor digitorum profundus. So, we have the tendons of flexor digitorum superficialis and tendons of flexor digitorum profundus. So, these are the tendons. We have the tendons of flexor digitorum superficialis and profundus tendon related anteriorly. Posteriorly, we will see there is the interossei muscles and the metacarpal bones, and on the medial aspect there is medial palmar septum, and on the lateral side they have got the lateral intermuscular palmar septum. When we are talking of thenar space, it is lying laterally below the thumb. So, it will be related with the index finger and the thumb. So, it will be related with the index finger and thumb and it will have the relation of these tendons. So, you can see the tendons related will be the tendon of flexor pollicis longus and the tendon of FDS and FDP. The tendon of FDS and FDP for the index finger and the thumb, and in the posterior aspect there will be the adductor pollicis muscle. Anteriorly there will be the lateral aspect of the palmar aponeurosis and lateral 1.5 digital nerves in the vessel, and posteriorly there will be adductor pollicis muscle. Actually, if we will see the proximal continuation of the mid palmar space, the mid palmar space will be continuing with the medial lumbrical canals, and the laterally the first lumbrical canal. So the first lumbrical muscle will be related with the thenar space. Actually, this is the distal continuation. If I talk about proximal continuation, only the mid palmar space is only the mid palmar space is communicating with that of the forearm space of Parona, but the thenar space is closed. Yes, dear, graveyard of ulnar nerve. Paul is asking which is graveyard of ulnar nerve. Paul, the graveyard of ulnar nerve is adductor pollicis muscle. Graveyard of ulnar nerve is adductor pollicis muscle. Paul has asked again a very good question, and the answer is adductor pollicis. Graveyard of ulnar nerve is adductor pollicis. Okay, Paul is adductor pollicis. Got it? Now, I just want that you can see this image where you can see the mid palmar space is communicating with the medial 3 lumbrical muscles and their web space and canal, and first lumbrical muscles and their is communicating with the thenar space. Now we will talk about digital. So firstly, please write down the details of these spaces, then we will come with this. So please write down few important points over the mid palmar and thenar space. Have you understood? Please let me know. Have you understood, dear students? So write on the heading mid palmar space. Mid palmar space. Mid palmar space. So let's talk about the mid palmar space. So mid palmar space boundaries. So let's talk about the boundaries of mid palmar space. So anteriorly, mid palmar space is related from following structures from superficial to deep. So it is related to palmar aponeurosis, it is related to superficial palmar arch, it is related to digital nerves and vessels, it is related to digital nerves and vessels of medial 3.5 fingers, medial 3.5 fingers, and it is related to ulnar bursa. It is also related to ulnar bursa, and we know that ulnar bursa is containing the tendons of medial 3 fingers, medial 3 fingers. So this is the anterior relations of the mid palmar space. What about the posterior relation? So posteriorly, the mid palmar space is related with the interossei muscles and the metacarpals, interossei muscles and the metacarpals. Laterally, it is having intermediate palmar septum. It is related with intermediate palmar septum, and laterally and medially by the medial palmar septum. By medially, it is related with the medial palmar septum. Proximally, it is continuing with the space of Parona, and distally it is continuing with the medial 3 lumbricals. All these things I have explained, I have just written so that in notes you will be able to know all these structures. Okay. So, and now I will also tell you about the thenar space quickly. So, thenar space Anteriorly, you already know it is related with the palmar aponeurosis. Lateral part, lateral 1.5 digits, lateral 1.5 digital nerves and vessels. Radial bursa containing the tendon of FPL. FPL means flexor pollicis longus, and also it is related with the tendon of index finger, FDP and FDS. And it is also related anteriorly with the first lumbrical muscle. So that means first lumbrical muscle is anteriorly related. So thenar space is anteriorly related with the first lumbrical muscle. And if I talk about anterior aspect of mid-palmar space, it is related with the 3 medial lumbrical. So that means in anterior aspect, mid-palmar space is related to medial 3 lumbrical muscle. But if we'll see the thenar space anteriorly, it is related with the following structures, and in the lateral aspect there lies lateral intermuscular septum. So lateral aspect, there is lateral intermuscular septum, there is lateral palmar septum, and in the medial side there is intermediate palmar septum, and in the proximal it is closed. Proximally it is closed. That is a good point. It is not communicating with the forearm space of Parona, and distally it is communicating with the first lumbrical canal or web canal. Okay, so we have done the detail. I have already explained. Now I want you to explain about the pulp space. So please see this diagram so that you can understand the pulp space. So if you are seeing the pulp space, you can see the pulp space is on the distal aspect of the fingers. So it is superficially having the skin and superficial fascia, and on the deeper aspect it is related with the distal 2 phalanx. So you can see it is related with the phalanx. So you can see it is related with the distal phalanx. So as you can see, it is related with the distal phalanx. So it is related with the distal phalanx. So it is related with the distal phalanx, posterior aspect, and superficial aspect. It is related. If I talk about superior aspect, it is related to distal phalanx posteriorly, and in the superficial aspect it is related to the skin and superficial fascia. Also the digital nerves and the vessels are traversing in the distal phalanx. Actually this space is commonly infected, and the infection of pulp space is called as phelon. What is it called as? The pulp space infection is called phelon or Whitlow. So we can see this. The infection of the pulp space is called as phelon. And what is the other name? The other name is Whitlow. The infection is called as Whitlow, and basically if it is there, you have to go for the surgical treatment as quickly as possible. Incisions should be made on either side. Pus will be drained and antibiotic coverage should be given to the patient so that it will not involve other spaces of the hand. So I just want you to so you can see this 3 images to understand what has to be done in this case. So you can just see the 3 space. So see the first diagram. So firstly, see this diagram. So basically, I just want everybody to know. So see the first diagram, my dear students. So ma'am, all clear. Okay, thank you, dear. So if you will see this, this is the infection. This is the pulp infection. You can see this is the pulp space infection. So this is the pulp space infection, and then in the second stage you will give a vertical incision. So in the second stage you will give a vertical incision so that the space is so that the infection of this space is drained, and in the third you can see the vertical incision is given, and then antibiotic coverage is done. Now space of Parona, actually space of Parona space is the infection of the space of forearm. Yes dear, all clear? Okay, good one. So space of Parona means the fascicle space which is lying in the infection of the distal aspect. So there is infection in this condition, there will be infection in the distal aspect of forearm. And we can have hypothenar or mid-palmar space which will communicate with the space of peroneal space of infection of forearm. So this is a axial CT scan scheme in which the distal aspect of forearm has been shown. Also we can see the tendons of the forearm, we can see the bones, we can see the pronator teres has been also shown, pronator quadratus, sorry. This is the tendons and this space is the radius R and this is the ulnar. Then the forearm distal aspect, you can see the space which is involved is the forearm space of perona, and you can see the flexor tendons are traversing pronator quadratus is shown by the star marked area, and this is the space which is commonly affected, and this is a grave condition. In this space you can see the digital synovial sheath, you can see the radial bursa, you can see the ulnar bursa, you can see the radial bursa and you can see the ulnar bursa. So ulnar bursa, if I am talking about ulnar bursa is containing the tendons of flexor digitorum superficialis and flexor digitorum profundus. Radius bursa is containing the tendon of flexor pollicis longus. It is containing the tendon of flexor pollicis longus. Okay, dear. It is containing the tendons of flexor pollicis longus. So now we have done with this. Now I have done with the two parts. Actually, there is one more part. If you want, I will explain. Otherwise, it's okay. So actually, in the third part of upper limb, what I have done, in the lower limb, what I have done, actually, we have finished all the important parts of the upper limb series, but only the muscles is remaining. So for example, lower limb has taken so much time. Why? Because I have covered the entire muscles also. So if you want, I will cover the entire muscles of upper limb also. I will cover the entire muscles of upper limb also if you want. So please let me know. So we can cover the entire muscles of upper limb also. So those students who are watching, actually I have covered. Yes, you want Paul? What about others? So it will take another 1 hour, minimum 1 hour more. So please let me know if it is okay with you. Paul is telling yes, Shaf is telling yes. Actually, yes, either I can skip this topic because only muscles are remaining. So I will require 1 hour 15-20 minutes for this. So all the cadaveric images I have included. So, okay. So let me know. So I will cover this in 1 hour 20 minutes or something, all the muscles. So all the muscles of upper limb. So it's a thing. Okay, so basically this is the third part which I want to cover up. So please let me know. Okay, Paul is telling yes, Shaf is telling yes. So can we have a break of just 5 minutes? Please let me know. 7 minutes, 7 minutes break. 7 minutes break and then I will come and start. Because it is, it will take another 1 hour 20 minutes. Okay, Paul and Shaf, I will take just a break of 7 to 8 minutes. Okay, okay, dear Shaf. Okay, okay. Break for 7 minutes. Okay. So it's just a break of 7 minutes. Then again I will come and I will complete. So please, I will only cover this topic if you are live for the session. Okay. Please be live for this session because it is another 1 hour 20 minutes on only. So please be live for the session so that I can cover up the entire topic. Okay, dear? Okay. Okay. So yes, hello everyone. Am I audible? So let me just check with the students. So this is the last part which I am taking for the upper limb series. And here everyone is back. I just came after 5 minutes only. So please let me know, are you back? Am I audible? Am I audible? Okay. So yes, I am audible. So we can start the session now. This is about the muscles. So basically we have finished all the important topics, but I just want quickly we can go with the muscles of pectoral region, the muscles surrounding the scapula, the muscles of arm, the muscles of forearm, and the muscles of hand. So this is the last topic which we have to complete today. So those who are live, so just be concentrating for these topic. Okay, is it okay, Shaf? Is it okay, Paul, Saf, and everyone? Punit. Okay. So let's start with the pectoral group of muscles. So if I am talking about the pectoral group of muscles, we have got in this category, if I am talking about the pectoral group of muscle, in this category, we have got 4 muscles, the pectoralis major, the pectoralis minor. Okay, Dr. Dive and Dr. Saf. Okay, dear. Okay. So here I just want to outline this muscle, which is this muscle. This is the so this is exactly the pectoralis major muscle. So if you will see this diagram, you can understand about the pectoralis major muscle, and you can know that pectoralis major muscle origin can be shown in this image. So you can clearly see the origin of pectoralis major muscle. So so it is having a clavicular head and sternum. So this bone which you are seeing is the clavicle. So this bone which you are seeing is the clavicle bone, and this bone which you are seeing is the sternum. This is the sternum, and this is a whole of the sternum, and this is the xiphoid process. So basically, if you will see here, you can understand. Basically, if you will see here, you can understand that the pectoralis major muscle is originating from the medial part of the clavicle. So it is arising from the medial part of the clavicle, and it is arising from, if we talk about the sternocostal aspect, the sternocostal head, it is arising from the sternum and costal cartilages. If you will see the insertion, you can see it is inserting in the humerus bone. It is inserting into the humerus bone. So that is about the origin and insertion of the pectoralis major muscle. So which muscle? We are talking about pectoralis major muscle. So it's a wide origin but having a narrow insertion. Now here I will write it, don't worry about that. Now everyone please see this cadaveric image. So everyone please see this cadaveric image to understand the attachment. So here also you can see, yes Paul, you are right, it is inserting into the lateral lip of the intercostal, lateral lip of the bicipital groove. Yes, you are right Paul, you are right Paul. Now if you will see this again, you can see this is the narrow insertion but the wider origin. So you can see the wider origin is there for the pectoralis major muscle. So it is originating from the clavicle and sternum and inserting into the lateral lip of the bicipital groove, lateral lip of the bicipital groove. Now here I just want to write the details. So I just want to write the details of pectoralis major muscle. So quickly we will write it. Origin, origin of the clavicular head. The clavicular head is originating from the medial half anterior aspect of the clavicle, medial half anterior aspect of the clavicle. Yes, sorry, and this is about the clavicular head. And the sternocostal, if I talk about the sternocostal head, so if I talk about the sternocostal head is originating from, the sternocostal head arises from lateral anterior aspect of lateral, it arises from the lateral anterior aspect of the sternum up to the attachment of 6th costal cartilage, and it also originates, so this is A and this is B, so it also originates from the medial part of 2nd to 6th costal cartilages, medial part of 2nd to 6th costal cartilage. It also originates from the aponeurosis of external, it also originates from the aponeurosis of external oblique muscle. So these are about the clavicular head. These are about the three origin of the clavicular these are about the origin of clavicular head and sternocostal head of the pectoralis major. And as I told you, it is inserted in U-shaped manner in the lateral lip of the bicipital group. So it is inserting. The insertion will be in the lateral aspect of, in the lateral lip of bicipital groove. Now talking about the nerve supply and talking about its important point. So let's talk about the nerve supply. So if I talk about the nerve supply of pectoralis major is from both lateral and medial pectoral nerve. So it is getting innervation from both. It is getting innervation from medial pectoral nerve and that of lateral pectoral nerve. And we have already talked about these nerves. What about the action? The action is very important. You have to know about the action of these muscles. So let's talk about the action. So written, the origin and insertion, and next point is action of pectoralis major muscle. So write down action. The action is the clavicular head flexes the arm, whereas sternocostal head adducts and medially rotates, the sternocostal head adducts and medially rotate the arm. So this is about the action of attachment and nerve supply of pectoralis major, the other muscle of the pectoral group. So in pectoral group, I am going to explain 4 muscles only: pectoralis major, pectoralis minor, the subclavius and the serratus anterior muscle. So let's talk about the pectoralis minor muscle. So I am just enlarging this. So when I enlarge the this muscle, when I enlarge it, you can see here that this is the coracoid process of the scapula. This is which structure? This is the coracoid process of the scapula. So this structure is the coracoid process of the scapula. So this structure is the coracoid process of the scapula, and we have got the attachment of 3 muscles on it. We have got the attachment of 3 bellies of pectoralis minor. So exactly, this is the first rib, this is the second, this is the third, this is the fourth and fifth, and this is the costochondral junction. So from the, so that means from the third, fourth and fifth costochondral junction, the pectoralis minor muscle arises and inserts on the coracoid process of the scapula and inserts onto the coracoid process of the scapula. Again, I would like to show you another image. All of you please concentrate on this. Are you understanding, dear? Are the students understanding? Okay. Yes, done. So, Paul, just see this and the other students who are present. So, many of them are getting exhausted, but they are telling me to cover up the topic, but they themselves are getting exhausted. What is this? Yes, yes, Paul, you are right. It is innervated by the, yes, you are right. It is innervated by, yes, it is, you are right. It is innervated by the pectoralis minor muscle and also by the part of pectoralis, by the medial and lateral pectoral nerve. So, this is pectoralis minor muscle. This is pectoralis minor muscle. Now, the origin is from third, fourth and fifth rib costochondral junction and insertion is on C, that is coracoid process of the scapula. So, please write on this, then we will move on the next one. So, let's write about the pectoralis minor muscle. So, pectoralis minor muscle origin. So, it arises from third, fourth and fifth. It arises from third, fourth and fifth ribs near costochondral junction, near costochondral junction, near costochondral junction. Insertion. So, we talk about insertion. So, if I talk about insertion, so yes, if I am talking about insertion, insertion is on the coracoid process of scapula. Insertion is on the coracoid process of scapula. Coracoid process of scapula. What about the nerve supply and action? So, nerve supply and action. So, let's talk about nerve supply and action. If I talk about the nerve, pectoralis minor muscle is actually it is why it is important, I will tell you, because it's also very important and it is actually giving support. So, basically it is giving support and assisting the action of also the serratus anterior muscle. It is assisting the action of serratus anterior muscle and nerve supply is similar to pectoralis major muscle. So, write down nerve supply. Nerve supply of pectoralis minor muscle, if I talk about, it is nerve supply is via medial and lateral pectoral nerve. So, it is via medial and lateral pectoral nerve. Lateral pectoral nerves. Okay. The action will be it assists the action of serratus anterior muscle of protraction. So, it assists the action of serratus anterior muscle. It assists the action of serratus anterior muscle and it also depresses the shoulder. It depresses the shoulder point and it is also an accessory muscle of respiration. It also acts as an accessory muscle of respiration. So, it also acts as accessory muscle of respiration. Accessory muscle of respiration. Done. Now, what about the fourth muscle in this group, that is the subclavius muscle. So, you can see here this is the clavicle, and the subclavius muscle is lying inferior to the clavicle. The subclavius muscle lying inferior to the clavicle. Actually, it is originating from the costochondral junction of the first rib and inserting into the subclavian groove of the clavicle. So for that, you can just see this image. So you can clearly see this is the clavicle bone, and this is the first costochondral junction. From this, the muscle arises and it is inserting into the clavicle subclavian groove. So this is the attachment of the subclavius muscle, which has been explained. And I would like to show you another image where the cut part and the point is showing you below the clavicle. This is the S for the subclavius muscle. This is subclavius muscle. Okay, just below the clavicle. Now the thing is to know about the subclavius muscle origin, insertion, and the action. So let's talk about that. So let's complete the subclavius muscle. So origin, let's talk about the origin of subclavius muscle. The origin is it arises from costochondral junction. It arises from costochondral junction of first rib. It arises from costochondral junction of first rib and insertion. So if I talk about the insertion, it is inserting into subclavian groove. It is inserting into the subclavian groove. On the inferior surface, it is inserting onto the subclavian groove on the inferior surface of the clavicle. Inserts into subclavian groove on the inferior surface of the clavicle. On the inferior surface of the clavicle. Now, nerve supply and action. So if I talk about the nerve supply, it is nerve to subclavius. So the nerve supply is nerve to subclavius, which is a branch from the trunk, and its action is to steadify or stabilize. The action is it stabilizes the clavicle. What is the action of subclavius muscle? It stabilizes the clavicle. It stabilizes the clavicle bone. It stabilizes the clavicle bone. This is the action. Done with this. Now, the next muscle is serratus anterior muscle. Serratus anterior muscle. So in this diagram, you can see the serratus anterior muscle. Why it is called serrated is already known to you. So you can see it is having serrations, and this can be 8 to 9 in number. This serrations can be 8 to 9 in number, and it is actually having 8 to 9 serrations, which is actually at the costochondral junction, and it is inserting onto the medial border of scapula. So if I talk about serratus anterior muscle, it is inserting onto the medial border of the scapula. Okay, so serratus anterior is a broad sheet of muscle. It is exactly arising from the upper 8 or 9 ribs as 8 to 9 digitation and inserting onto the costal surface costal surface of the scapula along the medial border. So it is the origin and insertion is already written here. Also you can see it is arising from upper 8 and 9 ribs as 8 to 9 digitation. Insertion is into the medial border of scapula on the costal aspect. The important point is nerve supply, which is known to you. The nerve supply is long thoracic nerve, which is also called as Bell's nerve. And the important action is it is an important protractor of the scapula. So protraction means forward scapula pulling, and this is the action of serratus anterior muscle, and protraction of the scapula, that is forward moving the scapula, is done by the serratus anterior muscle. The other important point is it is keeping the medial border of the scapula towards the vertebral column, and its lower digitation. So its lower digitations with the lower part of trapezius muscle is also involved in overhead abduction. So these are three important functions of serratus anterior. So I would like to show you another image where you can see the serrations of the serratus anterior muscle, and it is attached to the, it is originating from the ribs as shown in this diagram and inserting into the scapula bone. This is also showing you, so here in this diagram you can see the serratus anterior muscle digitations. And you can see the nerve which is supplying it is the long thoracic nerve, which is Bell's nerve. Long thoracic nerve, which is Bell's nerve. So done with this, now we'll come to the winging of scapula. As you can see, this is a case of winging of scapula because of injury of long thoracic nerve. So let me write all these points. So write on serratus anterior muscle. So what I want, so please write on serratus anterior muscle. So I would like to write only the nerve supply and action because origin insertion is already given in the image. So write on nerve supply. So if I talk about the nerve supply, the nerve supply is by long thoracic nerve. Or nerve to serratus anterior, or nerve to serratus anterior. If I talk about action, the action of this muscle is, it is a powerful protractor. So the action of this muscle is a powerful protractor of the scapula. It's a powerful protractor of scapula. It is a powerful protractor of the scapula. It keeps the medial border. It keeps the medial border of scapula. It keeps the medial border of scapula in contact with chest, chest wall. And it is also along with, so other important third point is along with the trapezius, that is mainly the lower aspect of the trapezius, lower part, it is causing, along with trapezius, it is also causing overhead abduction of shoulder joint. It also causes overhead abduction of shoulder. Okay. So done with this. Now, okay, this is, and I would like to tell also about the winging of scapula, which is seen in the condition of injury to long thoracic nerve. So actually another reason why it is causing protraction, of the scapula. So serratus anterior is also called as boxer's muscle. It is called as boxer's muscle. Now, winging of scapula occurs due to long thoracic nerve injury, So actually in this condition, what happens, if you tell the patient to push against the walls, the medial border of the scapula is protruded outwards, and this condition is called as winging of scapula. So done with this, this is showing you the clavipectoral fascia. We have already talked about clavipectoral fascia, and we have talked about the extent and all. I think the structures piercing clavipectoral fascia is remaining. So actually, if you remember, my dear students, we have already, if I remember, yes, Paul, you are right. Yes, Paul, you are right. So if we are talking about this clavipectoral fascia, attachment is already done. Structures piercing clavipectoral fascia is 4. We have got cephalic vein, we have got lateral pectoral nerve, we have got thoracoacromial artery, and we have got the lymphatics. So I just want everybody to just know, during radial mastectomy, if axillary nerve is removed, axillary lymph node is removed, which are the nerves which can be injured other than the long? Okay, yes dear, nerve to latissimus dorsi also get injured. Thoracodorsal nerve is also. Bindu, Thoracodorsal nerves can also get injured in the case of mastectomy operation, removal of the breast. Okay, dear? I will like to tell I will like to tell about clavipectoral fascia. Actually, clavipectoral fascia is already completed previous, but I missed out the structures piercing clavipectoral fascia. I will tell now. So yes, dear, let's come to this. Okay, dear, is it okay, everyone? Bindu? Okay, so clavipectoral fascia. Do you want me to write all the nerves? Bindu, you want me to write all the nerves or what? Please tell me, Bindu. Nobody. I will write it also. So Bindu's question is, in radical mastectomy, axillary lymph node removal, the long thoracic nerve is injured. Yes, you are right. Other nerves which can be injured is intercostobrachial nerve, intercostal nerves, and sometimes also the thoracodorsal nerve. So if Bindu, if you want, I can write it also. Please let me. Bindu has asked a very important question. So let me just come to that point. So Bindu has asked a question. Let me just search and so yes, you can write here. Bindu, this is for you. Nerves injured during radical mastectomy operation. So the nerves that can be injured, one is the long thoracic nerve. The other is intercostobrachial nerve. Also intercostal nerves. Also nerve to latissimus dorsi, also if it go low down means much, nerve to latissimus, thoracodorsal nerve can also be injured. But it is rarely, very rarely it is injured, thoracodorsal nerve. Is it okay? Now the next point is clavipectoral fascia. I have already completed, but I just want everybody to write on the structure. So you can write on the heading, structures. Welcome dear, welcome dear. Structure piercing, structures piercing clavipectoral fascia, structures piercing clavipectoral fascia. Ma'am, winging of scapula, please. Okay, Dr. Dive is telling winging of scapula once more. Okay. Okay, Dr. Dive. See here. See here, actually in this case, you can understand the winging of scapula. I will tell you why. So this is a case of winging of scapula. Okay, so this is the case of winging of scapula. So now why it is a case of winging of scapula, I will tell you. Actually what happened, we know that the function of serratus anterior is, so if we know that the function of serratus anterior is pushing up, it's a punching action. It has got a protraction of scapula. That means it is moving the scapula forward. So that is only, it is called as a punching and pushing muscle. So once, and we also know that serratus anterior is attached to which border of the scapula? So serratus anterior is attached to the medial border of scapula. So serratus anterior is attached to the medial border of scapula. So when the patient has to be examined, we tell the patient to push against the wall. So we want him to do the protraction action. So when he is performing that action, the medial border of scapula will be projected outwards because non-thoracic nerve is injured and serratus anterior is not able to hold the medial border towards the chest wall. So they are not able to hold the medial wall of the scapula where the serratus anterior muscle attached towards the chest wall, and it will appear like a wing that is protruded out. So the medial border of scapula, as you can see in the image, it is protruding out, and this condition is called as winging of scapula. Is it okay? Dr. Dive, is it okay? Have you understood? Okay, Dr. Dive. So structure. Okay. So now, so we will come to the structures piercing clavipectoral fascia. Now we will come to the structures piercing clavipectoral fascia. Trapezius muscle will be injured in the case of spinal accessory nerve. Paul, it will be injured in spinal accessory nerve damage. Basically, that is occurring when we will have the posterior triangle of neck is approached. Now, structures piercing clavipectoral fascia, the mnemonic is clap. What is the mnemonic? Thanks, dear. So we have the mnemonic clap. CLAP. So here C stands for cephalic vein, L for lymphatics, A for acromiothoracic wall, acromiothoracic artery, P for lateral pectoral nerve. So P for pectoral nerve, lateral pectoral nerve. So these are the four structures which is piercing clavipectoral fascia. Mnemonic is clap. C for cephalic vein, L for lymphatics, A for acromiothoracic artery, and P for pectoral nerve, lateral pectoral nerve. Now, I would like to tell about the muscles of arm. So quickly we have to complete this. I want another 40 minutes, 45 minutes more. So we will have the muscles of arm. So I want to complete the muscles of anterior aspect of arm and the muscles of posterior aspect of arm. Okay. So in the anterior aspect of the arm, we have got three muscles. Biceps, yes, BBC, yes, Paul, you are right. Biceps brachii, brachialis, and coracobrachialis. So let's complete it quickly. Let's complete it quickly. So here you can see in this diagram. So these are so one by one I want you to understand. So firstly, let me explain you the biceps brachii muscle. So when I am talking about the biceps brachii muscle, you can see this is as an image. So yes, you can see this is one and this is the other. So this is biceps brachii muscle. This is the biceps brachii muscle. So actually biceps brachii muscle is having two heads of origin, short head and long head. So when I am talking about the short head, it originates from the coracoid process of the scapula. So this is short head and this is the long head. This is the long head. So short head originates from coracoid process of scapula. And long head originates from, if I talk about long head, it originates from supraglenoid tubercle of the scapula. Supraglenoid tubercle of the scapula. Supraglenoid tubercle of the scapula. Insertion, if you will see, the insertion is onto the radial tuber. So it is inserting into our radius bone. It is inserting into our radius bone, that radial tuberosity, and medially it forms bicipital aponeurosis towards the ulna. So insertion. So write down insertion is in the form of biceps tendon. So biceps tendon will be inserting into the radial tuberosity. It will be inserting into the radial tuberosity and bicipital aponeurosis in the form of bicipital aponeurosis. So bicipital aponeurosis will be inserting into the ulnar bone. It will be inserting into the ulnar bone. Done. Now, so what will be, so we have done with the attachment, what will be the, so actually if I talk about the biceps brachii muscle, so actually all the muscles, BBC muscle is having innervation from musculocutaneous nerve, and action is biceps brachii muscle is flexing the forearm, and it is also causing the action of supination of forearm. So what is the action? So I just want everybody to write one line here. All the muscles of all the muscles of anterior arm that is BBC is innervated by musculocutaneous nerve. Is innervated by which nerve? It is innervated by musculocutaneous nerve. So all the muscles are innervated by anterior aspect of the arm by musculocutaneous nerve. Done with this. And what about the next that coraco? So basically we have done with this. I will come to coracobrachialis muscle. Before that I want to write biceps brachialis muscle action. So let's write the action. So the action is, if I am talking about the action of biceps brachii, the action of biceps brachii is it causes supination. It causes supination of forearm. It causes supination of forearm while the elbow is flexed. While the elbow is flexed. It causes supination of the forearm while the elbow is flexed. It causes flexion. It causes flexion of forearm when the elbow is extended. When the elbow is extended. Done. Now coming to the next muscle, that is coracobrachialis muscle. So see this image. So by seeing this image, you can clearly understand about coracobrachialis muscle. So here what you can appreciate, this is the coracoid process of the scapula, and this is actually the humerus bone. So what you can appreciate in coracobrachialis muscle, that coracobrachialis muscle is originating from the tip of coracoid process along with the short head of biceps brachii, and it is inserting into the middle 1/3 of the medial border of humerus. So it is inserting into which bone? So you can write down here, this bone is the humerus bone. So this is the humerus bone. So it is inserting into the middle 1/3 medial border of the humerus bone. So coracobrachialis muscle, write on origin. The origin is, it originates from coracoid process of the scapula, tip of coracoid process of the scapula, along with short head of biceps brachii, and insertion is on the middle 1/3 of medial border of humerus. Medial border of humerus. Okay. Now action. So let's talk about the action and nerve supply. So nerve supply I am not writing once more. Is it okay? Because nerve supply we have already done. What is the action, dear students? Anyone wants to attempt the action of coracobrachialis muscle? So it helps in which action? Can anyone tell me? Can anyone tell me which action? Yes, we will come to the triceps after completing this. Yes, you are right. It is the long head from infraglenoid tubercle. Paul, you are right. Can anybody tell me the action? It is causing flexion and it is causing, helping in flexion and adduction of arm. So it is helping in flexion and adduction of arm. Now talking about brachialis muscle. The next anterior muscle is the brachialis muscle. So for the brachialis muscle, if I am talking about the brachialis muscle, you have to know that it is originating. It originates from the lower half of anterior surface of lower half anterior surface of humerus bone and brachialis muscle insertion. If I talk about the insertion, it is inserting into the coronoid process. So it is inserting into the anterior surface of coronoid process. It is inserting into anterior surface of coronoid process of ulna, and also also in the ulnar tube, and also it inserts onto the ulnar tuberosity and on the ulnar tuberosity. Now brachialis muscle, if I talk about brachialis muscle, what is most important for you to know, it's a very powerful, it's a very important muscle which is flexing the forearm in all position. So one of the important action of brachialis muscle is brachialis muscle flexes the forearm in all position. Now the next muscle is triceps muscle. So we know that triceps is a muscle which is three-headed. So we know that triceps muscle is three-headed. It is having radial head, it is having long head, and it is having medial or medial head. So basically it is important to know triceps origin and insertion. So origin of long head is from infraglenoid tubercle. I think Paul has given me that answer. And origin of lateral head is from the posterior surface, posterior aspect of the humerus. So and so posterior aspect of the, so origin of medial and lateral head is in from the posterior aspect of the humerus bone. So humerus bone lower part to the radial groove is the medial head originating, and upper part of the radial groove is the lateral head originating and inserting into the olecranon process of ulna. So this is olecranon process of ulna in which it inserts. So please write down the attachments and all. So origin. Origin. So we have got three heads in the triceps. Write down long head of triceps. Long head of triceps originates from infraglenoid tubercle of scapula. Infraglenoid tubercle of the scapula. Long head from the infraglenoid tubercle of the scapula. Lateral head from posterior aspect of humerus above radial groove. medial head, medial head. So medial head originates from posterior surface, from posterior aspect of humerus below radial groove, below the radial groove, below the radial groove. Got it? Now insertion and action. Nerve supply is radial nerve. Write on the action. So insertion of the triceps muscle is on the posterior part of the superior surface of olecranon process, of the superior surface of olecranon process, Now nerve supply, so already known, action and nerve supply. Nerve supply, it is the muscle only on the posterior aspect of arm, so it is getting innervation from radial nerve. All the three heads from the radial nerve. And action is, it is having the action. So the normal, if we talk about the action, triceps brachii muscle is very, very important structures, and it is very importantly, it's a powerful extensor of the elbow joint. So it's a powerful extensor of elbow joint. It's a powerful extensor of elbow joint. So done. Any of the student is having any doubt, please let me know. Now we have just having the forearm muscle. So the next is only the forearm muscle is remaining. So forearm and the muscles of, so let's complete the forearm and the muscles of forearm, muscles in the front of forearm, muscles on the back of forearm, and the muscles of hand. That is only remaining here, the topics. Okay. So front of forearm, if I talk about front of forearm, there are 8 muscles in the front of forearm. How many muscles? There are 8 muscles in the front of forearm. We have got 5 superficial and we have got 3 deeper muscles. Arteries, we have got radial and ulnar artery, and nerves, we have got medial ulnar nerves and also radial nerves. So muscles of the front of forearm. So we have got 8 muscles. So we have got 8 muscles, and we have got one by one I will tell you about each one of it. Then the extensor group of muscles. So yes. So we have got 5 superficial and we have got 3 deep. We have got 5 superficial and we have got 3 deeper muscles. So exactly. So let me see the 5 superficial muscles. So superficial muscles on the front of forearm. When I am talking about the superficial muscle of front of forearm, we have got following muscles. We have got pronator teres, we have got flexor carpi radialis, palmaris longus, flexor carpi ulnaris, and flexor digitorum profundus. To be more specific, these are the 5 muscles, but if you want to be more specific, I just want you to tell that the flexor digitorum superficialis is not in the superficial plane, but it is in the intermediate plane. Flexor digitorum superficialis is lying in the intermediate plane, rest all muscle is in the superficial plane. So once more, we have, so exactly all the flexor group of muscle is originating from medial epicondyle. We have got pronator teres, we have got flexor carpi radialis, flexor palmaris longus, flexor digitorum, and we have got the flexor carpi ulnaris. Actually, in this case, we have got the flexor digitorum superficialis in the intermediate plane. So the muscles of front of forearm, I just want to enlarge it. So here few of the muscle I want you to show. So here we have got the pronator teres muscle. Then we have got the flexor carpi radialis muscle. We have got palmaris longus muscle. And we have got flexor carpi ulnaris muscle. Okay. So this is the pronator teres muscle, flexor carpi radialis, palmaris longus and flexor carpi ulnaris. So you can see these are the 4 superficial muscles. So here in this diagram, in this cadaveric image, what you can see the 4 superficial muscle, 4 superficial flexor muscles of forearm, 4 superficial flexor muscles of forearm. So we have got 4 superficial flexor muscles of the forearm, and here you can see the another diagram in which the muscles of deeper aspect has been shown. So here you can see the 3 deeper muscle which has been shown: pronator quadratus, flexor pollicis longus and flexor digitorum profundus. And one or more image is there which will help you to understand that here what you can see, the flexor digitorum profundus. The flexor digitorum profundus has been shown, and this is only seen when the flexor so you can see this is the flexor digitorum superficialis. So you can see the part of flexor digitorum superficialis is reflected out, and then only you can see the flexor digitorum profundus. That means FDS is in the intermediate plane. So FDS is in the intermediate plane. So you can here see this is the flexor digitorum superficialis, and this is the muscle of the flexor group. This is flexor digitorum profundus. This is the pronator quad. This is PQ for pronator quadratus. This is FD P muscle which has been shown, and this is the cut section of FDS. So only many books has written FDS as the flexor group, but I basically feel that FDS is not in the flexor superficial group of muscle, but it is in the intermediate level. Is it okay, everyone? Okay. Now done with this. Now basically before proceeding to the back muscle, I just want that you should have an idea of these muscles. So quickly, so actually if we talk about these muscles, all muscles is having, so basically muscles, if we talk about all these muscles, so muscles of forearm, flexor group, flexors. So the first one is PT, pronator teres muscle. So if you want to know the origin, so you can tell that origin is, it is originating from both medial epicondyle of the humerus, which is a common origin of all the flexor group, and it is also originating from ulna. It is also originating from the ulnar bone coronoid process. So I will just write superficially details only. Pronator teres, the first muscle, is having 2 origin. One is from the humerus, medial epicondyle, ulnar coronoid process, and insertion. If I talk about insertion of PT, that is pronator teres, it is on the middle 1/3 of radius bone. And what is the action? The action is pronation of forearm. So my dear students, I will not write about the nerve supply because I feel nerve supply is already known to you. I have covered the nerves, and we know that all the flexor forearm muscle is supplied by median nerve except flexor carpi ulnaris and medial half of flexor digitorum profundus. Only medial half of flexor digitorum profundus and that of flexor carpi ulnaris is supplied by ulnar nerve. Rest all muscle is supplied by median nerve. So I am not writing the details. Next is flexor carpi radialis. So flexor carpi radialis is originating from medial epicondyle and inserting onto the base of second and third metacarpal bone. So it is inserting onto the base of second and third metacarpal bone on the anterior aspect. Obviously on the anterior aspect, because these are the muscles which is lying on the anterior aspect of the forearm. And nerve supply is already known, it is actually medial nerve, and if flexor carpi radialis action, if I talk about, it is flexing the wrist. It flexes the wrist. It flexes the wrist, and when it acts along with brachioradialis, when FCR plus brachioradialis acts together, it can cause abduction of wrist. It can cause abduction of wrist. Okay. Next is, so palmaris longus is a degenerating muscle. Palmaris longus is a degenerating muscle. So if I am using the word degenerating muscle, what does it mean? It is actually degenerating. It is merging with the palmar aponeurosis, and it is important for gripping. So it is important for the gripping property, and it is actually inserting into the flexor retinaculum, and it is having a common medial epicondyle as the origin. It is important for making the palmar aponeurosis contracted. Now the other one is the flexor carpi ulnaris. So flexor carpi ulnaris is the muscle which is having again the two heads of origin. Actually flexor carpi ulnaris is having a common origin from the medial epicondyle of the humerus, and it is also originating as an ulnar head. So ulnar head is originating from the olecranon process, and also by the aponeurosis of upper, it was also originating from the aponeurosis and the posterior border of ulna. And where it is inserting, so it is flexor carpi ulnaris, so it will insert, I for insertion, and it will insert into the pisiform bone, it will insert into the pisiform bone, it will insert into the pisohamate bone, it will insert in pisohamate ligament, and the action is flexion of the wrist, and it is also supplied by ulnar nerve, which we have already done. Now here FDS muscle, if I just want to tell you about the attachment of FDS and FDP muscle. So why it is important to understand, can you see here, actually flexor digitorum superficialis and flexor digitorum profundus, very important. So flexor digitorum superficialis, which is having a common origin from medial epicondyle. So just you have to understand, it is originating from common medial epicondyle of the humerus. Also from the it is having origination from the radial bone, that is radius bone from anterior oblique line, and also from the ulnar bone, coronoid process and all. And what you can see, that flexor digitorum profundus is splitting at the middle phalanx. You can see exactly insertion, middle phalanx of the, it is inserting into the middle phalanx. So FDS is inserting into the middle phalanx, and at the proximal phalanx you can see it is splitting, and in between the gap of FDS, the flexor digitorum profundus is traversing, and it is going till the level of distal phalanx. So that is very important for you to understand. I just want you to see this image. So this is a cadaveric image in which you can see this is the splitting of FDS, in between which the, so you can see this is the flexor tendon of FDP muscle going to distal aspect, and this is the FDP muscle which is splitting at the proximal aspect. So that means exactly you can say that FDS tendon is splitting at the middle phalanx, and the FDS and FDP tendon is together, but the FDP will be going towards the distal phalanx, and FDS will be splitting at the middle phalanx. Okay. So I will just rub, you can see this image and you can correlate with the attachment. So I just want to write this. This is an important point. FDS inserts into middle phalanx of the finger of medial four fingers. So actually we have got FPL as a separate muscle for the thumb, FPL. So for medial four fingers, Till the level of middle phalanx, FDS come, and till the level of distal phalanx, the FDP inserts. And FDP inserts into the distal phalanx of medial forefingers. Done. Now, other than that, we have done with this. Other than that, deeper muscle, we have got pronator quadratus, which is actually a quadrangular muscle having the function of pronation of forearm. And it is actually connecting the lower aspect of radius and ulna, and flexor pollicis longus, it is actually going till the level of thumb distal phalanx. And one more point which we have already done, that all the deeper group of muscle, we have got 3 deep flexor group of muscle, and what is the name? The 3 deep flexor muscle has got the name of flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. These 3 muscle is having innervation from anterior interosseous nerve, which is the deep branch of median nerve. Rest all muscle is getting directly innervation from median nerve. Now, muscles of back of forearm. So I would like to explain. Please don't get worried that this much details of the muscle is required for you, but I just want that you should have an idea of the location of these muscles, because if it comes, you will not get worried of identification. The muscles of forearm on the back, we have got 12 muscles in this group. We have got many muscles in this group. So we have got a total of 7 superficial muscles, and we have got 5 deeper muscles. So we have got a total of 12 muscles. So the muscles of back of forearm can be categorized as the superficial group muscle, which is again in the form of lateral and posterior group, and we have got deeper muscles. So when I am talking of the superficial aspect, we have got following muscles. So muscles of back of forearm, in the superficial aspect, we have got brachioradialis, extensor carpi radialis longus and brevis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, and anconius. So actually superficial group of posterior group of muscles are, if we are talking about the superficial posterior group of muscle, all the muscles has been highlighted with different colors, which will help you to understand. So you can clearly see that in the superficial group, we have got following muscles. So we have got brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi radialis, extensor carpi digitorum, extensor digiti minimi, extensor carpi ulnaris, and anconius. So anconius is very small muscle which is lying on the posterior aspect in relation to elbow joint. Now, all the extensor group of muscle is having common origin from lateral epicondyle. Now, in this superficial group of muscle, 3 muscles are called as lateral group, and rest muscle is posterior group. The 3 lateral group muscles are brachioradialis, extensor carpi radialis longus, and extensor carpi radialis brevis. I will write the name. And the 5 deeper muscles. So we have got 5 deeper muscle in this list, and they are supinator, abductor pollicis brevis, extensor pollicis brevis, extensor pollicis longus, and extensor indicis. So total we have got 12 muscles. So I just want you to show the deeper muscle in this group. So here we have got S for supinator muscle, abductor pollicis longus, extensor pollicis brevis, extensor pollicis brevis is there, along with the abductor pollicis longus, and along with the extensor pollicis longus. No, it's just a minute. This is extensor indicis. So we have got index finger. This is extensor indicis. We have got extensor pollicis longus. Done. So these are the muscles which is the deeper group. So here also few images. This is the cadaveric images to help you understand the back muscles. So basically what I told you, that 3 muscles, the extensor, the brachioradialis, this is the brachioradialis muscle. This is ECRL and this is ECRB. So actually these 3 muscles which I have highlighted, here, These three muscles are of lateral group. Other than that, abductor pollicis, extensor pollicis brevis, extensor carpi ulnaris, extensor digitorum and anconius are of posterior group. Muscles of back, other anconius, as you can see, is a small muscle on the posterior aspect of elbow joint. All the deeper muscles are supplied by posterior interosseous nerve. So firstly, just have the name. So extensor group of muscles. So write down extensor forearm muscle. Extensor forearm muscle. So here the superficial group is lying. We have got the superficial group, and in the superficial group, this further subdivision is, one is the lateral group, one is the lateral superficial group of muscle, one is the lateral group, and the other is posterior group muscle. So the lateral group is just 3 in number. They are brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, and in the posterior group we have got again following muscles. So we have got extensor digitorum, we have got extensor digiti minimi, we have got extensor carpi ulnaris, we have got anconius muscle. So actually these are the muscles, these are the 7 muscles. Together we have got 7 superficial muscles. That means posterior group we have got 7 superficial group of muscle, and we have got 5 deeper extensor muscle, and we have got 5 deep extensor muscles. So when I am using the word 5 deep extensor muscle, the muscles are supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, and extensor indicis. So these are 5 muscles. These are 5 deeper muscles. Already shown in this image. Deep layer of muscles, all the 5 muscles of the deeper layer of posterior compartment has been shown. Supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, extensor indicis. Done. Now exactly what is very important for you, I am not telling that you should know the entire aspect, but just the important points. For example, all the extensor group of muscle is originating from the common extensor origin. And what is the common extensor origin, dear students? The common extensor origin is from lateral epicondyle. The common extensor origin is from the lateral epicondyle. So it is originating from the lateral epicondyle. And for example, action is all causing extension. For example, anconius will tenses the elbow joint capsule. Other than that, all will cause supinator will cause supination of forearm. Extensor group of muscle for extensor indicis will cause extension of index finger. Extensor digitorum will cause extension of digit. Extensor pollicis longus will cause extensor of thumb. So by the name only you can know the action. All the extensor group of muscle is supplied by deep branch of radial nerve, that is posterior interosseous nerve, except brachioradialis and that of extensor carpi radialis longus, which is directly getting innervation from radial nerve. This already done. So muscles of hand, the last topic. Just so all the students, this is the last topic. Last topic, muscles of hand, just 15 minutes more, 15 minutes more. So I just want you to explain this. Let me just enlarge. How many muscles are there in the hand? How many? 20 muscles. So let me just help you to understand these 20 muscles. How many? 20 muscles. So 20 muscles. So exactly, just see my hand and you can understand. 20 muscles. So this is thenar region. What is this? This is thenar region, which is having 3 muscles. So we have got abductor pollicis brevis, flexor pollicis brevis, opponens pollicis. These are three thenar muscle. In the hypothenar region also we have got three muscle, abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. So 3, 3, 6. And deeper to this thenar region we have got adductor pollicis. So 7. We have got 4 lumbrical muscle which is arising from the tendon of FDP muscle. So we have got 7 plus 4 is 11. We have got 4 palmar interossei and 4 dorsal interossei. Sometimes the palmar interossei can be 3 in number. So 11 plus 8 is 19 and we have got 1 as the muscle in the superficial fascia, that is panniculus carnosus example, and that muscle is palmaris brevis muscle. So together we have got 20 muscles. So after that I will just show you the images to understand their location and all. Is it okay? So there are 20 muscles in hand. So there are thenar muscles. There is 3 thenar muscles. There are 3 thenar muscles. There are 3 thenar muscles. Abductor pollicis brevis, flexor pollicis brevis, opponens pollicis. There is one adductor pollicis in the thenar region, but it is not a thenar eminensis. Adductor pollicis is the another muscle in the deeper region. We have got 3 hypothenar muscles. So we have got 3 hypothenar muscles. Hypothenar muscles. So in the hypothenar group we have got following muscles. We have got abductor digiti minimi, abductor digiti minimi. We have got flexor digiti minimi. We have got opponens digiti minimi. We have got, so again we have got 4 lumbricals. We have got 4 lumbrical muscles. We have got 4 palmar interossei. We have got 4 dorsal interossei, and we have got 1 superficial muscle, that is palmaris brevis. So this makes a total of how many muscles? This makes a total of 20 muscles. So now here you can see this 3 muscles is grouped as a muscle of thenar eminensis. So these 3 muscles are of group of thenar eminensis. So by the name only it is clear. So all the muscles of thenar eminensis is supplied by medial nerve by the name opponens pollicis, opposition of the thumb. Abductor pollicis, abduction of the thumb. Flexor pollicis, flexion of the thumb. Now seeing the hypothenar muscles, so these 3 muscles are hypothenar muscles. So hypothenar muscle, flexor digiti minimi, abductor digiti minimi and opponens digiti minimi. So these 3 muscles is lying on the medial aspect of the palm below the little finger. Lumbrical muscles, we have got 4 lumbrical muscles. So actually 4 lumbrical, 2 medial and 2 lateral. So I just want you to show this image. So actually this is showing you the lumbrical muscles. So here this is the first, this is the second, this is the third, and this is the fourth. So what I want you to understand in this image is, so the first lumbrical is the unipinnate, the third and fourth lumbricals are bipinnate, so we have got here The third, and so here it is an important point to note down that the third and fourth lumbrical muscle or medial lumbricals which is supplied by ulnar nerve is bipinnate. The first and second lumbrical is unipinnate. So you can just write down first and second lumbricals are unipinnate muscle morphologically, unipinnate muscles. Third and fourth lumbrical muscles are bipinnate muscles morphologically. Now, one of the important, so we have already talked about nerve supply. We know that the lateral lumbricals is supplied by median nerve, the medial lumbricals is supplied by ulnar nerve. I'm not repeating that. Other important point is that about the action. So, action of lumbrical is just opposite the claw hand. This is what? This is claw hand. This is what? This is claw hand. This is the action of lumbricals. So, just make a cobra and this is the action of lumbricals. This is claw hand. So, the lumbrical muscle is causing flexion at metacarpophalangeal joint and extension at interphalangeal joint. So, what is the action of lumbrical? Please write down. Action of lumbrical muscles. So, the action of lumbrical muscle is following. They cause flexion of metacarpophalangeal joint and they cause extension at interphalangeal joint. And when the lumbrical muscles is paralyzed, the patient will have, and when both median nerve and ulnar nerve injured, the patient will have claw hand. The patient will have claw hand, and we know that claw hand is just the opposite of the action of the lumbrical muscle. So here the claw hand will be like this. That will cause extension at metacarpophalangeal joint and flexion at interphalangeal joint. So what will be the claw hand? We have already know what is claw hand. Just opposite the action of lumbrical is the claw hand. It will cause extension at metacarpophalangeal joint and flexion at interphalangeal joint. So this will be the claw hand. Now the another image is showing you the interossei. So this is an image showing dorsal interossei. So we have got 4 dorsal interossei, and you can see that morphologically dorsal interossei are the example of bipinnate muscle. So morphologically it is an example of bipinnate muscle. Example of bipinnate muscles. Palmar interossei, which can be 3 in number at times, and they are an example of unipinnate. They are example of unipinnate muscle. All the interossei muscle is supplied by ulnar nerve. Now, it's important to know the action of these muscles. So, I just want you to show this. So, firstly, I want you to know the action of interossei muscle. So, this is the medial action. This is the axis of the line. So, actually, you can remember this action. So, when I am talking about dorsal interossei muscles, which is bipinnate DI, they are causing abduction of the fingers along the middle finger, and palmar interossei are causing, which is 3 in number or sometimes 4. The palmar interossei is causing adduction of the fingers, and the middle finger is the axis of the movements. Now, I just want how to remember. Mnemonic is action. So, mnemonic is action of interossei muscle. So, pad and dab. How you will remember? You will remember by the mnemonic pad and dab. So, that means palmar interossei cause adduction of fingers. AD for adduction of fingers. And D for dorsal interossei. So, dorsal interossei is causing abduction of the fingers. So, basically what I want you to understand that P for palmar interossei, which is causing adduction of fingers, and D for dorsal interossei, which is causing abduction of fingers. The action of these palmar and dorsal interossei takes place along the middle finger long axis, and actually it is also, these interossei muscle is also assisting the action of lumbrical muscle. And what is the action of lumbrical muscle? It is causing flexion at metacarpophalangeal joint and extension at interphalangeal joint. So these are the action of interossei muscle, and all the interossei muscle is innervated by ulnar nerve. So now adductor pollicis muscle. The next muscle is adductor pollicis muscle. Why I am showing you the adductor pollicis in detail? Because this is a muscle which is lying in the thenar region deeper to thenar eminences. So it is having two heads of origin. When we are talking about adductor pollicis muscle, it is having two heads of origin. So adductor pollicis muscle is having two heads of origin. One is oblique head and the other is, so one is the oblique head and other is the transverse head. So I will write here C for oblique head and we will write T for transverse head. So this is showing you which muscle? Adductor pollicis muscle. So here transverse head originates from, as you can see in the diagram also, transverse head is originating from, transverse is originating from the shaft of third metacarpal, from the shaft of third metacarpal bone, and oblique head originating from the oblique head originates from capitate bone and base of second and third metacarpal bone, base of second and third metacarpal bone. So that is the origin of adductor pollicis muscle, and we have got two heads, as you can see, two heads. We have got transverse and oblique head from the capitate bone and adjoining area of the base of the second and third metacarpal, and we have got a transverse head which is originating from the shaft of third metacarpal, and it is inserting, as you can see in this diagram, it is inserting onto the proximal phalanx. So it is inserting onto the proximal proximal phalanx of the first thumb. So adductor pollicis muscle insertion, it is inserting onto the medial side of the base of proximal phalanx, at the base of the proximal phalanx. Okay, done. Now here we have got the last muscle of this category. We have got the last muscle of the muscles of hand. So muscles of hand, the last category of the muscle which I want you to tell. So please let me know, are the students alive? So last muscle, all of you please concentrate. This is the last muscle of the series of the upper limb. So palmaris brevis muscle. So can anybody tell me the name of the muscle which is lying? Can anybody tell me, those who are live, that palmaris brevis muscle is categorized as the muscle lying in the superficial fascia. Generally the muscle lies in the deep fascia, covered by deep fascia, but it is lying in the superficial fascia. So can anyone tell me that kind of a muscle which is located in superficial fascia is an example of which type of muscle? So that category of muscle is called as panniculus carnosus, because fat, superficial fat is called as panniculus adiposus, and the muscle residing there is called as panniculus carnosus. So palmaris brevis is an example of panniculus carnosus muscle. Palmaris brevis is an example of panniculus carnosus muscle. So exactly which muscle in our body is an example of panniculus carnosus muscle? The muscle which is residing in the superficial fascia. For example, the muscles in the facial region, the platysma, the muscles in the platysma or the neck region, the muscle which is lying in the scrotum, the dartos muscle. So all these muscles are the example of muscle residing in superficial fascia. So they are example of panniculus carnosus muscle. Palmaris brevis muscle is actually arising, it is lying in the skin on the it is lying in the superficial fascia of the medial aspect of the palm, merging with the flexor retinaculum and the palmar aponeurosis, and it is gripping. For example, if I am holding this cup, that when I hold it and when I hold a cup, or when I hold it I forgot to have my tea. So for example, when I am holding this glass. So I'm holding it like this. So at that time, the wrinkling of the medial aspect of the palm, the wrinkling on the skin of the medial aspect of the palm, that wrinkled group of muscles contraction is the action of palmaris brevis muscle. It is helping in gripping the structure. So it is forming the grip of the structure, and palmaris brevis muscle is supplied by ulnar nerve. It is supplied by ulnar nerve. Okay. Now this is a very important point to be known. So this is a so exactly we have got 20 muscles in this category. How many muscles? We have got overall 20 muscles in the in the whole group of the hand. So basically, before ending, I just want to quickly recapitulate all these structures we have finished. So before finishing, so we have finished all the muscles. Is it okay? Now I just want you to give you a quick recapitulation of the important topics we have completed. Okay. Okay. So what all things we have completed? The first important thing is that we have completed the axilla. Then we have described the anterior, posterior, medial, lateral, apex and the base of the axilla, the six-sided pyramidal box. We have then discussed the contents of the axilla. We have also discussed the parts of the axillary artery, how it is continuing with the subclavian artery, the pectoralis minor muscle, the key muscle in the axilla, and dividing it into three parts, the branches of the individual part of the axillary artery. We have also discussed the tributaries of axillary vein and the location of axillary lymph node. We have discussed the clinical aspect of axillary lymph node. We have discussed the subscapular anastomosis. We have discussed the scapular anastomosis. We have discussed the spaces of the scapular region, the quadrangular space, the upper and the lower triangular space. We have discussed the scapular anastomosis, which is taking place between the branches of the first part of subclavian artery and the third part of axillary artery. The scapular anastomosis occurs at two locations, that is the body of scapula and also at the acromial process of the scapula. We have also discussed about the branches of brachial artery and the branches of profunda brachii artery. My dear students, we have also discussed about cubital fossa. We have discussed the content, boundaries, roof and the floor of cubital fossa. We have discussed the anatomical snuff box and we have discussed the structure lying inside the radial artery. We have discussed the structures crossing the roof of anatomical snuff box. We have discussed the floor bones and we have discussed the clinical anatomy related with the scaphoid fracture if there is pain and tenderness in the anatomical snuff box. We have also discussed Flexor retinaculum attachment. The space beneath flexor retinaculum is carpal tunnel, and when the fluid increases in that area, there is compression of median nerve, and that condition is called as carpal tunnel syndrome. We have discussed the extensor retinaculum attachment, and we have discussed the 6 extensor compartment, and we have also discussed the structures passing through the individual extensor compartment. We have discussed all types of palmar spaces. We have discussed the thenar space. We have discussed the mid palmar space. We have discussed the digital pulp space. We have discussed the infection of it, which is called as Fallon and Whitlow, and how we have incised that infection, the line of surgical incision. We have discussed about next, we have discussed brachial plexus in much detail, and we are knowing the branches of brachial plexus from individual components. We have discussed all the nerves, but we have discussed axillary, musculocutaneous, suprascapular, long thoracic nerve, but we have discussed 3 nerves in much more detail. What is that 3 nerves? Medial, ulnar and radial nerve. We have discussed wrist drop. We have discussed the Saturday night palsy. We have discussed pen test. We have discussed Tinel test. We have discussed Fallon test. We have discussed carpal tunnel syndrome. We have discussed Saturday night palsy, crutch palsy. We have discussed foment sign positive. We have discussed clasping test. So many of the things has been discussed. Also, I have completed all the muscles of the upper limb. So we have completed the muscles of pectoral region. We have completed the muscles action nerve supply of the muscles of arm, the anterior and the posterior aspect, the triceps and the BBC muscle. We have also discussed the muscles, 8 muscles on the front of forearm, the 5 superficial and 3 deep. We have discussed 12 muscles of the extensor compartment, 7 superficial and 7 superficial was there, and we have got 5 deeper muscle. We have discussed 20 muscles of the hand. So I think this is enough, and please go and revise all the structures which I have discussed. I want everyone to go through this lower limb and upper limb. It is an elaborate description, and approximately 80 to 90% of the topic has been done, and I feel 90% of the question are coming from these topics only. So just go through it. I have given you is very small breaks also, only so that is okay in explanation, and in the explanation and discussion of all the MCQs of small topics. The time has been taken. All the best and keep studying. Now major part has been done. Only the histology and embryology part is remaining, which I will discuss soon. Is it okay? Any doubt, please let me know. The students, if you have got any doubt, please let me know. Or shall I end the session? Paul, Usama, Dr. Dive, Usama, Dr. Dive, Paul, Bindu. Those who are live, Saf, anyone is having any doubt? Ganesh, Ganesh Solanki. Okay, thank you so much. Thank you so much. So can we end the session now? Please let me know. Okay, so the session is actually, we have completed the entire part, and the most important topics related to the upper limb. Lower limb also I have taken studied. So those who have missed the lower limb session, please go and revise. And previously I have completed the thorax part, the abdomen and the pelvis part, and also completed the head and neck and neuroanatomy. So I just want that you should go and revise all the important structures there. So that will be highly important for you. So if you have got any doubt, you can let me know. Otherwise, I will end the session. Okay, thank you. All the best. Keep studying. All the best. Thank you.